Good morning, sir. Dr. G. Ramanova, sir. Good morning.
Good morning, one and all. We are extremely honored and grateful to welcome you all to the Indian Psychiatric Society, Andhra Pradesh State Branch, Midterm CME for Practitioners 2021. Hope you all have an enriching and a scientific experience. Thank you. We request Dr. Uday Kumar sir, the organizing secretary, to welcome the guests on dais. We request Dr. B. Ramesh Babu sir to join us for the CME.
All right.
We request Dr. N. Raju, sir, the President-elect of Indian Psychiatric Society, as the chief guest to come on the dais. We request Dr. K. Ramakrishnan, sir, President of IPS South Zonal Branch, the guest of honor, to come on the dais.
Good morning, one and all. Thank you.
We request Dr. Ramasubba Reddy, sir, the past president of IPS, as the guest of honor, to come on the dais. We request Dr. Y. Sanjay, sir, the Vice President, who is online, to join us for the CME. We request Dr. P. Lokeshwar Reddy, sir, the Secretary, to come on the dais.
Nice solution.
We request Dr. S.K. Abdul Sahul, sir, the APMC observer, to come on the dais. We request Dr. Sharat Chandra, sir, the treasurer, to come on the dais. We request Dr. A. Vijay Chandra Reddy, sir, the editor, to come on the dais. We request Dr. Vishal Indla, sir, the AP representative of South Zone, to come on the dais. We request Dr. T.P. Sudhakar, sir, the organizing chairman, to come on the dais. We request Dr. T.P. Sudhakar sir, the organizing chairman, to welcome Dr. K. Uday Kumar sir, the organizing secretary, on the dais. We now hand over the proceedings to President Dr. B. Ramesh Babu sir, who is online.
Very good morning to all. First of all, I would like to request you to pardon me, to excuse me for my inability to attend the function physically, as I was done physically in the last 1 week. Otherwise, I was very eager to meet all of you physically. Uh, Today, actually, the Nellore Mine Club, and with the guidance of Dr. T.P. Sudhakar sir and Dr. Uday Kumar, they are doing excellent job. They have planned this conference very meticulously with very, very interesting topics with the renowned speakers. So I wish the conference a grand success. Now, um, now we will go for prayer now.
तुषारहार धवला या शुभ्रवस्त्रान्विता या वीणां वरदण्डमण्डितकरा या श्वेत पद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा पूजिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा
Now we will go for watering of the plant. The organizers, they have done an excellent job because we have to protect our plants. So watering the plants by our chief guest and other dignitaries on the dais. Thank you, sir. Thank you, sir. Now I request Dr. T.P. Sudhakar, sir, the organizing chairman of this event, our beloved teacher and our guiding force and our godfather. I request, sir, to give the welcome address to the audience.
Thank you, Dr. Ramesh Babu, President of Ips Ap chapter. ఎందరో మహానుభావులు అందరికీ నా వందనాలు. It is my proud privilege, though I don't belong to Nellore Mind Club, my friend Uday Kumar and some of my students had given me the honor to be the organizing chairman of this event. And it's not new that myself and the Nellore Mind Club had done so many events in the past also. And they had been so generous with me. Whatever I say, usually they carry out. And actually, they carry out beyond my expectations. So without much talking about that particular aspect, let me all of you welcome to this hybrid meeting of IPS Midterm CME for the practitioners, especially our chief guest today, Dr. N.N. Raju, who is the president-elect, Dr. Inna Ramasubba Reddy Garu, who is our godfather, and of course, Dr. Ramakrishnan, the South Zone president, and the other office bearers. Of course, Dr. Sanjay, I should not forget, even though he is not here. He is the incoming president of IPS South Zone. Dr. Lokeshwar Reddy, who is very close to me. Dr. G. Suresh Kumar, who is the secretary of IPS South Zone. Dr. Sarat Chandra, Dr. Vijay Chandra Reddy, Dr. Vishal, and of course, our MCA observer, Dr. S.K. Abdul Shahul. It's my proud privilege to again welcome you for this event, which is though small, had been made magnanimous. Because looking at the registrations, yesterday Uday was telling it has almost crossed 350. That is a fantastic number for a CME of this sort, that too during the COVID time. And as you all know, and the people who are already here, they have enjoyed the Nellore hospitality. After all, Nellore is my mother's place, and I'm very strongly attached to this town. So I always enjoy being with all my friends here in Nellore. And we have really planned out a fantastic program which involves some of the stalwarts in various fields. And we are concentrating basically on antipsychotic therapy. What exactly are the problems with antipsychotic therapy and the routinely encountered clinical problems, which is going to be very practical for most of the practitioners. My brother, Dr. G. Prasadarao, Dr. Varghese Punnos from Kerala, Dr. M. Suresh from Tamil Nadu, Chennai, and of course, our own president-elect, Dr. N.N. Raju. And then Sunil from Bangalore. And of course, Evergreen Suresh Badamat. They all will be talking about various aspects related to antipsychotic therapy. I hope it would be a real great academic feast for all of you, and hope you would enjoy and bless the conference. And again, I thank my brother, Dr. Uday, and all my people here, especially Ramesh Balaji. Actually, people may not know this meticulous planning is because of him. He does it so meticulously, so fantastic. I always appreciate you, Ramesh Balaji. Thank you very much for giving me this opportunity.
Thanks a lot, sir, for your affectionate and motivating words. Now, I will give a brief message Respected Chief Guest, Dr. N. Garu, President-elect IPS. Guest of honor, Dr. K. Ramakrishnan Garu, a very dynamic President IPS South Zone. Dr. I.R. Reddy, sir, our past President IPS, everybody knows him. And today's organizing chairman, Dr. T.P. Sudhakar, sir, organizing secretary, Dr. Uday Kumar, our APMC observer, Dr. Abdul Sahul Garu, and our South Zone representative to IPS, Dr. Inla Vishal, our office bearers, Dr. Lokesh, Dr. Sarath, Dr. Vijay Chandra Reddy, and all dignitaries on the dais, off the dais, and all these renowned speakers and all the delegates. Very, very good morning to all of you. It gives me very immense pleasure for me to preside over this, the inaugural function of midterm CME for practitioners at Nellore. I'm extremely glad to say that since beginning, I'm getting excellent support and guidance from all of our seniors. And also, I'm getting excellent cooperation from our office bearers and our EC members. And they're leaving no work for me to do. Really, Dr. Lokesh and Dr. Sarath and Dr. Vijay Chandra Reddy, they are doing excellent job. Dr. Vijay Chandra Reddy, he's putting sincere efforts to upgrade our journal. So I request all the delegates, all our members to share your quality scientific articles to him to publish in our journal. This year, for the first time, with the initiative of our past president-elect, past president IPS, Dr. P.K. Dalal sir, we initiated the celebration of IPS Foundation Day on 7th January every year. It is a wonderful opportunity to remember the sacrifices, the works of our dedicated seniors, and also to pass on their experiences to our younger generation. So every year, now we make a custom to celebrate this event on 7th January for about 3 to 4 days, IPS Foundation Day. I'm very glad to say that in this year, 3 of our members, our IPS AP State branch members, they got entered into IPS. First of all, Dr. N. Raju, he got with a very big victory. He got elected as IPS President-elect, as IPS National Body President-elect. And Dr. Inla Vishal, he got with his margin, he got elected as South Zone representative to IPS National Body. And Dr. G. Suresh Kumar, he unanimously got elected as IPS South Zone General Secretary. I am very happy and I congratulate them wholeheartedly. I would like to extend our AP State branch activities by starting 3 subcommittees like Suicide Prevention Committee and Women Empowerment Committee, like Samanvi Committee, AP State branch, and the Task Force Committee for homeless mental sick people. Because these are very, very essential. Suicide Prevention Committee aim should be to bring down the suicide rate 0. Even though with all our efforts, suicides are going on, increasing day by day among students and among farmers and among younger generations. So it's our primary responsibility to put, we have to intensify our efforts. So I think I'm planning to start these subcommittees, and also homeless mentally sick people. We are seeing many mentally sick people wandering on the roads. In my personal experience, when I go for a morning walk or evening walk, when I go for rounds to other nursing homes, I will see some of my patients wandering in the roads. I feel very guilty and ashamed. We are unable to do anything for them. So we have to start this task force for such patients, and we have to put our sincere efforts, whatever can be done from our side. And also Women Empowerment Committee. So many female psychiatrists are there in our association, but they are not participating actively in our executive line. So it is to encourage them to do our executive activity. I think it is better to start Samanvi Committee AP State branch. For all this inspiration, our Southern President, Dr. Ramakrishnan sir, is our inspiration for me. And for coming to today's midterm CME topics, as Dr. T.P. Sudhakar sir said, they selected very interesting, challenging topics. In our day-to-day practice, we will face all these problems. How it is very easy to make the person to bring back from active psychopathology to make him free from active psychopathology. But it is very difficult how to bring him back to the totally medication-free state. So all the patients will ask us from second day onwards. They say, "Sir, how long I have to take these medicines?" It is very difficult question to answer. So, weaning of psychotropic medications and how to manage sexual side effects of the psychotropic medications. It is also a very problematic problem. Actual patients, they won't come out so easily. We have to put leading questions for this side effect, and it is also very difficult to treat. And also these mixed affective disorders. It is a very common problem, but a neglected topic. And it is very difficult to treat such mixed affective states also. Like so many topics are there today with the renowned speakers. So I request all the delegates to participate actively with the active interaction and to pass on your own suggestions and your interactions to make the deliberation very highly impressive. So I wish the event a grand success, and I thank all the organizers for giving me this opportunity, and long live IPS. Thank you. Now, I will ask my Vice President-elect Dr. Y. Sanjay to give his message. Dr. Sanjay, kindly give your message. Sanjay is there?
Sir, he is not there, sir, online.
Okay, sorry. He may be busy. And I request Dr. Lokeshwar Reddy, our General Secretary, to give a secretary report.
Respected President, Dr. Ramesh Babu Garu, our Chief Guest, Dr. Nellore sir, President-elect IPS, our Guest of Honor, Dr. Ramakrishnan sir, President, IPS South Zone, our Guest of Honor, Dr. IRS Reddy Garu, Past President, IPS, our APMC Observer, Dr. Abdul Shahul, other office bearers, other dignitaries on the dais, off the dais, and who have joined us online. Good morning to one and all. I'm very happy to present the Secretary's report. In this year, even during these difficult times of COVID, we could conduct all our activities of our society through online. And even many of our members, they have played a significant role during this tough time by providing both online professional services and also other participation in other philanthropic activities. I would like to congratulate all of them for their contribution during this time. And the other important thing, sir, we have 3 members from our society representing IPS, our President-elect Dr. Nellore sir, and Dr. Vishal Garu, who has been elected as South Zone representative to National. Our General Secretary, Dr. G. Suresh Kumar, IPS South Zonal Branch, who will also be representing South Zone in National EC. And I would like to congratulate them for getting elected. And I congratulate Dr. P.S. Murthy Garu and Dr. R. Kishore Kumar, who have conducted PGCME 2020 at Shantiram Medical College, Nandyal, which was well organized, and more than 300 delegates have participated in that, and it was a grand success.
Okay.
And I would also like to congratulate Dr. T.P. Sudhakar sir and Uday Kumar sir for coming forward to conduct the midterm CME 2021 with an important theme, red flags in psychopharmacology, which will be helpful for our day-to-day practice, and hope we all benefit from their knowledge and wisdom. And an important update regarding our journal, Archives of Mental Health. I congratulate the efforts of our editor, Dr. A. Vijay Chandra Reddy, for getting the journal indexed in DOAJ and Scopus, so which is in par or in line with the NMC's requirements for publications and requirements and for promotion. So I like to thank everyone for giving me this opportunity. Thank you, sir.
Thank you, Dr. Lokeshwar Reddy. I am very happy to have Dr. Lokesh Reddy as General Secretary. He is a very dynamic person and able person. Thank you. Thank you. I request our APMC observer, Dr. S.K. Abdul Sahul Garu, to give his message.
Good morning, everyone. It's I'm trying to talk to you in front of everyone. I'm very happy and pleasure for inviting me from Indian Psychiatry Society and from Mind Club for the Observer. I hope this program goes well. Thank you, everyone.
Thank you, sir, for your wishes. I request our dynamic IPS 1000 President Dr. Ramakrishnan sir to give his message.
Unmute, sir. Unmute, sir.
Sir, you have to unmute, sir.
Yes, I have unmuted audible.
Yes, it's audible, sir. Audible, sir. Yes.
And I am very happy that Uday Kumar and Sudhakar sir has sent a wonderful memento and a shawl to me. And my secretary will put the shawl on me on this occasion. Thank you, one and all, for this wonderful gift from Andhra. Good morning to all of you. Respected and sir and my friend Dr. Raju, the President-elect of IPS South Zone, my mentor Dr. IRS Reddy, Dr. Sudhakar, ever young, always what you call academic and dynamic, Dr. Sudhakar sir, my friend Dr. Uday Kumar, President of the IPS Andhra Pradesh Secretary, Ramesh Babu, Secretary, Dr. Lokesh, and all assembled here, and my IPS EC members, Dr. Suresh Kumar and Dr. Vishal. It's a great privilege to be part of Andhra, because I am also part of Andhra. My native is Andhra. దానివల్ల నాకు దీంట్లో వచ్చి కలుసుకోవాలని నిన్న ఆశ. బట్ కరోనా వల్ల ట్రావెల్ చేసేదానికి కొంచెం హెసిటేషన్ ఉండినాం. ఉదయ్ కుమార్ సార్ చెప్పారు, సార్ డోంట్ రిస్క్ యువర్ సెల్ఫ్, యూ కెన్ కమ్ సమ్ అదర్ టైమ్ అని చెప్పారు. సో ఐ స్టాప్డ్ అట్ మెడ్రాస్. I did cross the border, that's all. But Nellore is not new to me. I visited IPS South Zone conference there. The midterm CME of the IPS South Zone was conducted there. All this I participated. And Dr. Uday Kumar is well known for his hospitality and his kindness. He's soft to all people. So he makes lots of friends. And as president and other people were telling, Andhra this time had a bag of representatives to national IPS, and the key post of IPS also they have won. RTH, congratulations. So this title is also very close to me, psychopharmacology. It is a very, very, very difficult area. Diagnosing the patient is easy, but treating the patient is very difficult. That's what I used to tell. And the combination, the continuum of illness, schizophrenia with the depression, OCD with the depression, all these things make our prescription very difficult. Unless you are very thorough in the pharmacodynamics or pharmacokinetics, drug interactions, you have to keep on reviewing. And previously in MBBS, they used to tell, if you read Hunter, every time you find a point, new point. Like that, I find stars. Every time we read stars, we get a new point. Like that, this CME is going to give you the latest state of the art and speakers like Prasad Rao are talking, and mixture effect state and all, and side effects profile. When to wean the see, there is a very wonderful topic, I think. When to wean antipsychotic. That is the uh, golden dilemma of every psychiatrist. When to stop? Suppose we stop this month. Next month he will come with another episode. Even if we reduce 10 mg, sir, last visit it was good. No, it is not good. People, they don't cheat us. They have real suffering and they tell us. So it is going to be a very difficult one. And huge number of registration. So Dr. Uday Kumar has stopped registration. That is also one good thing about how people are interested in the academic activities. That is another important area. So I wish the function a very grand success, deliberations a grand success, and I wish the organizers to record this and put it in our YouTube. That will be useful for others people. Whoever is Uday Kumar sir, you please record it and send it to me. I will put the recording proceedings in the IPS website. That will be my request. So what I am planning to do is assemble all the academic activities, whatever is happening in our Tamil Nadu, to be in our South Zone, to be put into the IPS YouTube. That is another point I have taken. So best of luck. Sudhakar sir, thank you very much for your leadership. Raju sir, thank you. IRS Reddy sir, he is sort of my mentor and he was the first inspector for our DNB program in 2008. I cannot remember that day, forget that day. So all good things are happening. Let us have a good scientific session. Thank you, sir. Thank you very much for all of you.
థ్యాంక్స్ అలా సార్. థ్యాంక్స్ వెరీ మచ్ ఫర్ ఎక్సలెంట్ మెసేజ్. యాక్చువల్లీ నాకు చాలా సంతోషంగా ఉంది మీరు మా ఆంధ్ర వాళ్ళే అని చెప్పినందుకు. తెలుగులో చాలా బాగా మాట్లాడారు. థ్యాంక్స్ ఎలా సార్. థ్యాంక్ యూ. In my message, I forgot to mention Dr. G. Prasad Rao sir. He came all the way from Telangana to Nellore. He is our past president IPS. I welcome Dr. G. Prasad Rao sir for this occasion. He is also a Telugu man only. So I am very happy to welcome him. So now, Sanjay, can you give a message? I request our Vice President,
Okay.
Dr. Sanjay.
Good morning to all. Dignitaries on the dais and off the dais, Dr. Ips Sudhakar garu, Dr. Nellore Ramasubbareddy garu, Dr. N.N. Raj garu, and executive members, Dr. Lokeshwar Reddy, Dr. Sarath, Dr. Vijay Chandra Reddy, and our beloved CME organizing secretary. Thank you all for giving me this opportunity. It is in a meticulously arranged CME program with very good speakers from different parts of the India with different topics. So I wish all the success to the conference and thank you for giving me this opportunity. Thank you all.
Thank you, Sanjay. I request our beloved sir, Dr. Nellore Ramasubbareddy sir, to release our APS Icon 2021 brochure. This time AP Sagan is going to be held at physical form in Vizag. I request all the members to come to this conference physically and make it a grand success. It will be in the month of July, I think 10th and 11th, I think. I request Dr. Inda Vasubardi sir to mesmerize us with your melodious speech.
Respected President of IPS Ap, Dr. Ramesh Babu, Vice President Dr. Sanjay, General Secretary Lokeshwar, and other office bearers of IPS Ap chapter. ఇవాళ ముఖ్య అతిథి డాక్టర్ రాజు గారు, మన నేషనల్ ప్రెసిడెంట్ ఎలెక్ట్ ఫ్రమ్ అవర్ స్టేట్. డాక్టర్ రామకృష్ణన్ ఫ్రమ్ ట్రిచి. అఫ్ కోర్స్ చాలా మందికి తెలియదు ఆయన తెలుగువాడని, అంటే ఆయన పూర్వీకులు తెలుగు వాళ్ళు. చాలా మంది తమిళ్ పాపులర్ పర్సనాలిటీస్ ఆర్ ఫ్రమ్ ఆంధ్ర ఒరిజినల్లీ, లైక్ కరుణానిధి అండ్ అదర్స్, విజయకాంత్. దేవర్ ఆల్ బేసికల్లీ ఫ్రమ్ తెలుగు స్టేట్స్ ఓన్లీ. చాలా సంతోషం ఆయన తెలుగులో మాట్లాడారు. అలాగే డాక్టర్ ప్రసాదరావు, అవర్ గుడ్ ఫ్రెండ్, who doesn't miss any of our Andhra conferences, even though he migrated to Telangana. ఈరోజు అంటే ప్రాబబ్లీ కోవిడ్ వచ్చిన తర్వాత ఫస్ట్ టైం ఫిజికల్గా రావడం అనేది 1 yearలో దిస్ ఇస్ ద ఫస్ట్ టైం, ఎస్పెషలీ ఫర్ మీ. ట్రావెలింగ్ బియాండ్ విజయవాడ అండ్ కమింగ్ ఇన్ పర్సన్ టు ఏ కాన్ఫరెన్స్, దిస్ ఇస్ ద ఫస్ట్ టైం. దట్ ఈస్ ఓన్లీ బికాస్ ఆఫ్ ఉదయ్ లవ్ అండ్ అఫెక్షన్. అంటే నెల్లూరు వాళ్ళ ప్రేమ ఎలాంటిదంటే ఒకసారి అతుక్కుంటే వదిలిపెట్టడం చాలా కష్టం. అంత గట్టిగా ఎరాల్ రైట్ కంటే చాలా స్ట్రాంగ్, ఆయన వదిలిపెట్టాడు. ఈ సందర్భంగా నేను కాన్ఫరెన్స్ గురించి కాకుండా నెల్లూరు వాళ్ళ గురించి 2 మాటలు చెప్పాలి. ఎందుకంటే వాళ్ళు పెట్టి ఇంత మంచి భోజనము ఇవన్నీ తిన్న తర్వాత ఆ కృతజ్ఞతకు నెల్లూరు వాళ్ళ గురించి 2 మాటలు చెప్పాలి. నెల్లూరు అందరికీ తెలుసు, చాలా ఫేమస్. నెల్లూరు రైస్ అంటే చాలా ఫేమస్. నెల్లూరు చేపల పులుసు అంటే ఇంకా ఫేమస్. నెల్లూరు కాజాలంటే ఇంకా అది ఇప్పుడు నేను ఇప్పుడే చెప్పా, బాబు మాకు 1 కాదు 2, 3 ఎక్స్ట్రా ఇవ్వండి అని చెప్పేసి. అంటే ఆ నెల్లూరు ఫుడ్ మీరు ఎక్కడ పోయినా, బెంగళూరులో మేము డిపిఎం ఎంటీ చేసేటప్పుడు మొట్టమొదటిసారి ఆంధ్ర హోటల్స్ ఎవరే అంటే ఆర్ఆర్ హోటల్, తర్వాత నాగార్జున హోటల్స్, ఇవన్నీ నెల్లూరులోవే. హైదరాబాద్ పోయినా నెల్లూరు మీల్స్ అంటే అంత ఫేమస్. మిలిటరీ హోటల్ అనేవాళ్ళు, నెల్లూరు మిలిటరీ హోటల్ అంటే నాన్ వెజిటేరియన్ హోటల్స్ అని. వాళ్ళ టిఫిన్స్ కూడా ఇప్పుడు మినర్వా గ్రాండ్, ఇవన్నీ ఇప్పుడు జరగబోయేది కూడా మినర్వాలోనే. హైదరాబాద్లో ఉండే మినర్వా, దిస్ ఆర్ ఆల్ బేసికల్లీ ఆఫ్ నెల్లూరు పీపుల్. అంటే నెల్లూరు ఫుడ్కు హాస్పిటాలిటీకి దే ఆర్ సో ఫేమస్. ఇంకా చెప్పాలంటే నెల్లూరు నుంచి చాలా మంది, అంటే నేను ఈ విషయాలు ఎక్కువ మాట్లాడతాను అసలు దానికంటే. బెజవాడ గోపాల్ రెడ్డి, సో మెనీ, హీ వాజ్ అవర్ చీఫ్ మినిస్టర్ ఆఫ్ ఆంధ్ర. కర్నూలు క్యాపిటల్గా ఉన్నప్పుడు ఏసీ సుబ్బారెడ్డి, ఆనం చెంచు సుబ్బారెడ్డి, ఆన్ హీస్ నేమ్ నౌ ద న్యూ గవర్నమెంట్ మెడికల్ కాలేజ్ ఇస్ స్టార్టెడ్. అఫ్ కోర్స్ జీవీకే మీ అందరికీ తెలుసు, బాంబే ఎయిర్పోర్ట్ ఈస్ బై జీవీకే, ఇంటర్నేషనల్ ఎయిర్పోర్ట్ సో మెనీ వాజ్ కన్స్ట్రక్టెడ్ బై జీవీకే. హైదరాబాద్లో ఈ తాజ్, కృష్ణ తాజ్, ఇవన్నీ కూడా వాళ్ళే, సుబ్బరామరెడ్డి, వీళ్ళందరూ కూడా. అంటే నెల్లూరు వాళ్ళు ఎక్కడికి పోయినా, వెంకయ్యనాయుడు ఇంకా నెక్స్ట్ దానికి వస్తున్నా. అంటే వాళ్ళ అఫెక్షన్ ఎట్లాంటిదంటే, ఈ కోవిడ్ స్టార్ట్ అయిన తర్వాత చిన్న ఎగ్జాంపుల్ చెప్తాను. సడన్ గా లాస్ట్ జూన్ ఆ ప్రాంతంలో అనుకుంటా, ఒక రోజు పొద్దున్నే నాకు ఫోన్ వచ్చింది. మీ అందరికీ గతంలో పంచుకున్నాను సోషల్ మీడియాలో. సడన్ నాకు ఫోన్ వచ్చింది, ఉపరాష్ట్రపతి గారు మీతో మాట్లాడతారండి అని వాళ్ళ పిఏ ఫోన్ చేశాడు. నేను ఏమో ఉపరాష్ట్రపతి గారు నాతో మాట్లాడడం అనేది ఐ వాజ్ లిటిల్ సర్ప్రైజ్ అండ్ షాక్డ్. 1 minute లైన్లో ఉండండి, ఆయన లైన్లోకి వచ్చారు. డాక్టర్ గారు బాగున్నారంటే, బాగున్నాను సార్, నమస్కారం అండి. ఏం లేదు, కోవిడ్ వచ్చింది కదా, నాకు ముఖ్యమైన మిత్రులు వాళ్ళను కొంతమంది పలకరిస్తున్నాను, మీరు ఎలా ఉన్నారు, మీ ఫ్యామిలీ ఎలా ఉంది, సేఫ్గా ఉండండి, జాగ్రత్తగా ఉండండి. ఆయన కనీసం 2-3 సార్లు మీట్ అయ్యింటాను అంతకుముందు, ఏదో డిఫరెంట్ అకేషన్స్లో. ఆయన గుర్తుపెట్టుకొని నా నంబర్, ఆయన నంబర్ నా దగ్గర లేదు, నా నంబర్ ఆయన దగ్గర లేదు. మరి ఎలా తీసుకున్నారో ఏమో, అంటే ఉపరాష్ట్రపతి లెవెల్లో ఇట్ ఈస్ నథింగ్ ఫర్ హిమ్. ఆయన ఫోన్ చేసి కనీసం 5 నిమిషాలు మాట్లాడారు. మాట్లాడమే కాకుండా ఆయన నేను కలుసుకున్న 2-3 సందర్భాల ఇన్సిడెంట్స్ గురించి కూడా చెప్పారు. మనం అలా కలుసుకున్నాం, ఆ రోజు ఇలా చెప్పారని చెప్పేసి. ఐ వాజ్ సో ప్లెజెంట్. అంటే నేను చెప్పాను, నెల్లూరు వాళ్ళు ఒక్కసారి ప్రేమ చూపిస్తే వీ కాంట్ ఫర్గెట్. అది నెల్లూరు వాళ్ళ యొక్క గొప్పతనం. ఇంకా నెల్లూరు వాళ్ళ గురించి చెప్పాలంటే చాలా ఫేమస్ పర్సనాలిటీస్ ఉన్నారు. గుంటూరు శేషేంద్ర శర్మ, చాలా మందికి యంగ్స్టర్స్ తెలియకపోవచ్చు. అలాగే సినిమా ఫీల్డ్ చాలా మంది ఉన్నారు. రాజనాల, జానపద సినిమాల్లో విలన్ రాజనాల, ఇక్కడ ఆయనే. వాణిశ్రీ ఈజ్ ఫ్రమ్ దిస్ ప్లేస్. కోదండరామిరెడ్డి, చిరంజీవికి లైఫ్ ఇచ్చిన డైరెక్టర్ కోదండరామిరెడ్డి ఈజ్ ఫ్రమ్ నెల్లూరు. ఇలా ఎంతో మంది ఉన్నారు. ఇంకా లైటర్ వీళ్ళు చెప్పాలంటే సింగీతం శ్రీనివాసరావు గారు, ఫేమస్ పుష్పక విమానం అని ఫస్ట్ మూకీ మూవీ తీశారు తెలుగులో, సింగీతం శ్రీనివాసరావు. రమణారెడ్డి, యా, టాప్ కమెడియన్ ఆఫ్ ఎస్టర్ ఇయర్స్, సన్నగా పొడుగ్గా ఉంటాడు. ఇంకా లైటర్ సైడ్లో చెప్పాలంటే జయమాలిని అండ్ షకీలా. షకీలా మీ అందరికీ తెలుసు, సౌత్ ఇండియన్ ఒక సెక్సీ స్టార్. చాలా మందికి తెలియదు షకీలా ఈజ్ ఫ్రమ్ నెల్లూరు అని. అలాగే జయమాలిని. ఇంకా చెప్పాలంటే దువ్వూరి రామిరెడ్డి. దువ్వూరి రామిరెడ్డి యంగ్స్టర్స్ ఎందుకు చెప్తున్నానంటే ప్రాబ్లీ మన సైకియాట్రిస్టులు చాలా మంది తెలియకపోవచ్చు. ప్రేమ్ నగర్ సినిమా చూసిన వాళ్ళు ద ఫస్ట్ సీన్ లో ఫ్లైట్ లో నాగేశ్వరరావు తాగుతూ ఎయిర్ హోస్టెస్ మీద పడిపోతాడు. పడిపోతుంటే ఆమె పట్టుకుంటుంది. అప్పుడు ఒక పద్యం పాడతాడు, అంతము లేని ఈ భువనమంతా ఒక పురాతన పాంతశాల అంటానే మళ్ళీ అంటాడు పాంతశాల కాదు పానశాల అని. అంటే కవికోకిల రామిరెడ్డి వాజ్ సచ్ ఏ ఫిలసాఫికల్ పోయెట్ ఇన్ దోస్ డేస్. వీళ్ళందరూ కూడా నెల్లూరు వాళ్ళే. మరి నెల్లూరు నీళ్ళు అలాంటివే కానీ, మరి పెన్నా నది మాకు ఉంది కడపలో, కానీ మరి మాకెందుకో ఇంత క్రియేటివిటీ వచ్చినట్లేదు నెల్లూరు వాళ్ళకు ఉన్నంత క్రియేటివిటీ. ప్రాబ్లీ హియర్ ద పెన్నా మర్జెస్ విత్ బే ఆఫ్ బెంగాల్, ది ఫైనల్ టచ్ ఈజ్ హియర్. కాబట్టి అలాగే అన్నిటికంటే మించి ఎన్టీ రామారావు చీఫ్ మినిస్టర్గా ఉన్నప్పుడు చాలా బ్రహ్మాండమైన లెవెల్లో సారా ఉద్యమం వచ్చింది, ప్రొహిబిషన్ చేయాలని. దానికి నాంది ఎక్కడ అంటే దూబగుంట, ఏ స్మాల్ విలేజ్ ఇన్ నెల్లూరు డిస్ట్రిక్ట్. వెంకమ్మ రోసమ్మ ఆమె స్టార్ట్ చేసింది. ఒక ఆర్డినరీ విలేజ్ లేడీ వాళ్ళ ఫ్యామిలీస్లో, మిగతా ఫ్యామిలీస్లో ఆల్కహాలిక్స్ వల్ల ఎంత ఫ్యామిలీస్ దెబ్బతింటున్నాయని ఒక ఉద్యమంగా తీసుకుని ఆమె చేసిన ఉద్యమానికి చెలించిపోయి ఈనాడు పేపర్ కానీ మిగతా వాళ్ళు కానీ ఆఖరి ఎన్టీ రామారావు కూడా దిగిరాక తప్పలా. అప్పుడు మొదటిసారి మన స్టేట్లో ప్రొహిబిషన్ ఇంప్లిమెంట్ అయింది. అంటే నెల్లూరు చరిత్ర ఆ విధంగా చూస్తే ఇట్స్ సచ్ ఎ గ్రేట్ హిస్టరీ ఈజ్ దేర్. ఇంక చెప్పాలంటే మన సైకియాట్రిస్ట్ ఫ్రెండ్ సిఆర్ రెడ్డి, నెల్లూరుకి చెందిన మొట్టమొదటి సైకియాట్రిస్ట్. ఆయన మనం గుర్తు చేసుకోవాలి ఈ సందర్భంగా. దాదాపు 50 ఆయన నిమ్హాన్స్లో డిపిఎం చేసి ఇక్కడ ఫస్ట్ సైకియాట్రిస్ట్ ఆఫ్ దిస్ ఏరియా. అప్పుడు ఈ చుట్టుపక్కల రాయలసీమలో కూడా ఎవరు లేరు. కడప వాళ్ళు, కర్నూలు వాళ్ళు అందరూ ఇక్కడికి వచ్చేవాళ్ళు సైకియాట్రిక్ పేరు. ఐఎమ్ స్పీకింగ్ ఆఫ్ 1965, 75 అండ్ 80 ఆ ప్రాంతంలో. అలాంటి ఘన చరిత్ర నెల్లూరుది. సరే, ఇకపోతే మన ఏపీ సైకియాట్రిక్ వస్తే ఈ బైఫర్కేషన్ అయిన తర్వాత చాలా టర్బులెన్స్, జస్ట్ ఐ విల్ టేక్ అనదర్ 1 or 2 minutes. ఈ టర్బులెన్స్ తర్వాత మనం ఎంతో ఇబ్బందులు ఎదుర్కొన్నాం. అల్టిమేట్లీ మనకంటూ సపరేట్గా ఒక ఏపీ చాప్టర్ అలాగే ఉన్నింది. కానీ మన తెలంగాణ మిత్రులతో విడిపోయి మనం చేసుకున్న తర్వాత ఎన్నో అచీవ్మెంట్స్ చేసుకున్నాం. ఇంకా గొప్ప గొప్ప అచీవ్మెంట్స్. మన తెలుగు సైకియాట్రిస్ట్ ఇప్పుడు ఇవాళ నేషనల్గానే కాకుండా ఇంటర్నేషనల్గా ప్రసాదరావు ఉన్నాడు. ఆయన ఇంటర్నేషనల్గా WPOలో కానీ, ఏషియన్ ఫెడరేషన్లో కానీ, సార్క్లో కానీ అన్ని చోట్ల హీఈస్ వన్ ఆఫ్ ద మోస్ట్ ప్రామినెంట్ పర్సనాలిటీస్. అలాగే మన రాజుగారు, ఎన్ఎన్ రాజు గారు మన పక్కనే ఉన్నారు. ఆయన నేషనల్ ప్రెసిడెంట్ ఎలెక్ట్గా మొన్ననే ఎలెక్ట్ అయ్యారు. అది మనకు చాలా గర్వకారణం. అలాగే ఈసారి జరగబోయే సౌత్ జోన్ ప్రెసిడెంట్ ఎలక్షన్ కూడా మన ఆంధ్ర టర్న్. అది మన తెలుగు వాళ్ళకు రావడం ఇది ఒక మంచి అవకాశం. దీన్ని వీళ్ళంత వరకు యునానిమస్గా చేసుకోవాలని చెప్పేసి నేను ఈ సభాముఖంగా అందరినీ రిక్వెస్ట్ చేస్తున్నాను. ఎందుకంటే చాలాసార్లు యునానిమస్గానే జరిగింది, ఎప్పుడో 1-2 సార్లు తప్ప. కాబట్టి ఈసారి కూడా వీళ్ళంత వరకు పెద్దలందరూ ఆలోచించి దాని వీళ్ళందరికీ ఏకగ్రీవంగా చేసుకుంటే మంచిది అని చెప్పేసి నేను అనుకుంటున్నాను. అందరూ ఆలోచించాలి. అలాగే ఇంకా సౌత్ జోన్ రిప్రజెంటేటివ్స్ ఇద్దరు కూడా, సౌత్ జోన్ రిప్రజెంట్ నేషనల్ IPS ఇద్దరు ఉన్నారు. కానీ ఇద్దరు ఈ 5 రాష్ట్రాల నుంచి ఎవరైనా ఉండొచ్చు. కానీ మన అదృష్టం ఏంటంటే ఈసారి ఇద్దరు సురేష్ కుమార్ అనే విషయాలు బోత్ ఆర్ ఫ్రమ్ ఆంధ్ర. దట్ ఈస్ అనదర్. చాలా మంది గుర్తించకపోయి ఉండొచ్చు. ఇద్దరు సౌత్ జోన్ రిప్రజెంటేటివ్స్ ఆర్ ఫ్రమ్ బేసికలీ ఫ్రమ్ ఆంధ్రప్రదేశ్. కేరళ, తమిళనాడు ఇన్ని స్టేట్స్లో కూడా మన వాళ్ళే ఉండడం అనేది మనకు గర్వకారణం. దేర్ ఆర్ సో మెనీ కమిటీస్. ఈసారి గౌతమ్ సహా ఇచ్చిన కమిటీస్లో చాలా మంది తెలుగు వాళ్ళకి అవకాశం వచ్చింది, ముఖ్యంగా ఆంధ్ర వాళ్ళకి కూడా. సో ఇవన్నీ చెప్పుకుంటూ పోతే మనకు చాలా అచీవ్మెంట్స్ ఉన్నాయి. ఇంకా చెప్పండి, మన జర్నల్ రాత్రే లోకేశ్వరు వీళ్ళందరూ, విజయ్ చంద్ర అంతా చెప్తున్నారు. ఎవడైనా ఎక్స్ట్రీమ్లీ వండర్ఫుల్ జాబ్. ఇండెక్స్డ్ జర్నల్. ఇప్పుడు మనం ఎక్కడో IJPలోనో ఇంకో దాంట్లో పబ్లిష్ చేసానికంటే దీంట్లో పబ్లిష్ చేసుకున్నా మనకు ఫ్యాకల్టీలో ఉన్న వాళ్ళకి ప్రమోషన్స్ కానీ, మనకు రికగ్నిషన్ కానీ అవన్నీ కూడా వీ నీడ్ నాట్ గో టు ఎనీ అదర్ జర్నల్స్. వీ కెన్ పబ్లిష్ ఇన్ అవర్ ఓన్ జర్నల్. అది చాలా మందికి తెలియదు. మన PGస్కి అందరికీ చెప్పమని కోరుతున్నాను, మన కొలీగ్స్ అందరినీ. మన జర్నల్ ఈజ్ నో లెస్ దాన్ IJP ఆర్ ఎనీ అదర్ నేషనల్ లెవెల్ ఆఫ్ సైకియాట్రీ జర్నల్. కాబట్టి మన జర్నల్కే పంపించండి. మన జర్నల్ని ఇంకా రికగ్నైజ్ చేయండి. మన వాళ్ళకు, నాకు చెప్తున్నాడు విజయ్ చంద్ర, మన వాళ్ళకు కనీసం ఒక 30% రిజర్వేషన్ ఉంది. పేపర్లు పంపిస్తే తప్పకుండా అవి పబ్లిష్ అవుతాయి. బెటర్ దాన్ అంటే దేర్ ఆర్ సమ్ ప్రిఫరెన్స్, లోకల్ రిజర్వేషన్ లాగా. అఫ్ కోర్స్ ఇట్ ఈస్ నాట్ ఆన్ పేపర్, బట్ ఇట్ ఈస్ టేకన్ దట్ వే. కాబట్టి పీజీలు అందరిని ఎంకరేజ్ చేసి మన జూనియర్ సైకియాట్రిస్ట్ అందరూ కూడా పేపర్లు కానీ కేసు రిపోర్ట్స్ కానీ ఏదైనా పంపించినా దే ఆర్ రెడీ టు పబ్లిష్ వితౌట్ మచ్ ఇబ్బందులు పెట్టకుండా చేసేదానికి అవకాశం ఉంది. కాబట్టి జర్నల్ కూడా చాలా బ్రహ్మాండంగా దూసుకెళ్తా ఉంది. విజయ్ చంద్ర డూయింగ్ ఏ ఎక్సలెంట్ జాబ్. ఇకపోతే రేపు యాన్సిప్స్, నెక్స్ట్ జనవరిలో యాన్సిప్స్ కూడా మనకే వచ్చింది. దాదాపు 36-37 సంవత్సరాల తర్వాత వైజాగ్లో జరిగింది. మళ్ళీ వైజాగ్లో ఈసారి దాన్ని వెబ్ బేస్డ్గా చేయాలని చేస్తే చాలామంది, ముఖ్యంగా ఎన్ఎన్ రాజు కానీ మహేష్ గౌడ్ అలాంటి వీళ్ళందరూ గట్టిగా పట్టుకొని దాన్ని ఫిజికల్గా చేయాలని చెప్పేసి దాన్ని మళ్ళీ ఫిజికల్గా చేసేదానికి ఎంతో కృషి చేశారు. వాళ్ళందరినీ కూడా ఈ సందర్భంగా అభినందిస్తున్నాను. సో నెక్స్ట్ జనవరి వీఆర్ గోయింగ్ టు మీట్ ఇన్ విశాఖపట్నం. నరసింహారెడ్డి గారు దానికి అప్పుడే ఏర్పాట్లు స్టార్ట్ చేశారు. ఆయన బ్రోచర్ కూడా 2-3 రోజుల్లో ఫస్ట్ బ్రోచర్ పంపిస్తానన్నారు. కాబట్టి అది బ్రహ్మాండంగా జరుగుతుందని చెప్పేసి మనందరం విష్ చేద్దాము. కాబట్టి ఇవన్నీ మన ఆంధ్ర వాళ్ళ అచీవ్మెంట్స్. ఇకపోతే రాజు గారు ప్రెసిడెంట్గా ఎలక్ట్ కావడం, ఆయన ఇంతకుముందు జనరల్ సెక్రటరీ కూడా పనిచేశారు. జనరల్ సెక్రటరీగా పనిచేసి నేషనల్ లెవెల్లో మళ్ళీ ప్రెసిడెంట్ ఎలక్ట్ కావడం అనేది ప్రాబబ్లీ, ఇప్పుడు నేను ప్రసాదరావు మేమంతా ప్రెసిడెంట్ ఎలక్ట్ అయ్యాం, కానీ మేమందరం జనరల్ సెక్రటరీగా పనిచేయాలి. కానీ ఆయనకు అనుభవం ఉంది. 3 years ఈ జనరల్ సెక్రటరీ. ఆ అనుభవంతో హీ విల్ ప్రూవ్ టు బి వన్ ఆఫ్ ద బెస్ట్ ప్రెసిడెంట్స్ ఆఫ్ నేషనల్ ఐపీఎస్. ఐఎమ్ షూర్ ఆయన మంచి పేరు తెచ్చుకుంటారని ఆశిస్తూ ఈరోజు ముఖ్యంగా మరొకసారి ఉదయ్, రమేష్ బాలాజీ, ఈ టీం, నెల్లూరు టీం, చక్రవర్తి, గంగాధర్, దే ఆర్ సో మెనీ పీపుల్, వీళ్ళందరూ కూడా తేజ ఈ ఎంత బాగా చేస్తున్నారంటే నిజంగా అదే చెప్పింది. 1 year తర్వాత మొదటిసారి కరోనా భయం ఉన్నా, ఈవెన్ దో ఆమె సీనియర్ సిటిజన్ అయినా కానీ ఉదయ్ కోసం ఇక్కడికి రావడం జరిగింది. కాబట్టి వీ కాంట్ ఫర్గెట్. ఇంకా అసలు ఉదయ్ ఈ నేను వేసుకున్న షర్ట్ రాత్రి ప్రయాణం చేశాడు ఉదయ్ మా అందరికీ. మీరు ఈ షర్ట్ వేసుకొని రావాలి సార్ అని నైట్ ఈ షర్ట్ నేను తెచ్చిన డ్రెస్ అంతా మార్చుకొని ఈ షర్ట్ వేసుకోవాల్సి వచ్చింది. కాబట్టి అలాంటి చిన్న చిన్న జిమ్మికులు ఆయన చేస్తూ ఉంటాడు. కాబట్టి హీ విల్ షో ఏ స్పెషల్ టచ్ అలాంటిది ఇస్తూ ఉంటాడు. కాబట్టి ఇవాళ పెట్టబోయే నెల్లూరు చేపల పులుసు కోసం ఈగర్గా ఎదురు చూస్తూ నెల్లూరు కాజాలు కూడా తీసుకొని ఈ స్వీట్ అనుభూతులు కూడా తీసుకొని వెళ్తాం విజయవాడకు. కాబట్టి మరొక్కసారి మాకు అవకాశం ఇచ్చినందుకు నెల్లూరు మైండ్ క్లబ్ వారికి, అలాగే ఐపీఎస్ ఏపీ ఎగ్జిక్యూటివ్ కమిటీకి పాల్గొంటున్న మన మిత్రులందరికీ కూడా శుభాకాంక్షలు తెలుపుకుంటూ ఈ మిడ్-టర్మ్ CME విజయవంతంగా సాగాలని చెప్పేసి కోరుకుంటూ సెలవు తీసుకుంటున్నాను. నమస్కారం. థ్యాంక్ యూ.
Thanks, sir. Thank you very much, sir, for your affectionate words and sharing your experiences with Nellore, and also expressing a lot regarding our APS state branch. చాలా బాగా చెప్పారు నెల్లూరు గురించి. నేను 88లో పీజీ చేసేటప్పుడు 88లో ఫస్ట్ టైం నెల్లూరు కాన్ఫరెన్స్కి వెళ్ళాను పీజీ చేసేటప్పుడు. అప్పుడు డాక్టర్ సిఆర్ రెడ్డి సార్ ఆర్గనైజ్ చేశారు. అప్పుడు ఇచ్చిన అతని హాస్పిటాలిటీ ఇప్పటికీ నేను మర్చిపోలేడు. ఆ ఫుడ్ కానీ సైంటిఫిక్ ప్రోగ్రామ్ చాలా బాగా చేశారు నెల్లూరులో డాక్టర్ సిఆర్ రెడ్డి సార్. మీరు బాగా చెప్పారు. థ్యాంక్స్ అలాట్ సార్. థ్యాంక్ యూ వెరీ మచ్. ఐ రిక్వెస్ట్ అవర్ ప్రెసిడెంట్ ఎలక్ట్ ఐపీఎస్ ప్రెసిడెంట్ ఎలక్ట్ డాక్టర్ ఎన్ఎన్ రాజు సార్ టు రిలీజ్ అవర్ జర్నల్. అంటే నేను ఎన్ఎన్ రాజు గారి నుంచి చాలా చెప్పాలా సార్. నాకు సిఐపి అంచెలో నేను సీనియర్ చేసినప్పుడు మా సీనియర్ అతను, నేను ప్రతి సంవత్సరం ఏ కాన్ఫరెన్స్ చేసినా ఏపీ స్టేట్లో నేను అతను యాక్టివ్ పార్టిసిపేట్ చేస్తుంటారు మన ఐపీఎస్ ఏపీ స్టేట్ బ్రాంచ్ లో. సో సిన్స్ ఇయర్ 1993 నుంచి చూస్తున్నాను. ప్రతి సంవత్సరము ప్రతి కాన్ఫరెన్స్ లో అతను ఎగ్జిక్యూటివ్ బోర్డ్ యాక్టివ్ పార్టిసిపేట్ చేస్తుంటారు. సో హీఈస్ వెరీ డెడికేటెడ్ పర్సన్ టు ఐపీఎస్ సొసైటీ. Sir, Dr. Nellore sir, I request you to give a message for all of us.
ఒక్క సెకండ్ ప్రెసిడెంట్ గారు కాదు, సుధాకర్ గారిని ఆయన లేకుండా అసలు నెల్లూరు కాన్ఫరెన్స్ లేదు. ఆయన కేవలం చాలా మంది తిరుపతి అనుకుంటారు. ఆయన తిరుపతి కాదు, మొత్తం ఆంధ్రప్రదేశ్ సైకియాట్రీ అంతా ఆయన శిష్యులే. ఆయన తయారు చేసిన పీజీలు ఎక్కడా లేరు. కాబట్టి నెల్లూరులో కానీ ఎక్కడ జరిగినా సుధాకర్ గారి టచ్ లేకుండా కాన్ఫరెన్స్ జరగదు. ఆయన టచ్ ఉంటే అది సైంటిఫిక్ ప్రోగ్రామ్ కానీ హాస్పిటాలిటీ కానీ అన్ని బ్రహ్మాండంగా జరుగుతాయి. ఈ సందర్భంగా సుధాకర్ పాండిచ్చేరిలో మేమిద్దరం కలిసి పనిచేశాం. ఆ అనుభవాలు ఇప్పటికీ చెప్పుకుంటున్నాను. విశాల్ స్మాల్ కిడ్ అట్ ద టైమ్ 1980. కాబట్టి సుధాకర్ని ఈ సందర్భంగా ప్రత్యేకంగా అభినందిస్తున్నాను. థ్యాంక్ యూ.
థ్యాంక్ యూ సార్. థ్యాంక్ యూ.
President of the morning, Dr. Ramesh Babu, guests of honor, Dr. IRS Reddy Garu, Dr. Ramakrishnan, the guests on the dais, the Dr. Vishal, Dr. Lokeshwar Reddy, Dr. Sharath, Dr. Vijayendra Reddy, the MCI observer today, and the organizing of the and the organizing team, Dr. Sudhakar and Dr. Uday Kumar, all the friends both in front of the dais physically and also online. Indeed, it is. I think at the outset, I thank the organizing committee of IPS AP chapter and also the local organizing committee Mind Club for inviting me as chief guest to this function. డాక్టర్ రామ్ సుబ్బారెడ్డి గారు మాట్లాడిన తర్వాత మాట్లాడటం చాలా కష్టం. ఆయన రూపము, ఆయన గొంతు, ఆయన వివరాలు, ఆయన రసాలతో నింపినటువంటి చక్కెర పలుకులు. సో తర్వాత మాట్లాడాలంటే ఏదో మంచి ఫుడ్ తిన్న తర్వాత ఏదో ఏదో ఇంకేదో తినమంటే కషాయం తాగమనిలా ఉంటుంది మా అందరి మాటలు. కాబట్టి కానీ ఏదో తప్పదు కదా. సో ఐ నీడ్ టు స్పీక్ ఆన్ దిస్ అకేషన్ అండ్ వాట్ ఎవర్ ఐ హ్యావ్ నథింగ్ మోర్. అంటే నిజంగా మాట్లాడటానికి అయితే ఏమీ లేదు. నిజంగా సార్ అన్నీ చెప్పేశారు. ఇక్కడ నెల్లూరు వివరాలు కానీ లేకపోతే ఇప్పుడు జరుగుతున్న సంఘటనలు కానీ కావాలంటే ఏం జరగాలో కూడా చెప్పేశారు. ఎలక్షన్ల గురించి కానీ యాన్సిప్స్ గురించి కానీ ఇంకా ఏమి వదలకుండా అన్నీ చెప్పేశారు. కాబట్టి there is nothing literally for me to speak except that I thank every one of you for elevating me to this post, which is a bit I would say కంప్లీట్లీ నాట్ ఎక్స్పెక్టెడ్. ఏదో కంటెస్ట్ చేద్దామా లేదా అన్న పరిస్థితుల్లో ఇన్ఫాక్ట్ అగైన్ డాక్టర్ రామ్ సుబ్బారెడ్డి గారు, డాక్టర్ సుధాకర్ గారు ఇలాంటి వాళ్ళతో మాట్లాడడం జరిగింది. లేదండి అంతగా సీరియస్గా లేను, ఇంతమంది ఉన్నారు కంటెస్ట్ చేస్తే దెన్ ఇన్ లాస్ట్ మినిట్లో అది విత్డ్రాల్ టైం అయిపోతున్న టైంలో ఐ వాజ్ ఇన్ 2 minds వెదర్ టు కంటిన్యూ కంటెస్ట్ ఆర్ విత్డ్రా. సో లేదు రామ్ సుబ్బారెడ్డి గారు అన్నారు ఎలాగో నామినేషన్ పంపించేసావు కదా క్యారీ ఆన్ చేసిన ఫోన్లు చేయండి, జరుగుతుంది, దానికి ఏముంది, లెట్ us try whatever best we can do అన్న encouraging words really literally pulled me and then whatever little I did. So I thank every one of you for that matter. In fact, I had తేజ ఫోన్ చేసి సార్ మీరు అసలు కంటెస్ట్ చేస్తున్నట్టు తెలియదు అయినా ఓటేసి మీకు ఫోన్ చేస్తున్నానని అన్నాడు. సో ఈవెన్ విజయసారెడ్డి చెప్తున్నాడు అసలు నేను ఎప్పుడు ఓటేయను, నేను ఎప్పుడు పిలిచి ఫోన్ చేసి వాళ్ళని అడగల సో మీరు ఓటు వేయండి అని. కానీ ఆయన నా నెంబర్ కూడా తెలియదు, అయినా సరే వెతికి మొత్తానికి సాధించి మీకు ఓటేసాను సార్ అని. సో ఐ హ్యాడ్ ఆల్మోస్ట్ 30 to 40 messages on the very first day that we have voted for you, whom I never called. That is what the beautiful love and beautiful encouragement you all had given me. Any words of gratitude, any words of thankfulness will not really express my emotions. I think I think this is something I think I should say that Nellore, Dr. Sudhakar have always been quite encouraging. Very few people remember that way back when I was non-entity. Literally, I didn't know what I was. Forget about others knowing me. Sudhakar invited me as a speaker. That was my first experience. Sriharikota ISRO. I myself was surprised that you will be the guest speaker there. I never knew that I could speak at all. No. So anyway, so Prasad Rao says that he was responsible for Sudhakar inviting you. So anyway, both of them are not different. Because Sudhakar does what Prasad Rao says and Prasad Rao does what Sudhakar says. So it doesn't really matter who invited him, but officially it was Dr. Sudhakar who invited me. So obviously I'm giving credit to him. I'm coming back to Prasad Rao anyway a little later. So I thank everyone and especially Dr. Sudhakar for literally putting me on the stage. Later on, I think opportunities have come. I've been speaking on many occasions, and also I have fortunately, I think I have occupied a lot of chairs both at the state level and the zonal level, editor, secretaries, and all those things. So thank you very much for everything. And today, again, my presence here was more out of love of Dr. Uday Kumar and Dr. IRS Reddy Garu. Basically, I was literally not, ready to come here. I thought I will participate only online, but Dr. Uday Kumar had called me, and so IRS Reddy Garu had with his advice and all. So he said, no, sir, you should come here and all participate. So that is how I made it to Ongole. It is not easy, not only as a chief guest, and he clubbed me for giving me a lecture too. It's not very easy to club both academics and politics unless you are Dr. Prasad Rao. So basically, a man, Prasad Rao, I think surprised that even after, I think he must be the most active president after even laying down his office. I think we don't see any presidents. Once the presidentship is over, we don't see them at all. But now you don't see the president, you see Prasad Rao only. That is how his greatness, I think, Nirantar Krushi, ala academics, lectures, rakal topic. That is what I was not jokingly, seriously telling. If we can do what 10% of he does, I think life of us will have a purpose, and we have a lot of things to learn from him. అసలు అంతం లేని తృష్ణ దానికి ఏం తెలుగు పేర్లు పెట్టాలో నాకు తెలియదు కానీ he goes on trying to do something which I think all youngsters should learn from him. I think whenever he comes, talk to him. I think he is a treasure. So most probably we are really lucky to have three really people who encourages others to go ahead, like Dr. IRS Reddy Garu, Dr. Sudhakar, Dr. Prasad Rao. I think Andhra Pradesh is really lucky that we are born in this time to have them, to encourage, to push them through. And it is really happy occasion for me to be here. And we have a lot of things to coming up. All Dr. IRS Reddy Garu already chepparu, the biggest of the events, ANSIPS in Visakhapatnam. So I request every one of you to be there present physically and encourage our committee under the chairmanship of Dr. Narasimha Reddy to do the best what we can do. And also we have APSICON again coming in Vizag. Geetham College is doing it, a new team and new youngsters. So let us all have, again, if possible, as many as we do. And another thing, wherever I go, there is another request. Let us all encourage a lot of people to come into the fold of IPS. I know a lot of them are not members. They are outside the society. Almost, I think I would say around 40% are not members of IPS at all. So somehow we have to encourage, if something has to be done at the central level, that also we have to think about. Most probably the amounts, the membership fees and all could be some deterrents to be the members. We don't know. We will discuss about it. In fact, I was discussing about this even in a recent office bearers meeting also. We should see to it that every psychiatrist in the country be member of the IPS. Somehow we have to find a mechanism to see to it that they are encouraged to commit. Maybe a good academics also could be one of the motivational factors for them to be the members. So bring out good academics, bring out good rewards for their hard work, and I'm sure the CME of today will go a long way in that direction. So once again, I thank every one of you for giving me this opportunity, and also I thank Dr. Ramakrishnan after taking over as South Zone President. I think South Zone has been quite vibrant. I think so. In general, zonal events are always on the low key, but once Dr. Ramakrishnan was the president, I think he is doing some activity or the other. Sir, we thank you very much for making South Zone such a vibrant, and also again I repeat, South Zone has been on the back foot in recent times. So we should encourage our younger generation to be more active both in national politics and also the state and the psychiatric activities. So I'm sure with good support from dynamic support, secretary like Dr. Suresh Kumar and the South Zone representative Dr. Vishal, South Zone should be absolutely a leading force in the nation. So I request every one of you to encourage, support them, make South Zone and also on the AP chapter the best in their own terms to be the best branches. So I once again thank everybody in general and Dr. Uday Kumar, Dr. Sudhakar and Dr. IRS Reddy Garu in particular for making all the efforts, literally bringing me physically to this place. And again, I will enjoy whatever done. And I think I enjoyed getting a good shirt and perhaps we are waiting for Chapel Pulso also. Thank you, everybody. And once again, I thank every one of you. Thank you.
Thank you, sir, for a good message. You covered all the topic, all the aspects of our IPS. I'm observing you since the year 1993 when I joined in IPS. Since that time, you are actively participating in all various levels, as editor, as general secretary, as president in IPS state branch and zonal level. So your services are very much needed for our society. For us. Thank you, sir. Now I request our organizers to felicitate Dr. N.N. Raju.
We are extremely happy and proud to have Dr. N.N. Raju sir with us. He has been selected as the President-elect IPS from our state.
Thank you, sir. Thank you. I request organizers to felicitate our guest of honor, Dr. K. Ramakrishnan, sir, followed by Dr. IRS Reddy, sir. Thank you, sir, for accepting our felicitation. Now, memento presentation.
The mementos will be presented to Dr. B. Ramesh Babu sir, who is present with us online.
I already issued this memento. A few days back itself, I issued this memento. I thank all the organizers for giving me the excellent memento.
The next memento is Dr. Y. Sanjay, who is the Vice President, who is with us online.
Already I received the memento. Thank you very much.
It's Dr. P. Lokeshwar Reddy.
Dr. P. Lokeshwar Reddy, sir, the Secretary. The memento will be presented to Dr. S.K. Abdul Sahul, the APMC observer.
Dr. G. Suresh Kumar. Memento to Dr. G. Suresh Kumar.
Thank you for your memento. I had to receive. I want to physically be present. Somehow, good night.
You will receive this memento soon.
Thank you.
Next, Dr. Sarat Chandra. I. Sarat Chandra.
The next memento is to Dr. A. Vijay Chandra Reddy, the editor.
Dr. Vinda Vishal. Dr. T.P. Sudhakar, sir. Dr. Uday Kumar. Now I requested Dr. Uday Kumar to give vote of thanks.
I would love to be thanking each one of you here. Great warm greetings and welcome all of you to this Term Cme of 2021 from the desk of Organizing Secretary. First of all, I sincerely thank all the EC members of AP State Branch, Dr. Ramesh Babu Garu, the President, for the guiding and continuously supporting and motivating us to do this event, and Dr. Sanjay Garu, the Vice President, for motivating and supporting and friendly gesture towards us to continuously guiding and making us to do this event. Thank you, Sanjay Garu. Dr. Lokesh Reddy, the dynamic secretary of South Zone branch, for making us to do a lot of things. He has done a lot of work towards, like us. He is all along stood with us to do many of the events like Google Forms for registrations, procuring CME credit hours, in making invitations and communicating to all state members and guiding the PG quiz. Thank you, Lokesh Garu. Dr. Vishal here is as a chairman of scientific committee of AP State Branch and AP representative to South Zone and South Zone representative to IPS. Thank you, Vishal Garu, for approving today's scientific event. Thank you, Vishal. Jai Chandra Reddy, the editor of AP State Branch, thanking for bringing the glory to the journal by indexing with Copernicus and Divorcee and bringing hard copies to inaugurate with the chief guest. Thank you, Vijay Chandra Reddy. Dr. Sharath, the treasurer, he kept calling me, sir, do you want the money? Do you want the money? We were in really trouble of funds. He was calling me a couple of times that, sir, do you require money? I'll give you the 1 lakh rupees to conduct the conference. Thank you, Sharath, for being with us. And Abdul Sahil Garu, the MCA observer today, is the renowned orthopedician in Apollo Hospital, Nellore. Though he has a lot of work to do today, he's supposed to conduct the orthopedic camp in one of the villages today. He left that and then he has come to bless this conference. Abdul Sahil Garu, that shows your dynamism and commitment towards these events. Probably you are the best observer of MCA, sir. Thank you for being with us today. I definitely salute my godfather, the organizing chairman of today, Dr. T.B. Sudhakar, sir, for influencing, motivating, inspiring the organizing team to do the best work towards the conference. I think he's definitely holding the cup of Limca Book of Records of conducting many number of conferences as organizing chairman. Sir, you deserve it, sir. I'm really blessed of you being as organizing chairman. Dr. N.N. Rosgaru, the president-elect and the chief guest of today's function. It's really an honor to felicitate you in this platform, sir. You are now a pride of Andhra State Branch. I thank you profusely for you being with us today to bless this conference, sir. Whatever you do in the IPS whole state of Andhra Pradesh, we promise you that we will be with you, to go along with you, to strive for this, to promote the psychiatry. Thank you, sir. Dr. Ramakrishnan, sir, the president of South Zone and the guest of honor today, is the man of service. Though he is very busy in many of those activities, with a short notice, he could accept and be with us to bless this conference. Thank you, Ramakrishnan, sir. Dr. IRS Garu, the well supporter of Nellore Mind Club activities. You are there with us like one of our family members, sir. You always made miracles by being with us. It's definitely a good gesture. I just called him, sir, you are the chief guest today as usual. He just refused. It took a breathing minute that he said no. I got surprised. I was breathless. Why he is refusing to be as a chief guest? No. This time, Dr. N.N. Razu is the apt person to be as a chief guest to bless this conference. That shows your commitment, sir. So you always promote the youngsters, sir. I definitely thank you, sir. We owe you a lot. Thank you. You have left you have brought your son and daughter-in-law to this conference, leaving all demands to the Almighty to support this event. Thank you, sir. Yeah, I have this. I have this. I think the most important people of today is definitely the speakers. We have very renowned speakers today to deliver the best deliberations. We have Dr. Prasad Rao Garu, the past president of IPS, who is as a delegate here and then he is preparing the best lecture. He is definitely will deliver the good lecture. Dr. M. Suresh Kumar Garu from Chennai, Dr. Varghese Punnus from Kerala, and Dr. N.N. Raj Garu is with us today, and Dr. Suresh Badamat from Nimans, and Dr. Sunil Mohan from Nimans. They're all renowned speakers today to deliver the lectures. I didn't speak to them. It's just a WhatsApp message that we have requested that you should be as a speaker for this event, sir. They readily accepted. All of them are. That shows really their commitment towards the psychiatry. thank you all the speakers for being with us today. To conduct all these lectures, we have very, very nice chairpersons. I thank each one of the chairpersons, Dr. Kariram Reddy Garu, Narasimha Reddy Garu, Dr. G.V. Raman Rao, Dr. Kota Suresh Kumar Garu, Dr. Vishal Reddy, Dr. Radhika Reddy, Dr. Bhagya Rao Garu, Dr. Ramesh Babu Garu, Dr. G. Suresh Kumar Garu. Dr. Suresh Kumar supposed to be with us. He couldn't make it. Thank you, Suresh. Dr. Fanibhushan Garu, Dr. Ravishankar Pashan Garu, Dr. G.V.S. Murthy Garu. They're all actually the national South Zone level speakers. I'm sorry, I have kept all these chairpersons as chairpersons instead of keeping them as speakers. Thank you, all the chairpersons. The important and my Mind Club members, sir, definitely I have to thank them because they have made all the important and significant role in conducting this conference. Dr. Ramesh Balaji, from pin to pillar of all the words, he has been with us to push us, pull us, throw us to this into this conference. Thank you, Ramesh Balaji. And Dr. Teja is the person who has brought this event today instead of me bringing all the time that we should have one or the other conferences. But this time, Dr. Teja is the person who has opted this conference. And Dr. Chakravarti, the chairman of the Scientific Organizing Committee. Thank you, Chakravarti Garu, for conducting a whole scientific meet. And Dr. Ranjit Kumar, who is the person who has done the PZ quiz along with his PZ students. And Dr. Subhani has done all the digital works of the conference. Thank you, Subhani, Dr. Ranjit. And Dr. Murali Idhar, the dynamic secretary, and Rahul, the dynamic treasurer. And Dr. Srina, Dr. Padmavati, Dr. Lakshmi Prasanna, Dr. Sesham Garu, Dr. Anand and Rajesh, and Radhakrishnan Razu, Lakshminarayan Reddy, and Dr. Sujita and Bindu Madhuri, and all of my PG students who are here right from the beginning of today. And definitely after this, I think all the delegates are very important to this event. We have fortunately about 370 registrations have been done. This is a surprising amidst of COVID issues. We have a good number of delegates around to log in. I think I request all of the delegates and chairpersons and everybody to be technologically wise to go through this scientific event. Thank you for Sun Pharma and Crescent, Alchem, Suraksha, and Intas, and all the pharmaceutical companies, Cyporemedies, Suraksha, and all, and the hotel people for giving us the congenial place to conduct this conference, and all my PZ students. Thank you, one and all, sir. Thank you, one and all.
Thank you, Uday. Thank you, Uday. Thank you, one and all. And we'll go for national anthem now.
भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
The scientific session will begin immediately. The theme of today is red flags in psychopharmacology. We hope this session will be enriching to everyone who is joining. The first topic for today is identifying and managing mixed affective states. We welcome the chairperson, Dr. G.V. Raman Rao, who is joining us online.
Hello. Thank you.
You are the boss.
Thank you. Thank you very much. I was online. Am I audible to you?
Yes, sir.
You are perfectly audible, Dr. Raman Rao Garu.
Thank you. Thank you, Prasad Rao Garu.
Honored to have you as a chairperson.
Thank you so much, Dr. Prasad Rao Garu. Yeah, shall I introduce? Yeah, one second.
Just one moment, sir.
Yeah.
Dr. G.V. Raman Rao, who is the chairperson, has finished his MBBS from Rangaraya Medical College, Kakinada, and has finished his MD Psychiatry from Andhra Medical College, Visakhapatnam. He worked as an associate professor at GSL Medical College and presently working as an associate professor of psychiatry at Ashram Medical College, Elur, since 2018. He has many academic achievements. He is the International Fellow of American Psychiatric Association from 2014 onwards till date, and his scientific papers were published in the AP Journal of Psychological Medicine and in International Journal of Current Research and Review. He is a resource person and speaker on classification of mental disorders in the PG CME program, which was held at Madurai in Tamil Nadu, and is the president of IPS AP chapter since 95-96. He has also received the Best President of IMA AP State Award at 2006 for 2007.
Thank you. Yeah, it is my pleasure to introduce my colleague and friend, Dr. G. Prasad Rao. Dr. Prasad Rao's versatility is well known to all of us. He is a very busy practitioner for the past 38 years at Hyderabad. Currently, he is the director of schizophrenia and psychopharmacology. Am I audible?
You are. You are, sir.
Thank you. Thank you very much.
We call upon the next chairperson, Dr. Vishal Inlagaru. Sir is present right now with us. Sir is the director of Vimhans Vijayawada, Inla Shantivanam Rehab and De-addiction Center. Sir has many achievements. He is topper of MD exam 2005 gold medalist and best outgoing student. Received the prestigious World Psychiatric Association Young Fellowship Award at Australia. We welcome you, sir. Currently, working as an IPS South Zone representative to National EC 2021 to 24. Worked as past president IPS AP State Chapter 16 to 2017. Principal investigator in many phase 2 and phase 3 clinical trials. Welcome you, sir.
Yeah. So already we are running behind the schedule by 40 minutes. So I would introduce Dr. Prasad Rao briefly. He is a thorough researcher with more than 160 publications, both in the reputed peer-reviewed journals and textbooks. And he is the principal investigator for 60 projects. He is an excellent teacher, exemplified by his presence in almost all state, journal, national, and international conferences. And the number of awards bagged by him is a testimonial for his academic skills. He has got 20 national awards and 6 international awards. His leadership qualities are exemplified by the posts he has occupied. He was the National President, IPS, and the Distinguished Fellow of American Psychiatric Association, and also the Distinguished Fellow of World Psychiatric Association. And he is currently the President and the past President of several subspecialties of psychiatry in India, especially the private psychiatry, geriatric psychiatry, biological psychiatry. You name anything, he will be there. And also he is the President for Asian Federation of Psychiatric Associations, past President, and also a very important person in several international organizations like SARC Association and other things. And apart from that, he is a very complete psychiatrist because he is a thorough researcher, teacher, academician, clinician, and he is a person to be emulated by all the upcoming generations of psychiatrists and PG students. He's a thorough family man, very simple, very hardworking. And my personal association with Dr. Prasad, he was the general secretary when I was the president of IPS AP chapter way back in 95-96. And 20 years later, he nominated me as the convener for the Yoga and Meditation Subcommittee of IPS. And because of my past experience and with the blessings of our NN Rajgaru, the present president-elect, and Dr. Gautam Shah, now I was nominated as the chairperson for the subcommittee on yoga and meditation for this year. And we wanted to plan the International Yoga Day on June 21st, along with the other subcommittees like Spirituality Subcommittee and the American Academy of Yoga and Meditation on 21st of June. I request all of you to participate and cooperate with us. And thank you very much for this opportunity given to me. Now I ask my co-chairperson, Dr. Vishal, to introduce the topic proper. Thank you.
Very good morning to all of you. We can't have a more auspicious and powerful start to today's CME program. The first topic is on managing mixed affective states in bipolar disorder. Many times we think bipolar is just only one, either the manic or hypomanic episode or the depressive episode, but most often, actually literature tells us that to the extent of 40%, each individual who has bipolar at some stage, 40% of them have a mixed affective state, and many times conditions like agitated depression, borderline personality disorder, generalized anxiety disorder, all these conditions can kind of make the picture very, very difficult to diagnose. Conditions like depression, for example, a patient who has prominent depressive symptoms, but at the same time is very assertive, which is not in keeping with the passivity one expects with depression. That's a mixed affective state. Somebody who has a hypomanic or a manic hyperactivity, but at the same time has extreme guilt and sometimes suicidal thoughts, that could also be mixed affective state. So some people refer to this condition as a diagnostic chameleon, and it's wonderful that we have such a senior and wise professor with us in Dr. Prasad Rao sir to give a deliberation on this topic. Now, without much delay, over to Dr. Prasad Rao sir.
Thank you, Professor Vishal. I would consider him as my younger brother, and Raman Rao for those wonderful words. I don't know whether I deserve most of them, but I always deserve to be in Andhra Pradesh Indian Psychiatric Society. And for this, though I think Indra Ramasubbareddy garu chala andanga chepparu. విడిపోవడం బాధ అయినా మనం అంతా ఒకటే అన్నట్టు. నేను మొదలెట్టినప్పుడు ఐ థింక్ నేను వన్ ఆఫ్ దోస్ పర్సన్స్ ఇన్ ఆంధ్రప్రదేశ్ ఇండియన్ సైకాట్రిక్ సొసైటీ స్టేట్ బ్రాంచ్లో దాదాపు అన్ని ఎగ్జిక్యూటివ్ పోస్టులు పనిచేశాను, ఇంక్లూడింగ్ ఎడిటర్. చాలా తక్కువ మంది చేశారు, మేబీ విజయగోపాల్ చేసినట్టున్నాడు, విజయగోపాల్ సెక్రటరీ చేశాడు లేదు తెలియదు. బట్ బియాండ్ దట్ నేను దేశానికి మన భారతీయ మానసిక సమాఖ్యకు అధ్యక్షుడిగా ఎన్నికైనప్పుడు ఆంధ్రప్రదేశ్ నుంచే ఎన్నికయ్యాను. ఆ తర్వాత తెలంగాణ స్టేట్ బ్రాంచ్ చేసినప్పుడు అంటే ఒక రకంగా రెండు రాష్ట్రాలకి నేను రెండు రాష్ట్రాలని రిప్రజెంట్ చేశాను ఒక టైంలో. బట్ మోర్ ఇంపార్టెంట్ దెన్ దట్, ఐ థింక్ ఐఎమ్ హియర్ టుడే థ్యాంక్స్ టు మై ఎల్డర్ బ్రదర్ టిపి సుధాకర్ అండ్ ఉదయ్ కుమార్ and a wonderful lot of people from Nellore, Srinivas Chakravarti, Subhani and Balaji, who is so meticulous. And I am thankful to Ramesh Babu, Y. Sanjay, Lokesh. The way I thought we are going, my topic is the only topic which is not connected to pharmacology, as I see. So let me try to go through this. And before that, I would take just 1 minute. On behalf of World Psychiatric Association, I am organizing the World Psychiatric Association International Conference or the World Conference on Spirituality, Religion and Psychiatry on the December 3rd, 4th, 5th. I request all the members from Indian Psychiatric Society, Andhra Pradesh State Chapter, the youngsters, to be ready with some research, and they come and participate at Hyderabad on 3rd, 4th, 5th of December. I also take this opportunity to thank the scientific committee for giving me this opportunity. I understood bipolar mood disorder much more now, and I'm going to share with you what did I understand. Bipolar mood disorder, to start with, is a conundrum. I would first declare my conflict of interest. I carry my bias as a clinician, as a researcher in psychiatry and in the drug development. I do carry a bias, and as an advisor and as a researcher doing a lot of molecule study, I do carry a bias. But I hope my bias would not be carried in this presentation. Bipolar manic depressive psychosis, major depressive disorder, melancholia, and then the mixed states. It is, as you see in the top of this cartoon, when I was a young student, way back in 81, of psychiatry in Ims, I thought manic depressive psychosis is such a beautifully, easily diagnosable condition. You had a manic episode, you had a depressive episode, and in between, patient usually recovers fully. That's what I started my fundamental basics, of course, from my teachers. And we always prefer to have a manic depressive psychosis when compared to schizophrenia at that time in our patients, of course. But I think in the last 4 decades, the extensive research has led the concept of bipolar disorder itself, some of them, because when we diagnose our patient's diagnosis, and that should be used, and diagnosis utility is basically a construct on which we really work with the patient. And when we ourselves are confused in a clarity of the concepts, the management goes, as Vishal said just now. But today I'm going to unravel some of the mysteries, and I'm going to tell you the story. The lower part of my cartoon is the new emerging concept of a mood disorder, very wonderfully presented by a psychiatrist from Indian origin, Jin Mali. Jin Mali, or also known as Gurvinder Singh Mali, is basically from India right now. He is the president of the society, the International Society of Bipolar Disorder. What he feels is that instead of concepting and concentrating on mood, the 3 important things as shown in this slide is activity, cognition, and emotion. Yes, is going to probably change our concept. And I'm going to delve this small story in a little while from now. The way I wish to cover, naturally, I would like to start with the introduction of history and the concepts, the diagnostic confusions of this syndrome of mixed, and the multiple overlaps as we go upon, covering the epidemiology of mixed states. Some of you might be surprised in the end that do we miss so many patients? Then, of course, finally, concentrating on the evidence today it's available on the treatment approaches of pharmacology, and of course the other methods, and summary. History. I think we should start. Many of us know this, but a lot of us, we don't know this one important concept. In 19th century, in the earlier part of 19th century, the Salpêtrière. The Salpêtrière is probably the best known mental asylums in the world in Paris. There was Julius Ballerger between 1809 to 1890. He, even before our Kraepelin, has formulated this concept of insanity of double form. Now, it consists typically of alternating periods of excitations and depressions. It was presented in the Academy of D Medicine in 1854 by Jean-Pierre Fabre, who is again a student. The Ballerger was a student of Jean Dominic. These are all the first known neuropsychiatrists, if you may, neurologists and come psychiatrists And even Esquirol around the same time did claim to identify a similar kind of a disorder. These are the three important milestones. But to us, I think Emil Kraepelin, he is the one who has clearly delineated, very painstakingly writing the stories of each patient and syndromes. He has delineated manic depressive insanity, what today we call as bipolar disorder maybe, when compared to schizophrenia or dementia praecoxi, the label which he has named. He talked about classical manic symptoms and euphoria in some group, but he is the first time he also talked about depressive symptoms coexisting in mania. This is very an important concept. For the first time, I think the concept of mixed states of what we call today has actually emerged quite long time back by Kraepelin himself. In fact, he has described 6 types of mixed syndromes. The anxious mania type, in which these patients, probably today we call it as a comorbid anxiety disorders with mania. But he has clearly said there is an anxious mania. Then he talked about a manic stupor, in which he said a patient who is in mania actually is in stupor. Then he talked about the third concept of excited depression. Again, remember, he is referring to 2 different syndromes which probably mimic both mania and depression simultaneously. Then mania with a poverty of thought. Remember, poverty of thought has always been a classical sign of schizophrenia. But he is the one who said that in mania, manic depressive insanity, he found some cases who had mania with poverty of thought. And then there is also depression with flight of ideas. Remember, flight of ideas is again a more towards the other pole. But here we are referring to it in the same time, in a same patient, we have these syndromes together. So he has delineated the last but not the least, inhibited mania. You would be totally surprised that in the last 2 decades, whatever more than 100 years back, Emil Kraepelin has alienated, has actually come back into the life. Here is another worker in the bipolar disorder, whom most of you know, Hugops Akiskal, whom I had the pleasure of working with him in a workshop in Armenia. He is the one who gave the almost bipolar half a bipolar disorder, bipolar 1, the classical core bipolar disorder, or 1.5, depression with protracted hypomania. All these concepts, depression with disturbing hypomania or distressing hypomania, depression superimposed with cyclothymia, and depression with induced mania, that is, and tricyclics induced mania. Remember, some of these concepts again fit into what we today talk about the mixed syndrome. In fact, Akiskal, in a conference in 2006, in which only the people who were interested in mood disorder met, and there he talked melancholia beyond DSM. Remember, at that time it was DSM-4. DSM and neurotransmitters was the conference theme. I happened to attend that too. And I picked up these 2 important definitions there. Melancholia is, as defined today, is most closely aligned to depression and mixed phase of bipolar disorder. He made a statement, a melancholia itself, probably we are missing and misdiagnosing. That's what the thrust of his lecture. He gave the 4 important points. 1, this group, melancholia or the bipolar type 2, if you may, and that's what the conundrum obviously is. He has a higher suicidality rate, have a higher successful suicide rate, have mixed states on an average occurs 40% of bipolar disorder. And this is probably the figure which comes repeatedly. in some of the good work on the studying of the bipolar. And most important, he presented during that lecture that antidepressants are grossly misused in this population. And that might be the reason for mixed. That's what his theory was in that conference. But more towards the current period, in 2017, Tavaro Mina, he is another person who worked on the mixed disorder. And if you see this chart, what do you find? You find the Akiskel, some of them, but you also find the Kreplanian sex syndromes, all supervised, all superimposed. So it's like a déjà vu phenomena where we are revisiting what Kraepelin has said 100 years back. And today, I think, for bipolar mixed, some of these syndromes are, and remember, each of our patient is unique and he wants help from us and our own way of diagnosing them based on this, including, for example, on the right side, you find cyclothymic temperament, mixed dysphoria, depression with mixed symptoms, which is rapid cycling, agitated depression. All these words are, in fact, are a kind of, and if you really come, typically, as I started bipolar, when I started 4 decades back, was classically hypomania, mania, and depression. From that, we have actually is a conundrum. And today we actually talk about 2 other complicated words, comorbid psychiatric disorders, where I think we tend to be specifiers, and Akiskel's, as I already said. I would also like to touch upon Jin Mali's article, which is published in Lancet in 2018, about the closing of DSM-5 and ICD concepts. And as you see in this cartoon again, we make a diagnosis based on total number of symptoms present. For example, you have depressed mood, you have anhedonia, you have loss of appetite, but most important again, and this is where I think Jin Mali again comments about that low confidence and the symptoms are, and he comes to that both DSM-5 and ICD-11 might ultimately reach this EAC, that is emotion, activity, and cognition as a core symptoms of mood disorder. Well, we'll discuss about this ACE at a much different lecture, but today's, if you historically you see, till DSM-3, probably it was mixed, was not very well mentioned. DSM-4 is clearly mentioned, but in a very narrow sense. What it mentions, and especially in DSM-4 TR, it mentions that simultaneously you should have both manic and depressive symptoms. And of course, as is the rule of DSM, you should have so many symptoms within the mania or hypomania and so many number of symptoms. Whereas DSM-5 very surprisingly removed the class, but what did they do? So DSM-5 has come with a totally newer concept in terms of mood disorder, what they call specifiers. You start, and in a mood disorder, the illness patterns, for example, a single episode of depression or a recurrent episode of depression. You also specify the severity of it, mild, moderate, and severe. Then you go further on to say totally remitted or fully remitted. Then you also have the onset, early onset, late onset, and there are differentials. Remember, these specifiers come based on the evidence over the last 2 decades. And then this is the last column which focus of our today's lecture. There are this anxious comorbidity, anxious distress comorbidity, or a mixed comorbidity, or a melancholic. All these 6 atypical, all these 6 actually would form the part of today's concept of mixed. More specifically, I think the theme has come with I would focus more on mixed, but all these 6 ones, as you can see here, are part of the mixed syndrome as today's topic. And the literature in the last 5 years has come with a much more clarity, as you can see in this cartoon. This I adopted from one of the authors who has published from our neighbor country, Pakistan, which I'm going to delve a little bit in the next 2 slides, that the concept of episode with mixed features might be a bipolar type 1, type 2, or it can be a major depressive disorder patients whom we often diagnose. And these 3 or more symptoms of depressive symptoms or 2 or 3 symptoms of hypomanic symptoms simultaneously present either in BD1 or BD2, that is bipolar 1 or 2, or in MDD. So we have such a large conundrum to form, and that's what is depicted in this cartoon, which I try to draw from the data. You have on the right extreme the greener ones, the mania or the other side, and towards the extreme left is the pink ones, which is depression, and right in the middle is mixed, because they can have both the spectrum of depressive symptoms or manic symptoms. Probably this is the best. And A. Munir or Atir Munir, this article should be read by all the postgraduates. And I'm going to show you that quotation in the next slide. He has systematically searched all the published articles till 2016 and 17. And this is the published article, which is published in the Canadian Medical Journal. And you can have the reference in this. You can see in the slide. What the mixed states in bipolar disorder. Here, he also deals with the major depressive disorder, the etiology, pathogenesis, and the treatment. And what comes out that almost 500 publications prior to this review are reviewed by this author. And he there comes out with a wonderful criteria for mixed. As you can see, though it's a little complicated table, I would like you to focus on the last part of it, in which they, based on the research, the review, both in the bipolar disorder 1, 2, or major depressive disorder, you need to have at least 3 symptoms of depression and 2 symptoms of mania. That is a summary of the data which is published. So this I adopted from Munir. So nosologically, if you debate broadly, Kraepelin had a much broader syndromes, which he has seen in the patients and described very wonderfully. Then they came an inclusive concept of manic depressive illness over the ICD-8 to ICD-10. And ICD-11 is more close to DSM-5. From 1980 onwards, the first formal approach from DSM-4 on mixed has started, and a separate distinct entity was first made probably in DSM-4 and DSM-4-TR. But by the time when we came to DSM-5, I think even major depressive disorder with the mood symptoms have started in this concept. But the nosological uncertainties are multiple. And if some of the postgraduates are seeing this, the young postgraduates in the first year, you might actually have 1 or 2 thesis topics at the end, because I'm going to present what are the unanswered questions. The tensions are lumping between which lumpers versus separators, that is always there in the mood disorder. The lumpers who are the purists, you might argue, the depressives or major depressive disorder versus the bipolar, that's another lumping and separating part. And then we today consider the bipolar as a large spectrum, so differentiating the purer syndromes to separate. But I think we do have, especially Color's articles, Goodwin and Jamison's article, Balder and Sari's article, and Elday's article, which very systematically studied to differentiate the mixed group and ranging from more or less pure depression to archetypal bipolar. So this is the colorful slide I want to project, that mixed often refers the presence of both depression and mania symptoms, mostly as a single episode in people experiencing the episode of mania or depression simultaneously having the opposite pole, and they should last for a certain period of time. That would be the, and typically there are these rapid cyclers, for example, or a mixed bipolar episodes. Most literature today talks about 2.5% of US population having this. in the famous national catchment area study. But the new DSM-5, and this is probably the summary total in one of the review by Jin Mali for the article, he talks about two important things, that the most widespread criticism is the exclusion of mixed state in DSM-5. It's excluded totally. And as we need to have a lot more interest, that's why they kept it as a specifier. Coming to the epidemiology, it depends on what kind of sample they are taking. It can be a bipolar sample or it can be a major depressive disorder sample. If you use roughly about 40% of all of our patients do have who do qualify for the mixed specifiers at this point of time. Remember, this figure is much higher in some contests, but in DSM-5, if you use it in the much more broader concept, you might have a little higher concept. And this is one slide. I'm sorry, again, this is a little big because I've drawn from one. What you find is right in the end, this is again Munir's article, which has the episode with mixed symptoms. That group definitely is distinctly different from bipolar 1 and bipolar 2 classical depressive episodes or manic episodes. Now, I would go a little bit into the understanding of neurobiology of the mixed states. Most of us know this, that our own depressive syndromes is basically on norepinephrine, serotonin, and dopamine. And we do have symptom clusters which correlate roughly to the neurotransmitters. But there's a little more work which has gone into the understanding of neurobiology, as depicted in this cartoon. In this wonderful cartoon, you find, based on the mixed neurobiology understanding, in a depressive episode, they did find an increased acetylcholine. And in mania, they find an increased dopamine. But in mixed states, they found a mixed of catecholinergic versus cholinergic imbalance. I mean, this is the emerging evidence at this point of time. This needs to be validated. There are only few groups of workers who have tried to understand the neurobiology. So depression is predominantly excess of acetylcholine. I'm talking about the bipolar disorder, depression. I'm again talking about bipolar mania, where predominantly increase of dopamine, whereas the emerging evidence from the neurobiology, whenever they studied together the mixed states, in mixed states, the catecholinergic cholinergic imbalance has been found. And more so, this is probably the area which any youngsters who wants to do a bit of work on biological psychiatry, dysregulation resulting in the different mood states in mixed state can be studied using this. There are a few hypotheses which has emerged. And finally, there are the 6 pathways which everyone would like to study in your research. One is the circadian dysregulation hypothesis for mixed state. Here, it is explained that the sleep-wake schedule clock is disturbed, and it is disturbed in most psychological disorders, but here it is probably the primary cause. The main molecular clock is the suprachiasmatic nucleus. We do have some early evidence of PET scan and MRI images in which hypothalamus and transcription translation circuit is impaired. But we need to be validating this. This is one of the working hypotheses which is going on. There is a third hypothesis which is again based on the clinical data, which talks about the switch process disturbance in bipolar disorder for mixed mechanism. And pharmacological triggers is the one putatively most commonly incriminated. Indiscriminate use of antidepressants is known to cause a mixed syndrome. That's what majority of the authors will talk. And finally, there is the new emerging clock genes in bipolar disorder, which is a wonderful data from GWAS, genome-wide association studies. Large network studies have come up with this wonderful SNP. I'm giving you the list, the number of genome. This is for also incriminated in the seasonal bipolar disorder, but for mixed, this seems to be. So we see also connecting not only the neurobiology, but also to the clock genes in bipolar disorder to the mixed state. So finally, to summarize, we do have distinct syndromes. We also have probably the mixed syndrome, and the etiology needs to be. And to really show a graph, what we have gone is the clock genes are probably responsible for this polymorphism in certain bipolar or major depressive patients, which acts through the ventral tegmental nucleus and dopamine neurons, which further leads to kind of a disturbed activity of thalamus, because thalamus and hypothalamus are responsible for the clocks, and then finally leading to the mixed syndrome. So this is the emerging, but this is mostly a summary of evidence at this point of time, which I picked up at this point of time. Coming to the diagnostic stability, how much does mixed stability, specifier stand? The large data of evidence in the last 2 decades, especially more so in this decade, I would say we have just entered the new decade, but last decade I would say, the tension continues between lumpers versus specifiers. But what has emerged is probably the word spectrum is used for the mixed much more from the archetypal bipolar. But today we have 2 important states. The top one is called unstable mixed states, which talks about either rapid cycling patterns or rapid cycling between inhibitions, agitations. So symptoms cluster within this, they are unstable, or a more stable mixed states, which is the classical. I think this is one area of research. You can take a large group of bipolar disorder and use, there are specific mixed questionnaires, item questionnaires to be given for this, and do a consistency study for 3 months. You might get a larger data on this question. But today, I think this is one area. Unstable mixed state versus stable mixed states is a data, and current state, probably a better delineation of these 2 syndromes is needed at this point of time. The possible outcomes from the large data which is published till this point of time, first conclusion is very often the correct diagnosis reached after 25 years of the illness. You are treating the same patient for 25 years, you label it as either a major depressive disorder or a bipolar disorder 1, or subsequently bipolar disorder 2, or a spectrum disorder, but then in the end, you reach out to a diagnosis, no, it is a mixed state. So we are learning from our mistakes in a way, and a lot of authors like McCombs, Haskell, Banerjee, Tawarema, who worked on this mixed state, comment that mixed state is probably the most common psychiatric diagnosis misdiagnosed. Difficulty in diagnosing most commonly occurred in mixed state. Almost large number of studies comment about this, and clinicians frequently found usage of benzodiazepines excessively in this group. How to differentiate this group is, this group usually they either are misused benzodiazepines according to the authors, and antidepressants, thus increasing dysphoria in this group. Tavaremina, who again has one of the wonderful most recent review published in 2018, talks about this. Whereas DSM-5, the way forward is DSM-5 wanted that this particular area should be studied and studied. In fact, I did talk with the both Rajiv Tandon, Macheri Keshwan, who are in the psychosis group, and the Alan Swan, who was in the bipolar group. When we talked about mixed, why did they keep a specifier not as a syndrome? They said we don't have data to really give us a status. We wanted to keep it as a specifier so that between DSM-5 and probably DSM-6, the data should actually prove to us that there is a state called mixed which needs an independent diagnosis, because both validation of criteria and the neurobiology, and as you know, the newer concept has to emerge. So at this point of time, probably we can still go forward with the unstable mixed and stable mixed depending on the way you diagnose. And then I'll come in the last part of my presentation what is the evidence for the pharmacological management of bipolar mixed states. The pharmacological treatment strategies are there, a lot of data is there. Thankfully, because US FDA wanted all the drugs to include mixed state, and the evidence and guiding forces I'm going to present. If you take the treatment of mixed state, very little data of psychosocial therapies are available for the mixed state. But there are some articles. Antidepressants are totally ineffective in bipolar mixed state. That is the emerging data. Atypicals are effective, valuable, singly or in combination with the mood stabilizers. ECT is probably the best effective in refractory cases. And then you also have a large data which mood stabilizers being used, lithium, and the anticonvulsant mood stabilizers. I'll come to the one after other from this data. Among the atypicals, risperidone does not have any randomized trials for mixed state, but there are a few open label studies which has shown that the data in a 2-week study and a 6 months, 3-month study, especially the long-acting risperidone injectable 25 and 50 milligrams was supposed to prevent the rapid cycling. This is one study which needs to be replicated further. Olanzapine probably has the largest data among the atypicals, along with the other two, lorazepam and the newer emerging molecules. 3 RCTs were done where mixed states were studied, and at the end point of both 3 weeks and 3 months, I think it is the take-home message is patients with mixed symptoms, efficacy with olanzapine, especially for the depressive symptoms, is much better. So this is one take-home message. Quetiapine probably has the one wonderful 2-year study, both as alone and along with divalproex sodium. And it does show as a post-hoc analysis that it prevents the mixed symptoms. So this is one molecule, quetiapine, probably less used. The dosage recommended is 300 milligrams and 600 milligrams because both the trials had 2 groups, one 300 and one 600. Not much difference between 300 and 600 milligrams. Then we have, but remember this is in addition to mood stabilizer. Asenapine is one molecule which seems to have large data, but probably least used by psychiatrists, probably because of the sublingual route of administration. This has data clearly for the mixed symptoms. Aripiprazole is another molecule in controlled studies. We have 2 double-blind controlled studies. The efficacy for the mixed states, this is one molecule which has, the dosage is between 5 to 15 milligrams. And there are aripiprazole alone and aripiprazole along with the mood stabilizers. So this is also has a better tolerability, as most of you know. Lithium, probably the contemporary perspective dictates that lithium should not be very effective in mixed state. Though there was not much data, this is based on the opinion of certain feelings. We don't really have large data. That's why this is percolation from the experts. Divalproex is another molecule which seems to have a larger data because there seems to be definitely multiple studies which have shown. Lamotrigine is a negative data. Negative data means there were at least 5 controlled trials, lack of proof of effectiveness in acute mania and mixed symptoms. So lamotrigine is definitely no for mixed state. And even for recurrent depression, the data seems to be 2 are positive and 3 are negative. So lamotrigine probably we can exclude further. The best evidence is obviously for ECT in mixed state, because on this there are at least 3 important studies which published, and the positive, especially treatment resistance, 2/3 of the cases have recovered, and majority had some catatonic symptoms. So ECT is one of the effective treatment which can be used. And coming finally to the course of illness, one slide which would tell the lot of data. If you summarize, these cases tend to have multiple repeated episodes with poor symptoms and poor functional recovery. That is the rule, especially with the mixed. They often have comorbid anxiety disorders, substance use disorders, and maybe axis 2 together. And refractoriness is probably the rule with this lot of psychopharmacological agents. Episodes with psychotic symptoms do occur much more common with the presence of subsyndromes which we miss out. And rapid cycling is more common. The one which I put in red line is probably universal in almost all this data. Suicide attempts are more frequent with people with bipolar mixed, and as a group, these people have high lethality and high number of successful suicide rates. So the course is probably bad, especially misuse of benzodiazepines and antidepressants. And so existence of a mixed symptoms, we need to be much more careful. Sadly, there is hardly any data on the psychosocial therapies. Cognitive therapies or mindful behavior therapies there's not the illness trajectory overall. If you have a mixed, and I told you 40% of our data of bipolar by this great workers has clearly shown to have mixed syndrome, or they qualify for mixed on the DSM-5 or DSM-4 TR, they qualify. So this is the summary of all the molecules which I tried to show you. Take home message is probably quetiapine, lorazepam, and divalproex seems to have a much edge along with aripiprazole, but we need to have large more data for that. Psychosocial, I would end saying the evidence is very meager, mostly few case reports, few papers, too small a sample to comment at this point of time. But I think this is one more area which our young researchers who are doing the psychiatry can do it on. So treatment of mixed states to end. Antidepressants are ineffective, should not be used. Atypicals are effective, especially used carefully or in combination with the mood stabilizers. ECT should always be used in refractory case. And finally, mood stabilizers are used. Then what is going to be the future? I think these are the 4 or 5 areas which I thought I would pick up from the data. We need to really establish a dimensional view, which is the DSM-5's view at this point of time, is most parsimonious clinical model to understand the specificity. And we need to study from this perspective and try to establish the syndrome once again, using a large cohort of either a bipolar or a major depressive disorder. The relation of mixed in context of bipolar versus unipolar needs to be established. This is one more research question for the youngsters. Research in the cognitive deficits in pure mixed versus pure bipolar or a pure major depressive disorder. The differences or non-differences can be studied. Clinical course of mixed and bipolar, not to talk much about the biological psychiatry. A lot of questions on biological psychiatric can be tested in this hypothesis. And finally, clinical course of mixed versus bipolar versus comorbid disorders need to be studied. And better understanding, for example, comorbid alcoholism and substance use. Better understanding of neurobiology of mixed needs to further improve, thankfully, for the neuroimaging studies. So there is large area. And finally, treatment response need to be studied in more naturalistic designs. Ladies and gentlemen, I thought I took you through the conundrum a little bit. Like this picture, you have a lot of colors. You don't know where to focus. So in our own cases, when individually they come, we probably would like to see the dominant symptoms in the mood. We might miss the other pole within our symptoms. I think the message is mixed syndrome is a specifier of any mood symptoms, be it major depressive disorder or be it any of the bipolar spectrum, but we are missing, and this probably needs large area of interest to probe and get much more data. Thank you, for the patient listening. Thank you, chairpersons, for the opportunity, and thank you, Indian Psychiatric Society, Andhra Pradesh State Branch, for this.
Thank you, Dr. Prasad Rao Garu. Excellent review of the literature with own with your own personal contacts with the thought leaders of the field, and you have made us very familiar with the mixed affective states and updated, and also you gave the future direction for the researchers, for the postgraduates, and everybody. Now this topic is open for discussion. Any questions from the floor? Because there are no questions in the chat box.
Yes, there are a few questions that I can see. So, sir, I'll put these questions across to you. One question is by Dr. Sanjay from Karimnagar. He referred to one of your points about depression being related to ACH, that is acetylcholine increases. So, can we use cholinesterase inhibitors for treating depression?
There is one interesting paper done by the Japanese workers who tried to use donepezil alone, but that data was negative study. Sanjay, I think you asked a very interesting question. That's a research question actually at this point of time. But this, when we have the knowledge that acetylcholine is imbalanced, I think our approach should be is to look for the pharmacological targets. Remember, in a chain of events of a neurotransmitters, acetylcholine was picked up in that particular parameters along with others. But I think this is a good research question can be answered. At this point of time, the data, there is one more study on memantine. You remember memantine NMDA receptors versus acetylcholine, there is an axis. Memantine did have a positive response. So that way to answer at this point of time, can we use alone? I think the straight answer is no, but it's a good research question at this point of time.
Another question by senior psychiatrist Dr. Nagareddy Garu from Kurnool. Is mixed affective state like a NOS category for psychosis, especially with the DSM-5 guidelines? Will it turn out to be like another NOS category?
Absolutely not. Dr. Nagareddy Garu, you are a senior psychiatrist. We psychiatrists, when we diagnose basically on the symptoms and the course of the illness. But we also carry certain bias for ourselves. What the literature at this point of time says is that in 40% of your bipolar, so-called bipolar, or major depressive disorder, or even more if you really look more specifically, you are missing the diagnosis of a mixed symptom. It is definitely not NOS. How to go? There was one slide in my presentation which I talked about the differences between bipolar 1, 2 and mixed in terms of clinical symptoms. This group of patients who had mixed had uniformly bad prognosis, had higher suicidality, had higher antidepressant and benzodiazepine abuse, and that's the literature today. Probably the caution here is that it's definitely not an OS category. It is, if you tend to look, spend a little more time using a little simple questionnaire. There is a 15-item questionnaire, and because today we tend to have an objective scales for most of this, we might pick up this. 40 to 45% is a figure which is in at least 15 studies, good studies, which we are missing out this mixed syndrome.
There are a lot of congratulatory messages on the wonderful presentation, apart from the questions that I can see, sir. And there are a couple of questions from our President, Dr. Ramesh Babu Garu. One of them is about the role of cariprazine in mixed affective states, and the other one is on lithium, especially considering that you mentioned there is a higher suicidal risk in mixed affective states. Is lithium a good choice?
As I said, there is no real double-blind trials about lithium. I'll start with lithium. There's no real double-blind trials. The Bowden study had very few mixed patients diagnosed using special criteria, so we don't have an answer. The conventional guidelines are based on opinions, based on not having evidence. So, and lithium is more effective in bipolar disorder, classical, whereas divalproate is more superior. For that also, we don't really have large data. Bowden studies, the Embolden studies did show some bit of data. So lithium is not the drug to be chosen if it's a clear-cut mixed syndromes, if it is present. Now coming to cariprazine, cariprazine is one molecule and brexpiprazole is another molecule which does have data on the mixed symptoms. But as I said, they are just the emerging molecules in the last 5 years. Cariprazine was approved in 2016 and brexpiprazole in 2017. So the data for mixed as a group is not really so robust at this point of time. But both cariprazine, brexpiprazole and lurasidone seems to have some bit of efficacy in the mixed syndromes at this point of time.
There are three more questions. I think we are running short of time. We'll just take these three questions briefly and then stop. There's one question from Dr. Rajesh, Hyderabad, on RTMS role in mixed affective state.
We don't have data, so maybe I think that's the easiest answer.
And then one question from Dr. Bharti from Trichy, a very interesting question on, you mentioned about anxiety states being quite prominent in mixed affective states, and you also mentioned antidepressants are a little risky in mixed affective states. So how do we manage anxiety with mixed affective states?
I think the simple answer is this particular group, anxious predominant depressives or bipolar disorder with anxious, originally even talked by Kraepelin as a clinical syndrome, needs to be studied much more detail. For this group, behavior therapies data is there. That's what I talked. There are few number of cases, 10 cases which has been worked. I think the strategies is for like in psychiatry, for each patient, we need to be uniquely person-centered therapies. Bharati, I don't think I have an answer, but I'm raising a lot of questions based on the research data. One of the things which I would think is using divalproate and the newer atypicals might be an answer. Lorazepam at a lowest dose, 20 milligrams to 40 milligrams was found to be effective.
Sir, we have a question from the floor. We will also take questions from the floor.
Sir,
Yes, sir.
from the organizing committee, I am Dr. Chakravarti from Nellore. How can we differentiate between an insightful manics and a mixed affective state? And three parts are there, sir. Second one is, you are telling there is no role of lamotrigine according to this studies. So it's all negative studies. But what about the pregnancy with the mixed affective state? I think lamotrigine is a wonderful drug during pregnancy, according to my experience. And third one is olanzapine and fluoxetine combination. You told antidepressants are ineffective, atypicals are better. So just your comments, sir.
I think all the three are wonderful questions. I can take a lot of time, but I would like to be very restrictive. Regarding olanzapine fluoxetine combination, that is effective in bipolar depressive, but not with the mixed state. We don't have clear data. See, whatever data I published is basically on the mixed population. So you are right, olanzapine fluoxetine. That's why I mentioned olanzapine there, but we don't have data. The second question on lamotrigine. I said lamotrigine is not efficacious for mania. It is not even efficacious for prevention of depression. It is only efficacious for treatment of a depressive episode. At this point of time, I know, I'm coming to that. GSK has hit five negative studies which came out later. That's a side story. Calabrese was the author for that. And now they are published. Now we have more negative studies than the positive studies. We have to present the evidence see the evidence as evidence. Coming to pregnancy, even lamotrigine, for your sake and for the sake of the large population, is not safe for pregnancy. It is as risky, and the risk of having higher, see, this is relatively kind of a thing. The current molecules, among the current molecules, including brevacetine or levetiracetam, are not safe for pregnancy. So if you are looking for a safety for pregnancy, that's a totally different issue altogether. I would prefer olanzapine when compared to others at this point of time. But that's where it is. Coming to your first question, is far more tricky. I think we'll talk it over the coffee and tea.
So one last question. I am sorry, some of the questions cannot be taken because of paucity of time. But one last question, sir, on the role
Vishal, I would only suggest that I will answer them and send them back to you. We'll send them through the mail or something.
So sir is gracious enough to take the questions and send them via email to you. So some of the questions we will pass it on to sir for responses to you. But sir, one final question on the role of the new molecule endoxifen in bipolar in general and mixed affective states in particular.
Endoxifen, I have been one of the, I'm just the lead.
This is from Dr. Vasan Kakinad.
Dr. Vasan. I'm just the lead investigator. If you're interested, I will involve you in this study too. Endoxifen has data only for acute mania and a short-term follow of mania. Doesn't have for other syndrome at this point of time. So I think I'm afraid we cannot have any straight answer for you for mixed state at least. But endoxifen as a molecule, right now I have about 20 patients who are received. Beautiful molecule in terms of side effects at this point of time. Efficacy wise, just we should wait for launch.
Thank you, sir, for taking all the questions and giving us such crisp answers. The most important bottom line and take home message is not to miss mixed affective states, and that it's much more common than what we generally think. Sir, over to you, Dr. Raman Rao Garu, for your closing remarks of the session.
Yeah, thank you, Dr. Prasad Rao Garu. You have done extremely well, answered all the questions, and you are available online and offline also to answer the remaining questions. And to summarize this very important topic, current topic, which is missed in the regular clinical practice by most of us, the mixed affective states, they have a chronic course, early onset, relatively not so good prognosis with its relentless course of illness. And it is complicated by the substance abuse, I think, which we need to emphasize in this particular topic. I think we didn't get some time about it. And also the perinatal as well as the childhood developmental phases where it is very crucial for its onset. And also regarding the treatment, second generation antipsychotics are they are the preferred drugs of choice along with the mood stabilizers, particularly valproate. However, lithium remains the choice in those with suicidal risk, and the ECT is reported to be the treatment of choice in the several severe cases, especially when given early in the course. And the psychotherapies have a definite place in a broader perspective rather than a narrow symptom relief. Overall, mixed affective states are still enigmatic and remains to be a Pandora box for psychiatrists. And I thank Dr. T.P. Sudhakar, Dr. Uday Kumar, and all other members of the organizing committee and the executive committee and everybody. Thank you very much. And with this, we'll close the session. Thank you.
Thank you.
Thank you very much, sir. Now we request Dr. N.N. Raju, sir, President IPS elect, to present the memento to Dr. G.V. Prasad Rao, sir, and Dr. Vishal Indla, sir. G.V. Ramana Rao, sir, is present online, and sir has the memento with him.
Yeah, thank you. Subhash Rao, sir, room lo. Yeah. And I have this memento. So thank you very much.
Dr. G.V. Ramana Rao, sir, is present online, and sir has the memento with him.
Yeah, Dr. Subhash is going to hand it out to me.
Thank you so much.
Yeah, thank you. Thank you very much. Okay.
I request Dr. IRS Garu, please be on the stage to appreciate your son, sir.
Moving on to the second topic for today, psychotropic medications and medical comorbidities. I invite Dr. D. Panibhushan sir and Dr. V. Radhika Reddy ma'am to preside over the session as chairpersons. Dr. Panibhushan has completed his MD from NIMHANS and is working presently as the professor and HOD of Department of Psychiatry at NRI Medical College, Guntur. He is also the consultant psychiatrist at Amravati Hospital in Guntur. He was the former superintendent at GGH Guntur and retired as the head and professor of psychiatry department at Guntur Medical College. He has attended and participated in many international and national conferences as speaker and chairperson.
Yeah, good morning to each and everyone. Now the second topic is there. I share the dais to all the virtual with Dr. Radhika Reddy, Professor of Psychiatry from Siddhartha Medical College, Vijayawada. And as you are aware, the topic is the prescription of psychotropic medication for the complex medically ill patients. And I had a small interaction with the speaker of this topic, Dr. Varghese Purnos. He would like to highlight on the issues of prescription practices, particularly persons with medical illness like say heart disease, renal impairment, hepatic impairment, and COVID, the latest add, and many more medical conditions including cancer. So, you know, it's not a easy thing to practice, particularly for consultation liaison psychiatrists who work in general hospital psychiatry and in private practice. They often come across with many patients with complex medical comorbidities and psychiatric comorbidities also. And this is the cornerstone of the practice of psychosomatic medicine. And Dr. Purnos, hailing from Kottayam Medical College, he is an expert in general hospital psychiatry, and he would like to share his views on how to go about the various issues related to psychotropic medication, whether to make a treatment diagnosis decision at all, or if at all you want to give a treatment, whether you want to go for psychotropic medication, or what will happen to drug-disease interactions, and what will happen to the drug-drug interactions. So we are going to have a very comprehensive review of the topic by Dr. Varghese Purnos. And may I request my co-chairperson, Dr. Radhika Reddy, to introduce Dr. Varghese Purnos to the audience. Over to Dr. Radhika Reddy.
We welcome Dr. Radhika Reddy, ma'am. Ma'am has done her MBBS, MD Psychiatry from SVNC Tirupati. Presently working as a professor and HOD of Psychiatric in Siddhartha Medical College, Vijayawada. Working as a consultant psychiatrist at Pooja Psychiatric Center, Vijayawada. President IPS Vijayawada chapter since 2018. Chairman of Women Empowerment Committee IPS South Zone 20 to 21. Ma'am has many achievements, included are the international member APA since 2004, WPA member since 2009, past secretary AP, IPS Vijayawada chapter 2006 to 2009, forum advisor in Bharat Mahila Mandal Vijayawada, participated in several awareness programs in print and electronic media. We welcome you, ma'am. Thank you.
Thank you very much for the nice introduction. First of all, let me thank the organizing committee for giving me this opportunity, and also for choosing an excellent topic in relation to the psychotropics in the day-to-day practice, all together in other comorbid conditions also. And speaker, as usual, will do the justice for this topic, and also he may clear many doubts of our practitioners, psychiatric practitioners, rather than the better for the students. So Dr. Varghese Purnos, he did his MBBS from Government Medical College, Kottayam, Kerala, and he is also working there itself as head of the department, and he is the Government Medical College, Kottayam, Kerala. So present position is he is the General Secretary General, Indian Association of Social Psychiatry, and also convener of Ethics Committee, IPS, Indian Psychiatry Society. And he previously was a past president IPS Kerala chapter, and he past assistant secretary IPS, and also honorable editor of Kerala Journal of Psychiatry and associated editor of Indian Journal of Social Psychiatry. convener of Awards Committee of IPS, and served in the National EC of IASP also. And his awards, there are many, and he is a recipient of fellowship for young psychiatrists by WPA in 2005, and Professor J.S. Satyanas Samarishanaha for excellence in medical teaching, and Catholic Effect Award for University Faculty in 2017. He has many publications to in his hand, co-authored Handbook on Suicide Prevention, and contributed a chapter on psychopharmacology in IPS undergraduate textbook of psychiatry. This is a very recent one. And 30 publications in international and national journals. And his areas of interest is child and adolescent psychiatry, public community mental health, consultation license, whatnot, each and everything, along with transgender psychiatry. So I welcome Dr. Varghese Manus for this to give his privilege. Thank you, sir.
Thank you, chairpersons, both my good old friend Dr. Panibhushan and Dr. Radhika Reddy for the nice words of introduction. Am I audible?
Yes, yes.
Okay, let me take a few seconds to start my screen sharing. Just a moment. Is it visible? Is the screen visible?
You are visible.
What about the slides? Has it come over there?
Not yet.
It hasn't come. It's showing on my this thing.
Let's see.
Sir, please share the screen, sir. Hello, sir.
Has it come?
No, sir. No, sir.
No, sir.
I'm trying to share the slides.
Please share the screen, sir.
Pardon?
Near the in the laptop near screen sharing is there, sir. Participant chatting.
Yeah. I am
Please share
doing that.
and click open
Click on
desktop. You can share.
Share content.
Your ID. Yes, sir.
Yes.
We can see that.
Has it come now?
Yes, sir. Yes, sir.
Yeah.
It has come. Okay, thank you.
Slideshow,
So,
sir. Make it slideshow.
so now the slides are shared.
Yes,
Okay.
sir. Yes, sir.
So first of all, let me express my gratitude and pride for being invited as a speaker in the Andhra Pradesh midterm CME. My good friends, Dr. Udaykumar, and senior friends and gurus like Dr. T.P. Sudhakar, President Dr. Ramesh Babu, Dr. Raveshwar Reddy, and great teachers, Professor Indira Ram Subbareddy, Dr. Prasad Rao. I have a lot of persons from Andhra Pradesh whom I consider as my teachers. So again, I consider it as my proud privilege to be back again in Nellore with an academic presentation. So today, the theme chosen for the CME is red flags in psychopharmacology. And as Dr. Prasad Rao mentioned, he started with a difficult topic, which is something away slightly different from the main topic of the team, but the way in which the CME was started by a great academician like Dr. Prasad Rao. So it's my task to start carrying the red flag to begin with. So I will start with a few scenarios in which we face in our day-to-day practice in general hospital settings. A psychiatrist is invited or given a consultation from other specialties to give an opinion or to make adjustments in the dosages of psychotropic medications they are or for non-pharmacological intervention. So this is a typical scenario where we get a call from cardiology, department of cardiology. An elderly gentleman with coronary artery disease, a coronary artery bypass done 3 years ago, who is on other medications, for several medications for his diabetes, hypertension, dyslipidemia, etc., etc. And currently he is admitted with an exacerbation of dyspnea, and the referral is for the purpose of restlessness and sleeplessness. And the psychiatrists find that in the background of an intact orientation and memory, the person is having a depressed mood and anxious cognitions and some persecutory ideations. The drug history, the cardiologist has already started him on alprazolam and quetiapine in small doses, and psychiatrists make the diagnosis of depressive disorder. And the important question comes, what are the safe drugs from a psychopharmacological? We are confining our discussion, today's discussion, mostly to psychopharmacology in consultation license settings. So this is a familiar scenario for most of us. And look at another scenario where the referral is from the Department of Nephrology, a middle-aged lady undergoing hemodialysis for chronic kidney disease stage 4 to 5. And she is having depressive features, and she is experiencing electrolyte imbalance in between. So her electrolyte status is not that stable. At the same time, she is depressed. So what are the safe antidepressants to be initiated and how they should be monitored? So it's a big question, and there are several red flags there. And look at scenario 3, where the consultation is from the pulmonologist. A COPD with frequent exacerbation, and again, it's depression. The pulmonologist thinks that his emotion state is also contributing to his frequent exacerbation. So the psychiatrist is roped in to manage the COPD, but again, we have a lot of constraints in choosing the right medications for him. So red flag number 3. And look at scenario 4, a very usual situation where we get a call from the internal medicine department or the gastroenterology department, where the patient with bipolar affective disorder, alcohol dependent syndrome, developing something like hepatic encephalopathy resulting from cirrhosis liver and portal hypertension, hepatic impairment. Already he is on multiple medications, and the gastroenterologist is very worried about the safety of this medication. At the same day, he wants our pharmacological intervention. And the last scenario, there are umpteen number of scenarios like this, just to get, I'm sure that many trainees also will be attending this over the Zoom, just for their sake. Person with, again, a middle-aged person with on treatment from the oncology department, who had a past history of recurrent depressive disorder, and now presenting with oncological problem primarily, but the oncologist is concerned how this treatment is going to affect her oncological status, that he is worried about the drug-drug interactions, etc. So with this, I'm not going to discuss these case scenarios. These are just, it's a teaser and introduction to the kind of problems which we are going to discuss as this presentation progress. See, the general hospital psychiatry has shifted from mental hospitals to general hospitals in a large way, starting from 1980s, and that is definitely a welcome sign. That definitely is something which has made psychiatry grow and made psychiatry acceptable to the public as well as to other medical professionals. And there is a lot of talk and emphasis on the consultation license model. But unfortunately, even today, even in the training of psychiatry, very little importance is given to the consultation license skills. For a PG examination, we very, very unlikely to give a case for the candidate for MD or DNB or DPM on a case or consultation license case. It's very unlikely to come up as an exam case. And the Medical Council of India, now the NMC, there's an interesting thing. Those who have gone for MCA inspection previously, there is something which is known as psychomotor clinic. People are not sure what the psychomotor clinic is. Again, I had the confusion. I did a little research, and I think I am right in understanding that it was a typing error, a clerical error for a psychosomatic clinic. Actually, it was a psychosomatic clinic where somebody who designed the curriculum for MD, DPM, and DNB, they thought that students, the trainees should be adequately and they should acquire their competence in psychosomatic medicine. But unfortunately, it was wrongly stated as psychomotor clinic, and many departments may not have. I don't think we have a strong consultation like psychiatry setting in most of the PG training center. So the times are changing, the skills needed of psychiatrists are changing, and this is an opportunity to seize that opportunity to get more skilled and trained in consultation licensed psychiatry, where we need to interact with our physician colleagues, our surgical colleagues, and other non-psychiatrist colleagues, so that we can deliver very effective services. So now there are a lot of areas, but for the considering the limited time available for today's presentation, I thought that I will shortlist the red flags in 5 major areas. One is heart disease, the prescribing a psychotropic agent in a patient with heart disease, as we have seen in case scenario 1, and the principles of using and the decision not to use certain agents in a patient with hepatic impairment, with renal impairment, and with lung disease. Lung disease has come into prominence recently over the last 1 year. When COVID came, we psychiatrists thought that we may not have a great role in treating an infectious disease of viral etiology. But anyone who has the opportunity, who had the opportunity to work with our COVID care centers, we know that a psychiatrist has become an important part of COVID care management because of the needs of the patients, development of delirium in the COVID ICU, along with pulmonary complications. And again, in Kerala, we had a spate of suicides in COVID wards. So the government has placed psychiatry as an important component in COVID care as well. So a mention about lung disease and a specific reference to COVID. And finally, the very difficult and confusing topic of drug-drug interactions. I'll make only a very brief mention about drug-drug interaction because that itself is a big topic. So these 5 shortlisted areas, I hope I will quickly cover in the next 30 minutes or so. So first, the red flag in treating a patient with heart disease, cardiac patients. So the generally, any practicing psychiatrist is aware that 3 group of agents, mainly antipsychotics, antidepressants, and among mood stabilizers, lithium. These are possibly the 3 group of drugs which have an effect on managing a patient with which comes or which becomes important concern for the psychiatrist as well as the cardiologist when it comes to treatment. And it's a matter of common knowledge that mainly the SNRIs, especially the venlafaxine, may cause a rise in blood pressure when it is used in dosages above 150 milligrams. And SSRIs, by their very nature, the inherent antiplatelet action can have an effect on coagulation. And almost antihypertensives from almost every class, starting from non-selective beta blockers, the central acting ones like the alpha-methyl dopa or clonidine or the reserpine-containing agents used not only in modern medicine but also in Ayurveda, calcium channel blockers. They are well known to cause or contribute to the development of depression. And again, we know the addition of antihypertensives or diuretics in cardiac patients like AC inhibitors and thiazide diuretics can precipitate lithium toxicity. So these are the common issues we face in our consultations or interactions with patients, cardiology patients. But I think after the introduction of the second generation antipsychotics, a lot of interest has come up with regard to the QTC prolongation. Every psychiatrist who is practicing in general hospital setting and interacting with the Department of Cardiology, especially to the residents, junior residents and senior residents who might be attending this program. Go back to your general medicine and cardiology and revise your ECG lessons. It's important because we cannot effectively interact with the cardiologist unless we know some of the basic electrophysiology with regard to, at least with regard to the QTC. So we know QTC is nothing but a measurement which we make of at the time interval of the QRS complex, which represents the ventricular depolarization till the T wave is over. That means the ventricular repolarization. So this QTC prolongation results from, it can result from psychotropic agents, antipsychotics or antidepressants which block the potassium channels. The potassium channel blockade can result in a prolonged, the repolarizing current is prolonged. The rectifier current is prolonged by certain agents. As a group, we cannot casually mention as a group of antidepressants or antipsychotics. There are relative differences, and that is where our expertise should come, and that is where we can effectively interact with the cardiologist. So the normal values of QTC is less than. So there is it is interesting to note that there is a gender difference. 430 milliseconds is the upper limit for QTC. QTC means corrected QT interval, and this correction depends upon the heart rate, and the cardiologists have several formulas like Bassett's formula, which we need not really know about the details, but we know what is the concept. Okay, so QTC less than 43 or less than 450 milliseconds is the ideal one, except in people with some congenital QTC prolongation situations. These are the normal values. And any value more than 450 milliseconds in men and 470 milliseconds in women. See the red flag there. So it's an important, very, very important red flag which we should be looking for when we are treating a patient with heart disease. When we are prescribing antidepressants or antipsychotics to this category of patients, we should never ignore this red flag of the QTC. So always have a discussion with your cardiologist. It's interesting to note that female heart takes 20 milliseconds longer for the depolarization and repolarization. So some gender issues are there, how biological and how it is related. It's an interesting thing. And what is the importance of this QTC? This QTC prolongation can lead to a very dangerous situation called TDP. When speaking in Andhra Pradesh, I should be careful in using the term TDP. It's not Telugu Party. It is torsady pointis. Torsady pointis is polymorphic ventricular tachycardia characterized by the twisting of QRS, the twisted QRS complexes you can see around the isoelectric line. This can lead on to very fatal ventricular arrhythmias and sudden death. So that is the importance. So a person who has been doing very well, you start the patient on a medication, say antipsychotic, and the patient develops a sudden cardiac problem, it can become a big issue. We may burn our fingers. So it's important to note. And you can see the ECG recording of a TDP. The torsady point is we can see the twisted QRS complexes around the ice on both sides of the isoelectric line. So this is important. And to cut it short, there are different authorities, different sources which have graded antipsychotics and antidepressants depending upon their propensity to develop torsady pointis. So look at this chart. The highest risk is for agents like thioridazine and pimoside, which we do not use nowadays, fortunately. When I was trained in 1990s, there was a lot of use for pyridazine and pimoside. People were very happy to use pimoside for negative symptoms of schizophrenia at that time. And pimoside was almost considered as the drug of choice for delusional parasitosis. Now, you look at the QTC prolongation, it is very unacceptable. It is definitely more than 20 milliseconds prolongation, pyridazine and pimoside. And again, another commonly, even now we use haloperidol, parenteral preparation of haloperidol, but again a danger is there. Intravenous haloperidol better avoid in situations, even when we have to use a parenteral haloperidol. It is better to go for either oral haloperidol or intramuscular haloperidol. Intravenous haloperidol has again unacceptable QTC prolongation more than 50 milliseconds. And you can run down and you can see that for clozapine, risperidone, ziprasidone is not a very good molecule in terms of QTC, even though it has got several advantages. As you come down, you can see olanzapine is slightly in the better range, and you can see agents like aripiprazole and agents like perfenazine are definitely on the safer side of QTC. So this consideration should be in our mind when we see and prescribe antipsychotics or modify antipsychotics when we see patients from cardiology department. Antidepressants again are not safe. Tricyclic antidepressants, even when they were introduced, it was known. I still remember my cardiology professor during our UG time listing imipramine along with the type 1A antiarrhythmic quinidine-like agents. So tricyclic antidepressants were known to be associated with type 1A antiarrhythmic action. So type 1A antiarrhythmic means something which influences the intraventricular conduction. And other problems associated with antidepressants, we know about the orthostatic hypertension resulting from the alpha-adrenergic action, etc. And to cut it short, if you want to make a gradation, ranking of antidepressants, desipramine may be, even though it's a secondary amine, which may have certain advantages in terms of anticholinergic action and other kind of adverse effects among the tricyclic antidepressants. It has got a bad profile when compared to agents like nortriptyline, which may have a relative better profile. When we come to the newer antidepressants, when SSRIs were introduced, we know the story. And when citalopram and escitalopram were introduced, everyone was very happy because we thought that it has got very minimal drug-drug interaction and a very potent SSRIs, and it is very safe in medically ill people. But remember that escitalopram and citalopram were not that safe when it comes to cardiac patients. We can see the QTC prolongation of nearly 20 milliseconds for citalopram, and it might be slightly less for escitalopram, but still it is not in the safe range. So when we consider with regard to the QTC intervals, other antidepressants are not are relatively in the safer range. And there is an excellent review by Xiong et al. And others as an expert consensus on QTC monitoring, Journal of Psychosomatic Research, July 2020. So it's a good article which those interested residents can have a look at. So look at this chart. Again, you can see desipramine at the worst end. And you can see imipramine, citalopram down there, escitalopram. And as we come down, we find that agents like venlafaxine or duloxetine, desvenlafaxine, bupropion are relatively in the safer range. So have a reference when we think about prescribing. This is not the only consideration. Okay, so when we consider the QTC pattern, this should be the consideration. But when we go to the drug-drug interaction, escitalopram may have certain other advantages. So it is all not a simple equations. We may have to make very complex decision considering different aspects, and QTC is an important red flag I want to mention. And before I conclude on cardiology patients, just have a quick look at the other risk factors of QTC prolongation. For example, several cardiac risk factors, several medical conditions like starvation, hepatic or renal coexisting, hepatic or renal disease, are all predisposing or risk factors for female gender, extremes of age, several other medications, not only psychotropic medication. When we review a patient in cardiology, we need to do a thorough review of the drug history. Other drugs used in the conditions of other medical conditions also may have a QTC prolonging action. And when we introduce an agent like, for example, citalopram or an agent like ziprasidone, we might be, or quetiapine, we might be actually synergizing that action. And always never forget to have a look at the electrolyte status, especially potassium, magnesium, and calcium. So this hypokalemia, hypomagnesemia, and hypocalcemia, these are all situations which predisposes a person for development of QTc prolongation and thereby tertiary pointers. And I made a mention about medications used for other purposes. So recently we had a problem. We had several issues when chloroquine was initially being tried in the treatment of patients with COVID syndromes. Initially, not now. Now they are not. It is out of the protocol now. And several antibiotics. So we had a lot of confusion whether what should we do with these agents. Okay. So ECG monitoring. So when and how we should monitor the ECG. It's a question which some of the authors have tried to answer this question recently. So according to American Psychiatric Association guidelines, one should obtain a thorough medical and medication history and ECG within 1 month as a baseline ECG if you are planning to use a agent which is high, has got a high propensity for prolonging the corrected QT interval. So a baseline ECG and a frequent monitoring, even though no authorities have given such kind of a prescription, such kind of protocols are not there in India. It is prudent and wise from our part to have a discussion with the cardiologist to have a baseline ECG documented. And if you are using an agent which can have the propensity to have a regular monitoring, actually IPS or professional organization should actually bring out such kind of guidelines for the safety of the practicing psychiatrist in the license setting. So baseline and follow-up ECG should be obtained whenever feasible with patients with 2 or more risk factors. Risk factors I will discuss in the next slide. And if any chance of getting a QTc above 450 milliseconds in the male or 470 milliseconds in the female patients, think about reducing, switching, or stopping. Definitely a QTc above 500 can be quite dangerous. So any sudden increase of QTc above 60 milliseconds from the baseline, consider stopping or switching the agent in question. So it should be a joint. This algorithm should be a joint workup with the cardiologist. We should sit together with the cardiologist. We should put our heads together by the risk and benefits of, if the risk factors you can see over there, the risk factors, if more than 2 risk factors are present, and if there is a definitely a baseline ECG is needed and a follow-up ECG is needed, and again we need to monitor the QTc interval, and at some point of time we may have to stop or switch or reduce the agent in liaison with the cardiologist. So since the lack of time, I am moving over to another important red flag, which we can see in liver diseases. Maybe one of the commonest situations where a psychiatrist's help is needed is the gastroenterology department, where a person may have comorbid psychiatric conditions like bipolar affective disorder, alcohol dependent syndrome, and developing a cirrhosis, liver, portal hypertension, hepatic encephalopathy, which we have mentioned in one of the case scenarios at the outset of this presentation. See, it's a matter of common knowledge that a lot of drugs, almost every drug except certain ones like lithium or amisulpride, they undergo extensive hepatic metabolism. So any impairment in the capacity to metabolize the drugs can precipitate hepatic encephalopathy. If the patient is having not only the metabolism, not only the cytochrome P450 system, not only, so other agents can also be contributory. For example, an impaired liver will not be able to produce the proteins. The AG reversal, hypoalbuminemia. Hypoalbuminemia can, on top of the already existing hepatocellular dysfunction, can add on to the toxicity by reducing the availability of the albumin or proteins which can bind to the drugs. So even if you go for a serum level estimation, that can be misleading, because the serum level estimation, unless we specify for a free estimation of drugs, we may get to total level which may not be actually representing which may not match with the level of drug toxicity. So the presence of protein is a must. It's a necessary factor for binding the drugs and transporting it to the different parts of the body. If albumin is reduced, since the drug molecules will not find enough albumin to get bound, and they are freely available, or they will be freely circulating in the blood, and that can precipitate toxicity. And again, liver failure is known to lead to vitamin K deficiency and bleeding symptoms. So gastrointestinal bleeding can be again contributed by agents like selective serotonin reuptake inhibitors because of their inherent antiplatelet action. So there are multiple reasons why the red flag should be looked for when you are dealing with a patient with hepatic impairment. So it's a very complex situation. So quickly, some general principles in the prescribing liver diseases. One of the common mistakes which can happen in concentration lysis is over-reliance on the liver function. The liver function test, even other physicians or patients may have a wrong idea that if the LFT is normal, everything is fine with the liver. Or if the ultrasound is normal, everything is okay with the liver. Not at all. LFT can be a poor indicator. At the same time, we may have to depend on LFT values. In the next slide, I will mention a few important points to be looked for. The golden rules are minimum number of drugs, low, start low, go slow, longer intervals for dose taking, very close monitoring, avoid long half-life drugs. The reason is well known. Why these are important, I don't have to tell an audience like this why these steps are important. And one thing which we need to remind ourselves and tell our colleagues who might be giving patients for drugs for other agents, avoid sedating and constipating drugs always in a patient with liver disease. A patient might be a bit restless, or the patient might be already taking benzodiazepines, for someone might have started chlordiazepoxide several months before when he was treated for the alcohol dependence, and still that Librium chlordiazepoxide might be continued without any reason, and it might be contributing to the persistence of hepatic encephalopathy or worsening of hepatic encephalopathy. So have a close look at agents. Are any of the agents either prescribed by us or prescribed by other specialists contributing to the sedation? And we know that if constipation happens, the nitrogenous waste materials will be reabsorbed, and that can again contribute to the hepatic encephalopathy. So one should always make sure that hepatotoxic drugs are avoided, like chlorpromazine, and we don't have to worry about monoamine oxidase, but still agents like seleginine, we need to be careful. So quickly to wind up on patients with hepatic impairment, psychotropic medications which can be slightly, even though none of these medications are absolutely safe, if one is choosing antipsychotics, better to go for agents like amisulpride and paliperidone. For antidepressants, the safer ones are escitalopram, sertraline, and mirtazapine. But remember that escitalopram and citalopram may not be safe in terms of QTc prolongation. Mood stabilizers, of course, lithium, if provided the renal functions are normal. And if one has to go for sedative hypnotics, go for the short half-life ones and those without metabolites, significant metabolites like lorazepam, oxazepam, and temazepam. And for hypnotic purpose, soficlone 3.75 milligram may be useful. So these are the things to be kept in mind. And just a few points about monitoring the liver. So we are all worried when we start the patient on sodium valproate. The patient is already on sodium valproate. The LFT goes slightly high. So go for the HICE rule. Hai Zimmerman is one of the authorities in these areas, and he has suggested a rule of thumb. It is widely accepted in gastroenterology circles that the ALT, the SGPT rise more than 3 times the upper limit of normal. Only then you need to consider it seriously. And again, a serum bilirubin more than 2 times the upper limit of normal. Otherwise, we can just monitor. So this HICE rule of thumb can be looked for. Again, consider female gender, obesity, co-prescription of enzyme-inducing drugs. All this should be kept in mind. And quickly, prescribing kidney disease. Kidney diseases are increasing since the diabetes is increasing along with the diabetes, CKD, and with dietary changes. So every hospital is coming up with renal dialysis units, the transplantation units, and the psychiatrist is very frequently called in to see patients with CKDs. Just like liver, kidneys are also very important in handling the psychotropic within the body. For any pharmacokinetics, along with liver, kidneys play an important role. And any impairment in renal functions, reduced capacity to excrete the drugs, and epidemiological studies have shown that even the presence of schizophrenia and mood disorder increases the risk of developing CKD later in life. And the possible direct nephrotoxicity is controversial, but still lithium, even some case reports and case series on olanzapine and quetiapine producing acute kidney injury. And any person above the age of 65, nephrologists say that they should be presumed to have mild renal impairment, even their serum creatinine or blood urea is normal. And when we are called in to see patients on dialysis, remember that they will have unpredictable drug effects. So dialysis is one condition. It's a renal replacement therapy. Any kind of renal replacement therapy is, especially hemodialysis, a patient can be very unpredictable. So one has to be extremely careful when prescribing antipsychotics or antidepressants or other agents to patients on dialysis. So the good old rule for the whatever was stated for those with hepatic impairment, starting low, going slow, and minimum number of drugs is applicable to renal patients as well. Two words of caution with regard to drugs having anticholinergic action. Any drug with anticholinergic action, not necessarily prescribed by the psychiatrist. It can lead on to urinary retention, and that can worsen the renal status. Any drug which produces weight gain. Weight gain can lead on to rhabdomyolysis, and a person with a normal set of kidneys will be able to deal with the rhabdomyolysis due to weight gain, but a person with renal impairment, especially when he is in CKD stage 3 or 4, this could be very decisive, and this could be tilting the balance towards worsening. Always, even simple dystonias can lead on to rhabdomyolysis, not necessarily envelopatic malignant syndrome. So one has to be very careful when the early signs of serotonin syndrome happens in a patient who is prescribed SSRI, because that can precipitate rhabdomyolysis, and that can tilt the balance, and that can decompensate a patient with renal impairment, and the patient can go in for an acute renal shutdown. Always caution with drugs prolonged QTC and producing electrolyte imbalance. So electrolyte imbalances, not only sodium and potassium, but also magnesium and calcium should be monitored carefully in patients with renal failure, because even those drugs with minimal or moderate QTC prolongation in the background of an electrolyte imbalance like hypomagnesemia, hypocalcemia, hypokalemia increases the risk of QTC prolongation and TDP. So it is important to learn the language of nephrologists. Most of us, conventionally, we rely on blood urea serum creatinine when we monitor a patient with lithium. But it's important that when a patient has got an active kidney disease or any serious kidney disease, one has to go for these terms like creatinine clearance and GFR and albumin creatinine ratio. Since the lack of time, I don't go into the detail, but those who are into the practice of or those trainees who are seeing patients from kidney, let's learn some of these basic concepts so that we can effectively communicate with nephrologists, and they will have some respect for psychiatrists if you know these basic things. So to conclude on this area, the psychotropic medications, antipsychotics, if one has to go for antipsychotics, better to go for haloperidol and olanzapine in lower doses, and better to avoid amisulpride and agents with significant anticholinergic actions like chlorpromazine or thyroidazine, etc. So antidepressants, sertraline and escitalopram may be the better choices. Mood stabilizers, better choices are anticonvulsant mood stabilizers rather than lithium, fact which is well known. If you want to use anxiolytic hypnotics, again go for agents like lorazepam and soficlone. Anti-dementia, rivastigmine has got some advantage over donepezil and memantine. So in a kidney patient. And finally, the patient with lung disease. As I mentioned at the outset, the COVID has brought the importance of knowing about pulmonary function when we prescribe a patient with psychotropic medication. The COVID interstitial pneumonia has really focused the importance of psychotropic medications. Okay, so we know before coming to the COVID in general, COVID in specific, the general things about in a patient with respiratory failure or any condition which has got potential to develop respiratory failure, a patient with pneumonia, patient with COPD, beware of benzodiazepines. So there might be a lot of pressure from the part of the patients or the relatives or even the treating clinicians to get a benzodiazepine prescribed. But to control acute agitation, which may be seen with delirium. So one has to go for, if at all we are going for benzodiazepine, go for agents with short half-life, agents like etisulam, oxazepam, and lorazepam. And use with caution drugs with anticholinergic properties like tricyclic antidepressants or paroxetine. There are issues like aspiration and siluria associated with the use of agents like clozapine. And there is at the same time, we need to be aware that there is a high prevalence of depression in patients with COPD. And on the other side, again, there is evidence that there is high mortality on those patients who are on antidepressants. So one has to weigh it very sensitively. COVID-related. So just one or two slides about COVID-related problems, as I have been mentioning from the outset. The bilateral interstitial pneumonia has placed a lot of focus, importance, concern with regard to their behavioral problems. Many patients developing delirium as a part of the respiratory distress syndrome, and the need to prescribe psychotropic agents, and the concomitant use of steroids, antivirals, the possible drug-drug interaction. Nobody knows. It's a relatively new area. What is to be done? And there are some guidelines have been drawn by certain groups. Quickly, these are the sedative properties of psychotropic medications should be considered when we prescribe in a patient with COVID pneumonia. The pharmacokinetic interaction, raising the plasma levels, especially when the patient is on antiviral agents like the lopinavir, ritonavir, etc. It has to be carefully looked into, and several other concurrent use of medications can contribute to COVID-related deaths. So when we use, actually the studies are going on only. One of the significant reasons why COVID death rate could be iatrogenic due to use of psychotropic agents, interacting with unknown interactions, etc. And finally, the drug-drug interaction. Drug-drug interaction is a vast area, but quickly, frequently overlooked aspect. In consultation licensed psychiatry, always find some time to thoroughly review the drug history. So it involves several areas, and it is impossible to have a ready knowledge and ready information. So it is always better to go for sites. For example, there are any number of good internet sites where you can have the WebMD site where you can just very easy one add the medication one, for example, escitalopram oxalate, then add the medication to chloroquine phosphate and just click it, and you know that there is a significant interaction. Chloroquine and escitalopram oxalate can significantly interact, and which may produce a cardiac increase the cardiac risk. So such kind of sites. Another drugs.com. Drugs.com has got a professional arm also. So it has got it's a mobile app where again you can very easily use it, and you will get very valuable information at the click of a button. So nowadays it has become very easy. Previously, when we used to attend CMEs, we thoroughly get confused by all the cytochrome P450 systems, which are the inducers, which are the inhibitors, and such kind of problems are easily solved now. Have a quick access to any of these quick drug interaction checkers, and you get the answer. Only thing we need to spend a few minutes for that. So, for example, one of the COVID, again going back to the COVID challenge, when we had to use antidepressants and antipsychotics along with antidepressants like remdesivir, chloroquine, so many antiviral agents with which we were not familiar, and now quick references are available in the net, and we can decide in the bedside itself which drugs are safe and which cannot be used. So finally, I conclude with these take-home points. I tried to cover red flags in certain important areas only, in heart disease, in kidney disease, in renal, in liver disease, in pulmonary or lung diseases, and finally a few points about drug-drug interaction. So one need to have some basic relearning or updating with regard to concepts like what is QTc role, what is GFR, what is creatinine clearance, what is albumin creatinine ratio, what are pulmonary function indicators, etc. So that definitely indicates a close interaction with our colleagues in other specialties. And I will always advise the trainees or residents to have a quick reference to the board's prescribing guidelines of 14th edition. That gives a reasonably good quick reference to the possible safety, drug interactions, etc. And also the prescriber's guide, 7th edition. So these are some quick references. And I already mentioned about the online references for drug interactions in drugs.com. Drugs.com, I feel that that's a very easy thing. Go for the professional. There are the client one, the consumer one, and the professional one. You can easily go for the, it's free, it's easily available, it's good, and the data is reasonably good. So the bottom lines are a close liaison and interaction with internists and specialists. We need to focus those who are in teaching, those who are in training. So my appeal is that we need to have a more focus on training in the consultation license area, because the future of psychiatry is definitely in the license areas. And again, it provides bidirectional learning teaching experience and places psychiatry back to the place where it belongs. So before I conclude, I acknowledge the help received from my senior resident, Dr. Suman from Kottayam, and my daughter, Sneha, who is JR in Imhans. Both of them helped me with some recent articles in the preparation of this presentation. So thank you very much. I hope I have finished within my allotted time. Thank you.
Thank you very much, Dr. Varghese, for the lucid presentation of psychopharmacology in medically ill with special reference to cardiac patients, patients with hepatic impairment, renal impairment, and special consideration of COVID-19 patients. Although it's a very enormous topic and it's very easy, it takes a lot of time to understand the psychosomatic medicine and consultation liaison, because the diseases are many, and as psychiatrists, we are asked to see a myriad of cases in day-to-day life in a general hospital practice, and you probably need to have a pocket book, as suggested by Dr. Varghese, the MARSA guidelines or the SALTS prescriber guide, because for ready-made, it's very difficult to remember drug interactions, drug disease interactions. So very nice suggestion from his side. Absolutely very clear presentation. The diction is very clear, understandable, and dot onto the point, whatever he spoke. Thank you very much, Dr. Varghese. Now, may I request Dr. Radhika Reddy just to address the question and answer sessions.
Hello, madam. Unmute, ma'am.
Yes.
Thank you, sir. That was a very wonderful session and very lucid and to the point. And it showed there is no questions in the chat box actually. That itself indicates that the clarity you have given in this lecture. And it as well tells everyone that the importance of LISA, psychiatry, and the youngsters has to get the training in that aspect. It's really a thoughtful session, and everybody has really enjoyed your sessions. There are no questions, and there is one question from my side. So we see patients with diabetes, hypertension, cardiac problem, and also nephrology, CKD and all. So with the multiple problems, usually at the end of the day, they land with us for a referral. And all the physicians, they refer the case to us usually in an ICU. What is your take-home message for this kind of cases? The complex illness with the multiple problems.
Yeah, thank you, Dr. Radhika, madam. See, that is exactly the challenge in this situation. We need to, so my simple answer to this problem is that we need to learn to shift from the consultation psychiatry to licensed psychiatry. Consultation license, if it is followed in its true spirit, there could be an answer for this problem. But unfortunately, what happens is consultations only. And we don't discuss. So rarely, for example, in a COVID intensive care unit, we may have to do certain decisions by the bedside. Even then, a licensing is possible. In other situations, whether it is a patient with multiple systemic diseases, we can do licensing within the limits and constraints of our settings. So what I do is that either the place where I work, since it's my home ground, I have a personal rapport and relationship with most of the departments, so we do discuss it over phone, or sometimes we may discuss it over small WhatsApp groups form for, suppose if a VIP, for example, for VIPs, we form WhatsApp groups, so that it may not be possible for every patient. So as rightly suggested by you, some protocols, some operating procedures and protocols should be developed when we have a patient with multiple medical problems. Only this is the answer. So licensing in its right spirit, and of course we need to acknowledge to the patient as well as other. We are not encyclopedias. Previously, a professor of psychiatry was supposed to be an encyclopedia when we had only 3-4 drugs. But now we have hundreds of drugs, hundreds of molecules, and we cannot claim to have. We cannot have such pretensions and tell them that we need time to refer, and they should also. It's a learning experience. So that is my comment on that. It's a very valid. Thank you, ma'am.
Thank you very much. Any questions from the floor?
I am happy to share this presentation to the organizers. I can send the, maybe if some of the PGs trainees are interested, they can have it. I shall send it.
Thank you very much, sir. Your contribution and generous sharing also.
Thank you, Dr. Verghese, sir, Dr. Fani Bhushan, sir, and Dr. Radhika, ma'am. The mementos have already been handed over.
Yeah, thank you. Thank you for this excellent, beautiful, aesthetic memento, which I value.
Thank you, sir.
Thank you very much.
Sir, thank you. The best possible lecture you have delivered. Thank you, Verghese Punas garu. And both the chairpersons I thank personally, the Fani Bhushan garu, Radhika Reddy. Thank you, sir. You made the lecture very nice. Thank you.
Thank you.
Thank you very much.
Thank you very much, sir.
Thank you
for
very
your
much.
memento. Very nice memento. Thank you.
The next topic for the session will be long-term use of antipsychotics as mood stabilizers, the pros and cons. I would welcome Dr. G. Bhagya Rao and Dr. P. Ravishankar, sir, as the chairperson to preside over this session. Dr. G. Bhagya Rao has completed his MBBS from Kurnool Medical College and was awarded the gold medal in physiology. He has completed DPM from CMC Nellore and completed DNB Psychiatry in 1983. He is also has MA and BL from Andhra University. The achievements of Sir has received Manasa Hospital Oration Award in 2015. He also served as the past president of IPS AP State Branch and South Zone. He has won the Republic Day Merit Award in 2009 for his contribution in the field of community psychiatry. And his professional experiences are he served as a superintendent of GHMC Vizag for 10 years and as the principal of Andhra Medical College for 3 years. He is retired as the Director of Medical Education in 2011. He served as the Professor of Psychiatry for 20 years and conducted many de-addiction camps in Visakhapatnam. We welcome you, sir.
At the outset, am I audible?
Yes, sir.
Am
Yes,
I
sir.
audible?
Yes, sir. Yes, sir.
At the outset, let me thank the organizers of IPS AP chapter, Midterm CME, for giving the opportunity to chair an important session. These topics were selected very meticulously, very practically for the practitioners, useful for the practitioners. Myself and my co-chairperson, Dr. Ravi Shankar, will be happy to present this topic and interact with you. The speaker is Dr. Suresh Kumar, Director, SciMed Hospital, Chennai. He is an adjunct professor of psychiatry, Sri Ramchandra Medical College, and he has done extensive work in the field of addiction psychiatry and other fields. And Dr. Suresh Kumar is a voracious speaker. I heard many times, and I'm sure he will definitely do justice to the topic and also to the new knowledge to the practitioners about the long-term use of antipsychotics as mood stabilizers, pros and cons. As all of you are aware, there are 3 types of mood stabilizers that are used. One is the minerals and salts like lithium, which was extensively used, almost first mood stabilizer. Then anticonvulsants, sodium valproate, then carbamazepine and other things. Then antipsychotics were also used like olanzapine, quetiapine, flurazidone, risperidone, aripiprazole, clozapine. So there are some pros and cons with these antipsychotics that will be explained by Dr. Suresh Kumar in detail. Now I request my co-chairperson, Dr. Ravi Shankar, to introduce Dr. Suresh Kumar.
Now we would like to invite Dr. Ravi Shankar, sir.
పెన్షన్ ఒకటే కదా వాళ్ళకి ఇంకేమన్నా వచ్చే ఛాన్స్ ఉంటుందా?
Sir is not available right now. He will join us shortly.
Then Dr. Ravi Shankar is available.
Sir is not available, sir. He'll join us shortly, sir.
If I'm given the permission to share the slides, it will be useful for the presentation. Should I go ahead, sir? Dr. Bakirao, sir? Can I go ahead? Sir, you're muted.
Bagheera, sir, unmute.
Sir, you need to unmute yourself. Yeah, thank you, sir.
Okay.
Sir, you can go ahead, sir. Suresh, sir.
Yeah, okay. Thank you very much. Good afternoon. And at the outset, I want to thank Professor Sudhakar, Dr. Uday Kumar, Dr. Ramesh Balaji, and the Nellore Mind Club for asking me to present in this fantastic CME. I had the pleasure of listening to Prashad Rao and Dr. Verghese Punos. Brilliant presentations, very educative. The topic I'll be dwelling on is atypical antipsychotics, long-term use of it as mood stabilizers, what the pros and cons are. So my outline for the presentation is going to be first the introduction, and then I'll talk about atypical antipsychotics in the maintenance treatment of bipolar disorder, particularly focusing on the efficacy of the atypical antipsychotics as mood stabilizers. And I will actually call out some of the recent evidence for atypical antipsychotics as mood stabilizer in 2020, the recent evidence. And I will talk about some of the limitations of its use before concluding. That'll be a very short presentation. I will save you the trouble of waiting for the long period of time. I know it's very difficult to hear a talk just before lunch. So first about introduction. Radhika to mute herself. I think if you can request Dr. Radhika to mute, would be nice. Thank you, Dr. Radhika. Thank you. So as a way of introduction, I would like to say bipolar disorder is one of the most disabling severe psychiatric disorders with a lifetime prevalence of 3%. Is indeed the fourth leading cause of disability adjusted life years in people between the age of 10 and 24. So it's a disabling condition, younger people, adolescent, young adults. It is characterized by frequent recurrences, and suicide is the biggest threat, political threat we face among people with the lived experience of bipolar disorder. The disorder has substantial consequences not only for the individual and the family, but also for the society, because the healthcare spending associated with bipolar disorder is pretty huge. If you look at bipolar disorder, we look at it as a multi-system disorder these days. People with bipolar disorder don't come only with bipolar disorder. They come with many other psychiatric comorbidity and somatic comorbidity, which is very unfortunate when we deal with them. Compared to general population, the lifetime prevalence of anxiety disorders, substance use disorders, eating disorders are way high in people with lived experience of bipolar disorder. Similarly, people also have many medical comorbidities in addition to bipolar disorder. For example, headache is a very common presentation in a fifth of the individuals, and hypertension can occur in about 18% of the individuals. If you put all the diabetes together, both complicated and uncomplicated, about 6% of the people, it may be way more in South Indian settings. And diagnosed obesity is in about 5% of the individuals in bipolar disorder. So we have a huge population of bipolar disorder experiencing psychiatric comorbidity as well as medical comorbidity that makes the treatment quite challenging. The most important point for our discussion is the fact that it is a recurring disorder. Relapse is integral to this disorder. Is very much a rule. Recurrence is very much a rule in bipolar disorder as opposed to the exception. You know, rarely see a person with the diagnosis of bipolar disorder who never experienced, like recurrence. In 4 decades of my clinical practice with bipolar disorder, I certainly would think that, there are very few individuals, I would say, who had never had any episode except in the first episode. Maybe I need to revise the diagnosis. The high rates of recurrence that's seen uniformly throughout the illness course from the first episode onwards is the most challenging in this disorder. Because of the high risk of episode recurrence, we always have to consider prophylactic treatment. That becomes an essential part of the treatment. It's not enough to provide acute phase treatment. We need to really stabilize them and put them on maintenance treatment with some mood stabilizer. That's when it becomes very, very difficult and interesting for the clinicians to deal with them. So let's look at the history of atypical antipsychotics and bipolar disorder. Dr. Bhagirao, as a chairperson, very nicely alluded and talked about the different mood stabilizers. And antipsychotics as mood stabilizers has a fairly recent history in the long-term use. We all know antipsychotics have been used in the acute phase of mania for a long period of time. But as a maintenance therapy, is only in the 1990s people started using it. When after the publication in the Journal of Clinical Psychiatry by Zarate in 95, that's when it became more popular. The earliest observational study of atypical antipsychotics, which is also called as second generation antipsychotics. I don't like the word second generation because then you'll have to talk about the third generation and the next generation. So I would rather confine to the word atypical antipsychotics, even though some researchers and practitioners would like to call it as a second generation antipsychotics. So the earliest observational study of atypical antipsychotics for maintenance treatment was observed in people with a refractory mood disorder who have been treated with clozapine. So that really paved way. These individuals were followed with a long period of time with the clozapine, the first atypical antipsychotic that was used and in the population of people with psychosis. And this was found to be extremely useful. And that's when atypical antipsychotics were actually started to become important in the maintenance therapy of bipolar disorder. Still then, only they were used in acute phase. Let's look at the pros. Is there an efficacy for atypical antipsychotics in the maintenance treatment of bipolar disorder? Nobody will argue that the acute phase of mania has to be treated with antipsychotics. They're probably cheaper, more efficacious, more time consuming. But can we use atypical antipsychotics in the maintenance treatment of bipolar disorder? What's the efficacy that is available? There are many drugs. Dr. Bakirov alluded about a lot of drugs that are used in the maintenance treatment, but FDA only gives approval for very few drugs. And these drugs are aripiprazole, olanzapine, Q-tipin immediate release, not the extended release, ciperidone, risperidone long-acting injection, not the oral risperidone, as a monotherapy as an adjunct, aripiprazole injection, which is available in the Western countries, is called as aripiprazole once monthly, known as OAM, aripiprazole once monthly. And that's very popular. Injection Abilify once monthly is quite popular in the Western world. These are the drugs that are approved by FDA for maintenance treatment of bipolar disorder. Let's go and look at some of the evidence we have for that. If you look at olanzapine, there are 3 randomized controlled trials which support the efficacy of olanzapine. If you talk about olanzapine, which is a very favorite molecule in this country, it prevents manic episode, depressive episode, and the mixed episode, which is extremely common. Dr. Prashad Rao talked about the mixed episode this morning. To prevent manic, depressive, and mixed episodes, in patients with an index episode of either mania or mixed episode who responded to olanzapine, they are the ones who do very well as a maintenance treatment. But fortunately, this is one drug, olanzapine is one drug, which can be used as a maintenance therapy, even in people in whom we have not used olanzapine during the index phase and seen the response. If somebody has been treated with some other drug and responded, even those can be considered for olanzapine, unlike many other antipsychotics. You will see with many other antipsychotics, you can use the antipsychotic only when the antipsychotic has proved to be useful in the acute phase. It's logical that something which is useful in the acute phase shall also be continued during the maintenance phase. It's only intuitive and logical. So, but then with olanzapine, it belies a logic, because even if somebody is responded to, let's say, aripiprazole at the acute phase or valproate at the acute phase, but still they can be maintained on, olanzapine in the long term. The long-term effects of olanzapine on rapid cycling is really unknown at this point in time. Aripiprazole is another drug which is really robust in terms of efficacy because 2 randomized clinical trials supported it. They are not just ordinary randomized controlled trials. You look at the randomized controlled design and the quality of it and the robustness of it. I think the aripiprazole trials are the best one in terms of fulfilling all the criteria. So even if you critically look at the data, aripiprazole is the most robust data that is available to say that it supports the efficacy of aripiprazole as a maintenance treatment for bipolar disorder. So it's useful in preventing mania, but not depressive episodes. Unlike olanzapine, aripiprazole can only prevent manic episode, but not depressive episode. But in these patients, they also should have responded initially as an index case of mania or mixed episode. They should have responded to aripiprazole. That's the difference between, olanzapine and aripiprazole. Another advantage with aripiprazole is, compared to ziprasidone, olanzapine, quetiapine, like other antipsychotics, aripiprazole has the reduction in the number of hospitalizations. So that has a tendency to prevent severity of the disease. That's also very important. Aripiprazole can produce not only preventing the recurrence, but also prevent the recurrence of a severe disease. So much so, the person need not get hospitalized even if there's a relapse. Risperidone is quite robust, oral risperidone, but I think statistically it's also, not very comparable to, aripiprazole. The numbers will be a little different, but statistically not very different. But the another advantage with aripiprazole is mental health treatment costs are very low for aripiprazole. So if you start somebody on aripiprazole, you're going to save a lot of money for treatment of mental health related issues. Is it comparable to ziprasidone and quetiapine? Definitely it is way better than ziprasidone and quetiapine. But olanzapine and risperidone are also pretty useful in terms of reducing the mental health treatment cost. This difference is explained only by the cost of aripiprazole versus olanzapine and risperidone in the Western world. In India, the difference may be not so large. Total healthcare costs was actually lower with aripiprazole because a lot of the side effect burden, metabolic burden resulting from other antipsychotics may not happen with aripiprazole. So much so, the total healthcare cost is also reduced. So aripiprazole not only is efficacious in preventing mania, but it is definitely able to reduce the recurrence of, not only the manic episode, but also prevents hospitalization. It improves the mental health treatment costs and also reduces the total healthcare costs. Let's look at antipsychotics in the maintenance therapy. What is about QTPN? QTPN was one drug which has been talked a lot in the literature. And I think if you look at robust studies, there is only one published positive study on maintenance treatment of QTPN. There is only one positive study. Everything is ambiguous and, vague. Only one published positive study is available for the efficacy and safety of QTPN in the maintenance treatment of bipolar disorder compared to lithium, in switch out to lithium or switching out to placebo. So the time to recurrence of any movement, any mood event is actually longer for both QTPN and lithium. So it's comparable to lithium. It's not superior to lithium in terms of preventing recurrence of any mood event. And in those people who are been suffering from bipolar depression and who have been put on QTPN and they responded to the bipolar depression in the acute phase, they also is capable of preventing further depressive episodes. In people with bipolar depression who responded in the index episode with QTPN, they will benefit with continuation of QTPN that can prevent depressive episodes later on. That's the only advantage with QTPN. Paliperidone, we don't use it very often in Indian setting for whatever reasons. It's oral paliperidone. People only use the injectable long-acting paliperidone. There is one positive study of its usefulness. Again, like many other antipsychotics, is useful to prevent manic episode, not depressive episode, particularly when the person has responded in the index phase. Risperidone long-acting injectable is pretty interesting because there are studies that are available which really point out that this is a very useful drug. There are two studies that robustly support the evidence of risperidone long-acting injectables. It prevents mania, again, but not depressive episodes. But certainly, people who actually benefit with the long-acting are the ones who responded either with the long-acting itself or the oral risperidone in the index episode. It's not moving. Okay, so let's go on to olanzapine fluoxetine combination. That's a very favorable combination for people when they are using it for bipolar depression. The efficacy of olanzapine fluoxetine combination is very similar to lamotrigine in terms of preventing incidents of relapse if you use it as a long-term treatment. So there are a lot of literature now emerging and saying it's comparable to lamotrigine. But unfortunately, no randomized clinical trials have not been done on this OFC. But cohort studies have shown that very similar to lamotrigine, it can prevent the incidence of relapse. But then overall bipolar depressive patients who responded to OFC in the beginning are the ones who respond later on. So the moral of the story is very simple. Many of these antipsychotics are pretty useful as maintenance treatment when you have found them useful in the acute index phase of either mania or mixed episode. When it comes to depressive episodes, either only QTPN is the only drug that shows some kind of a robustness or olanzapine fluoxetine combination in bipolar depression. Otherwise, other drugs are not capable of preventing depressive episodes. Look at the mixed bipolar episode, which Dr. Prashad spoke about this morning very, very, nicely and lucidly. And the data suggests that olanzapine is one drug that can be used very well to prevent mixed episodes. And if you continue to use it, the occurrence of mixed episodes is really controlled. Data also supports QTPN, not alone. QTPN in combination with either lithium or valproate could be useful in mixed episodes. But the data is quite negative when it comes to aripiprazole. Aripiprazole is capable of preventing mania, but not depression and mixed episodes. So olanzapine stands out in controlling mixed episodes and depressive episodes as a maintenance treatment. If you look at rapid cycling, this is a big challenge. people with the rapid cycling with 4 episodes or more in a year are a big challenge in clinical practice. And for this, only a post-hoc analysis is available. For this, I think aripiprazole is the most favorite drug. Aripiprazole has the one drug which has got an established efficacy, at least in a post-hoc analysis, for preventing rapid cycling. No other antipsychotic as a monotherapy is capable of preventing rapid cycling. Only quetiapine, again, in combination with lithium or valproate, can actually prevent rapid cycling. So the value should be additionally given to lithium and sodium valproate, not to the antipsychotic. Then we talk about, like risperidone long-acting injectables. And this is also another drug which is extremely useful in preventing, rapid cycling. So for rapid cyclates, other than, aripiprazole, you can also consider long-acting risperidone. And I think if you look at the summary of what's available evidence so far, olanzapine, quetiapine, risperidone are shown to be superior to placebo. We all understand that. But as a monotherapy, only quetiapine was capable of, reducing the depressive episodes as comparable to lithium and valproate. But as an adjunct, all these drugs, if you add as an adjunct, they all serve the purpose. Whether aripiprazole as an adjunct, or quetiapine as an adjunct, ciprasidone as an adjunct, they're all capable of reducing the overall risk of relapses in the patients. Also, quetiapine can, both manic and depressive episodes can be prevented effectively if you add on with valproate and manic. Another advantage of atypical antipsychotic psychotics is in people who are pregnant. Pregnant women cannot be given mood stabilizers because many of these mood stabilizers have teratogenic side effects. So when pregnant women require some maintenance therapy, you need to be considering atypical antipsychotics. Because we have a low risk or no risk of teratogenesis, we know with the first generation antipsychotics is the safest because we have a 50-year data available with us. We all know anybody who has used the first generation antipsychotics like haloperidol, very safely you can use it during pregnancy. But unfortunately, they carry with them other side effects. So if you shift them to atypical antipsychotics, is there a risk? But generally speaking, the overall conclusion of all the research literature is no significant congenital abnormalities happen with atypical, antipsychotics because the risk is either low or no. But when we ought to warn you and say that the data that is available is very, very scarce. There's very little data available. You'll be surprised to find there's very little data available for us to conclude on it robustly. But we can say, more or less, we can say there is no risk for congenital malformations following the prenatal exposure to not only typical antipsychotic you're sure about, but also with atypical antipsychotic, with the exception of risperidone. Risperidone is one antipsychotic, you have to be a little bit careful. So this is one atypical antipsychotic I would want to prescribe to a pregnant woman because the risk for overall malformations is pretty big. If you look at 1.26 risk ratio with a confidence interval between 1 and 1.6 is actually pretty threatening. So we do not want to give risperidone to pregnant women because you can have overall malformations. If you look at cardiac malformations alone, again the risk is elevated, but the confidence interval crosses 1. So it's kind of yes and no. But you need to consider not using risperidone in pregnant women. Let's look at the recent evidence. So far, whatever I told is, like Lindstorm work of 2017. Even in 2020, there is a new emerging evidence. A lot more has been done in this year, and I think they published it. Kishi et al. In Molecular Psychiatry in 2020 published a fantastic one. This is a systematic review and a network meta-analysis that really looks at the efficacy and the safety of monotherapies and combination therapies with antipsychotics. And then they looked at mainly adult patients who have been treated with the antipsychotics during maintenance treatment. Their conclusion is very good. Most antipsychotics that we can use in practice are capable of reducing recurrence and relapse rate of any mood episode. So you're quite okay if you continue with an antipsychotic that you're used in the index episode quite successfully. You can do that. But look at this. Where is the evidence for some of these antipsychotics? Top in the list is asenapine. Surprisingly, in this country, asenapine has gone out of the market. It got introduced and found people not using it very well. I think the suboral hypothesia it produced, many people didn't like it, patients didn't like it, so people didn't use it very heavily. But there is a new emerging evidence to say asenapine may be an excellent drug as an antipsychotic in the prevention of recurrence of both mania, mixed as well as depressive episodes sometimes. So if you really look at asenapine, this is new emerging evidence which has not come so far. So asenapine, maybe people have to revisit asenapine and try and use it in bipolar disorder. Maybe we dispense of its use in people with a lived experience of schizophrenia. It's time. And another drug which stands out very well is aripiprazole once monthly. So these two drugs we need to really think, which has not come so far in the literature. The other drug is olanzapine. I talked a lot about olanzapine, risperidone, long-acting injections. These are the antipsychotics which will work for. Okay, but then asenapine and aripiprazole once monthly are two drugs we can consider. So the other one you will look at is, what is the drug that is useful in preventing depressive episode? In depressive episode, I think as a alone monotherapy, again asenapine followed by olanzapine is the most important drug. Olanzapine, we talked about it many times, but asenapine is another drug which is also can prevent depressive episodes, because there are many other antipsychotics don't do that. Olanzapine is the only drug, or quetiapine in combination does it, whereas asenapine is also capable of reducing the recurrence of both mania, mixed episode and depressive episode. Another drug that may be useful is aripiprazole, but in combination with valproate. Aripiprazole in combination with valproate stands out as the best combination in preventing depressive episode. If somebody comes off with depression again and again, often in a long history of bipolar disorder, people spend most time in depressive episodes than in manic episodes. If you think that's the one which is impairing individuals, and I think if you want to prevent that depressive episode, which is a big challenge, only lithium is capable of producing it robustly. Now, another agent you can add, you cannot lose lithium, is aripiprazole valproate combination. So, what is the reason evidence talking? The evidence is talking about asenapine as a very important drug because it's capable of reducing relapse rates of mania, hypomania, mixed episodes, as well as depression. And then, also I will talk about the discontinuation rates. Discontinuation really talks about a combination of, efficacy and tolerability. It's a measure of both tolerance and efficacy. If you look at discontinuation, any drug people don't discontinue over a period of time, which they are adhering to, probably a good drug. So discontinuation rate is very high with asenapine, despite this capability of producing oral hypothesia. I think many people don't discontinue with this medication. Long-acting aripiprazole is also very, very important in reducing not depressive episodes, but manic and hypomanic and mixed episodes. Again, we all agree that olanzapine and quetiapine things are again confirmed. Only result I want to emphasize here is those who love quetiapine, I want to warn them. If you look at the studies and conclude on quetiapine results are the only results which are to be interpreted with caution, because all the quetiapine studies are industry sponsored. Unlike other antipsychotics, many of them have not been industry sponsored, whereas all the quetiapine results are industry sponsored. So we have to take it with a pinch of salt. Second, all the quetiapine studies use an enrichment design. They don't use the typical, randomized control design model. In an enrichment model, it will increase the recruitment. To increase the enrollment, they will probably use other methods, which means, they will do a randomized control design and then look at the respondents, take only respondents and do the trial. So that kind of enrichment design is what is done in quetiapine. So we need to really interpret it with caution. So I will actually vote for the other drugs more importantly. So the recent evidence also points out to long-acting antipsychotics because they are better than oral antipsychotics. And I think aripiprazole valproate is another combination I want practitioners to think about. It's a good combination to use aripiprazole valproate. Okay. Now, where are we today? In 2020, if you look at it, people's prescription for antipsychotics had tremendously increased. We have an unpublished data from India, the paper which will be submitted by Dr. M.S. Reddy with many other Indian authors in this. We also looked at and say what mood stabilizers are being, prescribed in India for people with bipolar disorder in the long run. We were surprised it was antipsychotics. So it's not only in India, but also if you look at the Western world. I think in the Western world, in the US, for example, from 1997 to 2000, only about 2.4% of the outpatients were receiving antipsychotics as maintenance treatment. But you look at the number in 2013 and 16, the figure is about 51%. Half of the population of bipolar disorder patients on maintenance treatment are with antipsychotic medication. This is a huge shift that has happened in the US. So similarly, the mood stabilizer use has decreased from 97 to 2000 from 2/3 of the people, 62%, to just 1/4, about 26%. So there is a big shift. Many people practitioners are using less mood stabilizers, less of lithium, less of sodium valproate, and more of antipsychotics. Whatever. Is the reason good or not, we will commit to it. But you need to understand, you look at the atypical antipsychotics, we are called sometimes the second generation antipsychotics. We list them all in a big bag. We put them all in a loose bag and call them all as same. They're not the same. They have very many different potential when it comes to their biological action. I think it's very, very prudent for us to understand the mechanism of action of all these drugs and become familiar with that. Then you'll know why some drugs are acting better than the other drugs. For example, if you look at aripiprazole, useful in mania and mixed feature prevention, as well as acute phase treatment. And this is a drug which is a partial, agonist against D2, 5-HT1A, receptor antagonist at 5-HT2A. When you look at asenapine, which is a wonder drug in the recent evidence, mania, mixed feature, depression, everywhere you can use it. You look at the profile. The profile of the drug is very interesting because it's a receptor antagonist as 5-H2 and the receptor agonist at D2 and norepinephrine and also alpha-2. So it has a multimodal action which probably gives this advantage compared to many other drugs. You look at olanzapine. It's useful in mania, mixed features and depression. Look at the profile. It's a receptor antagonist as D2, 5-H2 receptor antagonist. And this is a very important one. Quetiapine immediate release. The extended release has not been investigated with trials and so they are not given approval for that. So mania, mixed features and depression in all the three you can use it. Again, it has got the receptor antagonist at D2 and 5-HT and receptor inhibition at norepinephrine. So they have a variety of functions that would probably be helpful for us to think through what are the ones beyond the dopaminergic antagonism that drugs are being helpful. Ciprasidone, again another drug which is probably not very well used, but is a useful drug. It can be comparable to asenapine in one way or other because it can be useful also in depressive episodes, excepting that it's QT prolongation is what worried people and then stopped it. It's also a drug that receptor antagonist to D2 and 5-HT1. So I think looking at the profile of these drugs, you probably conclude why some drugs are very useful only in mania mixed features, why some drugs could be useful in preventing depressive episodes. Okay. So what are the limitations? What are the cons of this atypical antipsychotics? Are we comfortable? Can we all prescribe atypical antipsychotics to people and be very comfortable? That's a question. Now, but even in 2020, if somebody asks any of us, we'll say, what is a gold standard drug for maintenance therapy of bipolar disorder? We close our eyes and say it's lithium, lithium, lithium. This has been a cornerstone treatment for maintenance treatment from 1960s. The first report appeared by Hartigan in 1963. After that, we started using lithium in the prophylaxis. Lithium, the only drug which has got an anti-suicidal property. You know that suicide is a big public health threat in bipolar disorder. You want to use a drug which is also anti-suicidal. No other drug has this property excepting lithium. Lithium prevents both mania and depressive episodes better than any other monotherapy that you know of. So lithium is still the gold standard drug. Whatever be it, I would actually think this is the best drug at this point in time. So are we going to replace a gold standard drug suddenly just because antipsychotics have been prescribed widely by so many people? Now, you look at the database of about 500 people in UK who have been on olanzapine, quetiapine, lithium, sodium valproate monotherapy for a long period of time. This Arthur Hayes has actually followed this people for a long period of time. He found the longest time to failure for lithium is lithium. So people on lithium, they don't relapse. They take a longer period it takes an average of only 2 years. Whereas the time duration is less than 1 year for quetiapine or for valproate or 1.13 years for olanzapine. So I think still the evidence is pointing out to gold standard lithium. And recent evidence, Professor Molly from Australia is talking about the neuroprotective effects of lithium too. So that's also another added advantage we're talking about. So lithium is still the gold standard drug for using maintenance therapy. So that's a disadvantage with the atypical antipsychotics. Another big disadvantage with the atypical antipsychotics, when I talked about it, I repeatedly said antipsychotics are useful in the maintenance treatment if they're useful in the index case, but preventing mania and mixed episodes is possible. Preventing depressive episodes is not possible for many antipsychotics. Exceptions are quetiapine and olanzapine, and perhaps azinapine. Also, we do know in some cases, you cannot prescribe sodium valproate or lithium, and then it may be, you find this drug may be more efficacious than these drugs. And you might have more adverse effects when you give long-term, antipsychotic. That's the biggest worry for us. It's not a drug that comes without any, baggage. Look at the mortality rate. This is a very striking one. This data was called out from a person who originally originated from Andhra, Belli Rao, and he has settled in the US. He has published a paper. He talked about the, mortality rate of different drugs. The mortality is the highest for olanzapine. Risperidone. The green one is the risperidone. That's one of the reasons why it's not been given approval by FDA now. Risperidone has the highest mortality rate, followed by olanzapine in the violet, followed by, red one, which is quetiapine. So, compared to valproate, in the mortality risk, atypical antipsychotics have a higher mortality. So this is something one should be warned about. This is not very comfortable when you look at the picture like this. If you give long-term treatment, you're going to lose your patients. People are going to die of this, particularly when you give drugs like risperidone, olanzapine in the long run, including quetiapine. Okay. And then, can they produce extrapyramidal symptoms? Bipolar disorder itself is considered as a risk factor for developing extrapyramidal symptoms, but this is a little bit inconclusive. A lot of clinicians will very firmly believe, I forward believe that, compared to people with the lived experience of schizophrenia, people with the lived experience of bipolar disorder, when they receive an antipsychotic, they are more likely to develop extrapyramidal symptoms. This is my belief, but it is still not tested to such robust conclusions. It's more of clinical observation. Risk greatly increased for overall EPS for risperidone. For risperidone, the number needed to harm is only 5. The number needed for anticholinergic use is 5 for risperidone. So that's a big risk. When it comes to risperidone, the number needed to harm with EPS is 11, but anticholinergic use is 5. Akathisia, for aripiprazole, number needed is only 9. If you treat 9 people, at least one of them will develop akathisia. So EPS in quetiapine related bipolar depression may be 19, maybe the only drug which has a less potential for EPS, quetiapine. Hyperprolactinemia is another important one. Of all the antipsychotics that are there, aripiprazole and quetiapine have the most favorable profile with regard to hyperprolactinemia. Whereas amisulpride, risperidone, and paliperidone, if you use them in the long term, you certainly are going to have problems with hyperprolactinemia, particularly in women, and when you start giving it, they have complaints of so many kinds. So we have to be very, very clear about hyperprolactinemia. It's a big challenge. And I think this can really cause, many people argued and say, these people already had an established hyperprolactinemia even before that. But then I think we know new onset hyperprolactinemia has also occurred in many of these individuals. Because there's literature which talks about hyperprolactinemia in drug-naive people with lived experience of bipolar disorder and schizophrenia. So, but then it can produce new onset hyperprolactinemia. I think drugs like clozapine, equivalent to azinapine and iloperidone, ciprasidone, olanzapine, equivalent to lurasidone, they also have a little bit of elevation. The best is aripiprazole and quetiapine. Most of these are related to dose dependent. You reduce the dose, you might have an advantage with that. Okay. But then, relatively small dose of amisulpride, risperidone, and paliperidone can also produce a profound effect on the hyperprolactinemia level. So when you are giving these 3 drugs as a maintenance treatment, you should be really, really warned. You should be very careful about it. We have burnt our fingers many times with these drugs. People have asked our uncomfortable questions. So PR levels, prolactin levels in antipsychotics have a minimal effect, particularly, they don't remain change over a period of time with quetiapine. They even reduce in aripiprazole. So if you want to really use a drug where you suspect hyperprolactinemia has a good potential, I think use aripiprazole. Because over a period of time, it actually reduces the prolactin level. You know the mechanisms? It's due to the affinity for the dopamine 2 receptors in the anterior pituitary lactotropes. And also it depends on the blood barrier, like penetrating ability of the drug. So if you look at the second generation drug side effects, you really look at, it's not just extrapyramidal symptoms, it's also akathisia, it's weight gain. If you look at weight gain as anything greater than 7% weight gain, number of drugs can produce weight gain, notably drugs like clozapine, olanzapine, risperidone. Hypertriglyceridemia is another important thing. You need to watch for the lipid profile. You need to watch for the cholesterol, hypercholesterolemia. You need to also look at, sedation is a very important side effect in them, and somnolence, daytime somnolence, which is very high with drugs like olanzapine. These are the most threatening things when you look at, again, an Indian author, Pillai, in Guardian Journal of Psychiatry, recently looked and said, these are the things that happens when you give them over a long period of time. This is people who have been on bipolar disorder maintenance for a long period of time. These are the various things that they have come across. So, if you look at drug safety, one drug that may be very favorable may be aripiprazole. Aripiprazole may be having a relatively better tolerability profile. It's associated with less weight gain, less dyslipidemia, less new onset of diabetes, and hyperprolactinemia. So, compared to many second generation antipsychotics, aripiprazole has a reduced propensity for extrapyramidal symptoms, barring akathisia. Akathisia is one thing that we warned about. It has got a better cardiovascular safety too. So Dr. Punus talked about how important to evaluate the heart in many of these people, particularly given that they have a multi-system disorder. Maybe preferring a drug like aripiprazole may be very important. If you look at all-cause discontinuation, this is the measure, as I said, of tolerability and efficacy, which really tells you which drug or many people are likely to, carry on. I think as a monotherapy, it's olanzapine. It's olanzapine. People love olanzapine and will continue with olanzapine. Acinapine and quetiapine are the drugs as a monotherapy they are most likely to continue, along with aripiprazole once monthly or risperidone long-acting. So these are the good drugs. They'll continue forever. If you look at combination, I think the combination with the antipsychotic is aripiprazole-lamotrigine combination. Again, you combine aripiprazole-lamotrigine, people don't discontinue it so easily. So I think that needs to continue with these drugs in your mind, whereas adherence will be better. The discontinuation purely due to adverse effects is very less in acinapine, lamotrigine. These are the drugs. If you look at only the antipsychotics, acinapine, quetiapine, and paliperidone are long-acting injections. These are the drugs which cause less adverse effects, and so people won't leave it in a maintenance treatment. These are the data coming from 2020. So what are the various things you should consider when somebody is having a non-adherence? There are factors which are common to all psychosis, like levels of education, poor insight, cognitive impairment, substance use, poor therapeutic alliance with the therapist, barriers to treatment. They're all common. But very specifically, if you look at the non-adherence in bipolar disorder, is the presence of psychotic symptoms, the high severity of depressive symptoms, rapid cycling, high affective morbidity, comorbidity with other conditions, as I said, very common with anxiety, OCD, adverse effects like weight gain and cognitive impairment, longer duration of episodes, suicidal attempts. These are the ones which will definitely interfere with non-adherence. You should also consider that and treat that. Particularly since we are starting to give to a lot of younger people, adolescents and younger people. Young children and adolescents are also receiving antipsychotics these days. And what happens to these individuals? The long-term treatment with these antipsychotics can produce potentially very impairing things for the people. For example, after 24 months, 2 years of treatment with any kind of an antipsychotic, the mean weight gain is very much poor. It's undesirable. The fasting glucose levels go by 0.29 millimoles per liter. The impaired fasting glucose is about 10%, 9.4%. The incidence of overweight is about 22%, 23%. And that means 1/4 of the people who are taking this medication are going to become, overweight. BMI scores will shift in about 10% of the people. Diabetes, even at that age, young age, will occur in 3% of the individuals. So we are really liable if you really put them on long-term medications without thinking about these side effects. So we should also be warned about what will happen to younger people, adolescents, when you start giving them maintenance treatment for a long period of time. You should be warned, at least educate them on the side effects. What do you do with them? should not prescribe. I think we should educate them. We should make them aware that these kind of things could happen to young people in particular. So we should keep screening and monitoring these people appropriately, provide them psychoeducation. You should have, like a weight control program in your clinic. As you put them on a patient, you should regularly monitor weight. And I think we should suggest healthy nutrition, increase their physical activity, encourage them to join a gym and go for a walk, definitely. And we are going to prescribe anything for the medication to treat the obesity or fasting blood sugar or anything. You should also look at the potential interactions between atypical antipsychotics and these particular drugs and what would have the effect on the mood, will it worsen the condition or not. These are the things that should allude into. So what is really not known in terms of cons is also, we don't know whether we can combine antipsychotics, because in India we are very much wanting to combine one drug with the other. We'll combine olanzapine with the aripiprazole sometimes. We'll combine. Do they have any value? Do they have combining value of one drug with the other? Excepting when somebody has an hyperprolactinemia, where one combines that antipsychotic which cost it, like a risperidone or a paliperidone or a, amisulpride with aripiprazole, combination of antipsychotics is not really encouraged, usually. But then I think that's Puritan value, but in the real world, we do combine drugs. The optimal duration of maintenance treatment is a very challenging question. People ask how long to continue the treatment. If anybody has the answer, I'll be very happy to know. I'll say as long as lithium should be given, we should also give it as antipsychotic. Then people say how long lithium should be given. That's a challenging question. For a long, long period of time is the answer I would like to give, looking at the number of episodes, the severity of episodes, the interval duration. So but then the duration is always longer. So the optimal duration of maintenance treatment has not been worked out. So I want to conclude by saying antipsychotic use have tremendously increased in the past decade as a monotherapy, or even more importantly as an adjunct therapy. Even though they are lumped together as one generation drugs like second generation, their pharmacological properties are varying. You have to look at the pharmacological variation and say which will be suitable for what. Atypical antipsychotics like aripiprazole, quetiapine, olanzapine, ciperidone, azinapine, they're all very efficacious in the maintenance therapy. We all can choose these drugs. But in the case of prevention of depressive episode, their effects are less pronounced, excepting for quetiapine and olanzapine. So when should we, I want to end by asking a very practical clinical question to the clinicians who are here. So when would we consider? At the end of the talk, one should not get confused and say, what am I supposed to do here? You talked about the efficacy of the drug. You said where it can be useful. Then also talked about the cons. Should I prescribe or not? Where are you leaving us? My take on that for that would be, for those people who are intolerant to lithium, are unable to adhere to lithium for whatever reasons. You can't prescribe lithium to everybody. Somebody is intolerant to it because of side effects, or somebody cannot adhere to lithium because of its side effects, or in the long run it produces some side effects and so they have to dispense away with that. So for those people who are intolerant to lithium, that's when I would consider antipsychotics. There are other people who are unwilling to consider lithium. I had a patient recently, when I suggested lithium, she said, I don't want to take lithium. I know my relatives who have taken lithium. It is stigmatizing. The moment I take lithium, people will know that I have a severe disorder. I don't want to consider lithium. So there are people who stigmatize lithium. They're unwilling to take lithium. And for those people, I think maintenance treatment with antipsychotic may seem to be proper. Lastly, I think those who cannot adhere to treatment with monotherapy of anything, I think I would consider long-acting injectables. It's not a bad choice to consider a long-acting injectable. At the moment, risperidone, which got a robust evidence, and in the future, when aripiprazole is available, I would consider those for those people who have adherence problems. Thank you so much. I'll be happy if there are questions. I'm very, very sorry that we have eaten up on your lunchtime a lot. I want to profusely thank Dr. Bhagirao and Dr. Ravishankar for agreeing to chair this session. Thank you so much, sirs.
Thank you, Suresh Kumar Garu, for your wonderful lecture about the very important topic. Actually, I was supposed to introduce you to the audience, but due to technical problem, I could not make it. Sorry for that. It's a wonderful lecture. And about regarding the questions, I don't have any question, but a compliment from Dr. Prasad Rao about it's a very great lecture as usual from Dr. Suresh Kumar. I got a question from me regarding the usage of what that you think more useful in the patients with the suicidal tendencies, especially like schizophrenia or recurrent suicidal episodes. What could be your choice of drug
Sir, not my choice, the world's choice, the evidence-based choice is lithium in preventing. It's the only drug which is having an anti-suicidal property for management of bipolar disorder. There is no other drug which is having an anti-suicidal property. There is a little bit of efficacy for clozapine having an anti-suicidal property in people with the lived experience of schizophrenia. I do not know whether somebody has actually looked at the data and examined the efficacy of clozapine in preventing suicidal thoughts and wishes and attempts in people with the lived experience of bipolar disorder. I haven't seen data relating to that. More robust data is available for lithium in suicide prevention. This is the only drug. This is a very robust evidence for that. I think this is a compelling evidence. That's one of the reasons we are all sticking on to lithium. Lithium is not only, like drug that can prevent mania, but also depression, and it can be anti-suicidal, it can be neuroprotective. And that's one of the reasons, like people who are working in the bipolar disorder group, like Professor Molly and all that, they vouch for lithium. I think they are right in stating that. But then there are unfortunate individuals who can't use that, lithium in everybody. And I think antipsychotics will be useful. Again, I would not want to dismiss away the age-old practice of using electroconvulsive therapy. I think suddenly we've become very stigmatizing towards electroconvulsive therapy. I do not know for what reasons. I think psychiatrists should be a little more bold in stating that I am happy to give electroconvulsive therapy in people who deserve it, because it is a life-saving procedure. To me, it is a cheap, cost-effective, and I think a most evidence-based treatment in controlling suicidal thought in any population, irrespective of somebody has a major depressive disorder, bipolar disorder, or with the lived experience of schizophrenia. It doesn't matter. I think, to me, when somebody has a suicidal expression and they attempted suicide, ECT comes to my mind. Maybe I'm very traditional, I'm old. Younger people will say, my God, my younger residents work with me, say, sir, you want to consider ECT straight away, sir? Shall we not do this? Shall we not do this? Can we consider ketamine? Yes, ketamine is a good boy, I understand. But I think he's a weaker fellow compared to ECT. I will want to, not have any chance with this person when somebody is talking about suicide. Because our life is to save lives. So to save lives, I will resort to ECT, no matter what this, thinks about. I will convince the relatives. I will convince the relatives for a modified ECT.
Thank you, sir, for the wonderful answer. I got 2 or 3 questions there is a question from Dr. Suresh. I wish to know, as most maintenance, you had only 2 years data. Or you take something like that you was telling?
Absolutely right. The trial data lasting for 2 years. That is a big thing. If you are engaged in a trial, in any case, you will understand it's not easy to, follow up people for 2 years. So you will have to look at the cohort data, real world data. That's what is happening now. This enrichment designs that people have worked out now is very helpful, because actually you can recruit people from the clinic in the real world patients, and then, you have to de-identify the data. All you need to do is to de-identify data. If Asha Hospital is collecting data, if Simon Hospital is collecting data, if Government Hospital is collecting data, we all collect data, we put them on patients, but we don't use it. Somebody takes and analyzes the data, de-identifying the patient identifier information, and only look at the information and say, what has happened to people over a period of time? We will be really, really informed about many things. I think that's the way forward. So if you look at that real world data, I think, rich information will actually come, because the real practitioners, people like me would think that, certain drugs are more useful than the other drugs. If somebody asks me, where is the evidence? I will say, I have no evidence. I'm only coming from my evidence of whatever I have seen over, so many years. And I think that's really not very robust, but I think I can say that. For example, when
another question from, okay, sir, thank you, sir. There is another question from Dr. Narasimha Reddy. What is the usual dose of required for maintenance treatment with atypicals?
That's a very important question. That is a very important question. No clear guidelines on that. I think the clinician usually treats. You see, the logic is very simple. How would you manage any maintenance? There are controversies when it comes to depressive disorders. We have a management of saying that, maintenance has to be the same dose in which he has maintained with the acute dose. But when it comes to psychosis, we don't do that. We actually, have a reduced dose. With bipolar disorder, I think that's what we have been doing. We don't really aggressively manage the, interval period, right? When somebody has no symptom, no logic to treat him with the 20 milligram olanzapine. That's what he responded in acute phase. You don't want to give him, we are managing people with a small dose of olanzapine. I think you continue to give that. Same logic appears. So there are no guidelines. These are, like nascent areas. You see, please understand, it's only in 1995 we started examining the benefit of a maintenance therapy with atypical antipsychotics. So we're not past many years. We are pretty young in our, only now, I think the data is coming in. More people are using antipsychotics and the data will be examined and then the dosage range will be worked out. But there again, it will be worked out for average, not for a given patient. Given patient is, if Dr. Ravi Shankar is managing, he has the best wisdom to treat the patient and provide the dose required for him because he knows it better than the books.
Thank you, sir. One more question from Dr. Prasad Rao. Clozapine as an anti-suicide, you agree?
I just mentioned, I think there are people who definitely talk about clozapine in people with lived experience of schizophrenia and psychosis having an anti-suicidal property. They argue that's the only drug that has, but it's not replicated in the population of bipolar disorder. That's what I'm trying to say.
Thank you, sir. Thank you for the nice answers for the questions. Thank you very much. And now I hand over to the mic to Dr. Bhagyara garu. Sir, Dr. Bhagyara garu.
Sir, you have to unmute, sir.
Sir, please unmute, sir. Bhagirav, sir.
Sir, please unmute your mic, sir. Bhagirav, sir. Your mic is muted.
Hello.
Sir, you have muted your mic. Bhagirav, sir, you have muted your mic. Please unmute.
Pardon?
Yes, sir. Now you're able to hear.
Go ahead, sir. Go ahead, sir.
Yeah. Okay.
Sir, you unmuted again. You have to mute it again. So you have thank you, sir.
I am not able to hear properly.
Go ahead, sir.
So I think we close the session,
sir,
and pass on to the organizers for.
Thank you, sir.
Thank you,
Thank
sir.
you very much to all the organizers for the wonderful occasion they have given to us. Thank you.
Thank you, Suresh Kumar garu. We have literally missed you physically here.
Thank you, sir.
Thank you for giving an outstanding spellbound lecture, sir. Thank you. Thank you, Bhagyara garu and Ravi Shankar Pasin garu to conduct this lecture. Thank you.
Thank you, sir. Thank you for the
urgent for the
memento. Thank you for
The
the memento.
mementos have already been sent.
Yes, sir. I'm holding it. I hold the national peacock in my hand. Such a wonderful one. Thank you so much.
And nice way of receiving the memento prayer.
Yes, sir. I certainly appreciate
Thank
Dr. Uday Kumar
sir.
for all the hard work and the Nellore Mind Club doing this. Thank you.
Thank you for the memento. Thank you, sir. Thank you very much.
Thank you, three of you, sir. We'll adjourn for a small break of lunch. We'll come back soon. 2 o'clock. 2 p.m. we'll start again. Thank you.
Unmute చేస్తాను. Yeah.
Dr. Kota Suresh Kumar, sir, are you online? So please turn on your video.
Hello, good morning.
Video on.
Video.
We shall start with the next session, which is management of sexual side effects caused by psychotropic medications. We welcome Dr. N. Raju, sir, the President-elect of IPS, to come onto the dais. I also invite Dr. Kota Suresh Kumar, sir, and Dr. GVS Murthy, sir, as the chairperson, to join us online and preside over the session.
Good morning, thank you. This is Dr. Suresh. Good morning, Murthy sir.
Good morning, Dr. Suresh Kumar garu.
Good morning.
A few words about Dr. Kota Suresh Kumar, sir. He has finished his MBBS from Rangaraya Medical College and DPM from NIMHANS, Bangalore, and studied MD Psychiatry from PGI, Chandigarh. He is a consultant psychiatrist at Shravani Mental Health and De-Addiction Center in Guntur. He worked as a professor of psychiatry at NRI Medical College for 5 years, and he is currently working as the professor and HOD, Department of Psychiatry at Katuri Medical College, Guntur, since 3 years. His professional experiences are many. He has an article published in American and Archives Journal of Psychiatry and various state and national journals. He is a speaker at national and international conferences, also the quiz master at zonal and national conferences. He is the past president of Indian Psychiatry Society, AP State Branch, and the dean of IMA AP State Medical Specialties, and is involved in research in 2 international drug trials. Sir is popularizing psychiatry to the lay public by delivering public lectures, radio and TV programs, and is also responsible for de-addiction and student guidance clinics and teaching. We welcome you, sir. I also welcome Dr. GVS Murthy, sir. He has finished his MBBS from Andhra Medical College and DPM and DNB from NIMHANS. He's practicing as a consultant psychiatrist in Visakhapatnam for the last 22 years. His special interests are bipolar disorders and schizophrenia. We welcome you, sir, to preside over the session.
Thank you.
Thank
you. Dr. Suresh garu, unmute yourself, unmute.
Right, am I audible?
Right, audible.
Yes, sir. Shall I? So I'll just introduce sir, and you can read the biodata, Murthy sir.
Okay, sir, okay. I am very fortunate and happy to introduce our speaker today, Dr. N. Raju garu, who has been elected as a Vice President and President-elect this year for IPS. Congratulations, sir. And Dr. N. Raju garu, he did his MBBS from Andhra Medical College, and then he did his MD from CIP Ranchi. And he is currently holding a position as head of the psychiatry department at Gayatri Vidya Parishad, Visakhapatnam. And he's as I told you already, he's a vice president cum president-elect of IPS. And previously held several academic posts as a lecturer in CMC Vellore, and then a professor in HOD Department of Psychiatry in Andhra Medical College, and vice principal of Andhra Medical College, and medical superintendent and at Government Hospital for Mental Care in Visakhapatnam, and he was the honorary editor, secretary, and past president of Ips AP chapter, and he was the past honorary general secretary of Ips Saujam, and he hosted the Ips National Midterm CME, which was held in 2017 in Visakhapatnam. And he authored few papers and chapters, including the latest in Ips textbook of undergraduate psychiatry. And he is the editor of Monogram on OCD. We welcome you, Dr. N. Raj Garu. Over to Dr. Suresh Kumar.
Thank you, Mutkaru. It's an honor, really an honor to share our Vice President and President-elect Raju Garu's talk. As already introduced by my colleague Murthy Garu, Raju Garu is quite experienced in this. And the topic is very useful both for clinicians as well as for postgraduate students, especially management of sexual problems with the psychotropics. In fact, majority of our patients, they stop antipsychotic medications because of sexual side effects or fear of sexual side effects. This happens very frequently, and especially in cases of chronic schizophrenics where they need almost lifetime compliance or prolonged compliance of the antipsychotics. The people are afraid of these effects and stop the medication. So clinically it is also very useful for the practitioners, the topic that has been chosen, and also for the postgraduates what to select, which drug to be select when there are sexual side effects. The sexual side effects of psychotropics in both sexes, especially in females, it is mainly related to the menstrual problem, which Raju Garu will elaborate, especially menorrhagia or even menopause. One of the major problem of young females who have been on antipsychotics who develop amenorrhea, they are afraid of this amenorrhea because young females, especially unmarried or even married females, whether it is pregnancy, so all these things, questions haunt the patient. So we have to be very choosy in selection of antipsychotics, as well as we have to see withdrawing the medication or giving an alternate medication treating the problem, which Raju Garu would elaborate. And surprisingly, the country which has given a lot of knowledge about sex, they are very shy of sex. Our patients don't speak much about their sexual problems unless detailedly asked by us. So it is always imperative that once we are starting an antipsychotic or a psychotropic medication, patient should be given a caution that if he develops any sexual side effects, he should report immediately. Because majority of the people don't know that it could be secondary to the medication, or he might assume that because of the illness he is not having the sexual mood or potency. So we should explain to them that the sexual side effects can occur with these medications, and he should report to us early, and nothing to worry about the sexual side effects because majority are reversible, especially if in the early stage. So this type of knowledge has to be provided both to the patient as well as caregiver, so that they can bring the patient in the very early stage itself. And one of the side effects as far as the males are concerned, in addition to decreased erectile dysfunction, there is also predominantly in relation to ejaculatory problem, and that has to be dealt, and majority of the cases by reducing the medication or changing the medication will help these people. I think now I will leave it to our Professor Raju Garu to elaborate further how to choose the drug and how to treat the side effects. All things will be very crystal clearly mentioned by my colleague and our President-elect Raju Garu. Thank you, Raju Garu.
Thank you. Thank you, Dr. Suresh, and thank you, Dr. G.V.S. Murthy, for those beautiful words about me. And good afternoon, both on and offline viewers and friends. I'm sure all of you had a sumptuous lunch, and sex after lunch is something perhaps not especially in the afternoon. Maybe after dinner, it might be the one which we be looking forward to. But after lunch, I'm sure very few, maybe younger generation might be looking forward to. People of our age group, I think that would be the last on the list. But high on the list is the problems we have with sex, especially if you are older. After having the same wife and husband for so long, it would definitely be a problem. And let us see how best we can tackle it. Basically, I'm supposed to speak on psychotropics and their sexual side effects. We all know that we live with psychotropics. Psychotropics basically something like we have different types of drugs. We have quite an effective attackers if you take a football field or something, you have attacks with risperidone and olanzapines, whereas you have defenders like sertralins and citalopram, and of course you have that goalkeeper benzodiazepine saving everything you from every side effect which these attackers are likely to cause. Same is the case here in our psychiatry practice, where the drugs do have their good intentions, but unfortunately they create the problems too. So basically my talk would be on management, especially targeting the practitioners. Probably the people who are highly knowledgeable or keeping latest developments in this field could get disappointed with the basic things which I discussed, because what I believe is that today is basically targeting the general practitioner of psychiatry, not the hi-fi postgraduate or not a hi-fi researcher. So probably I will be managing mostly in a language which would be understandable by a common practitioner in psychiatry. Basically, before going into the details of the likely side effects which we have with these drugs, let us understand what really causes sex behavior. So by and large, the antipsychotics or antidepressants or any other drug which we use manipulate the chemicals and the functioning of the brain, and in result disturbing the sexual behavior. So the sexual behavior, basically we all know that it is an interplay between nerves, endocrine and genetic factors. But it doesn't mean that only biological factors play a role in each individual's sexual behavior. We do have, I'm sure, the cultural settings, that our own personalities, our own environment, the chances you get. I think we all know that, because most of us might be ruing, I had that opportunity to go with that boy, I had that opportunity to go with a girl, but somehow I couldn't do that. I couldn't finish the desire which I had. So basically this is what the multi-system interactions decide what type of sex behaviors we have. Basically, all of us, like any animal, has a sexual desire. That is the secret of any human being. Being a psychiatrist, being a cardiologist, is all what we created. But the basic instinct of any animal, including the humans, is hunger and sex. So sex is an important component of human behavior, or say animal behavior. So the desire is the presence of sexual thought, fantasies and motivations to engage in a sexual behavior in response to an internal or an external cues. Here, this is where the psychotropics are relevant here. It changes those internal cues. Obviously, the sexual behavior is expressed based on the external and internal cues. And in spite of the external cues, because people who take an antipsychotropic will have his internal milieu changed. That results in the disturbances in sexual behavior. So this is what I think all of us are aware of this cycle. This is sexual response cycle. This is one which Masters and Johnson had familiarized us all with. I'm sure everybody, I think it is a stark question for postgraduates. It has been repeatedly studied by the psychiatrists when they were doing it. Earlier, I think in our generation, we use it to practice also this Master-Johnson technique of treating sexual disorders. Either fortunately, unfortunately, it is almost not practiced now. by and large, especially after the advent of sildenafil, literally that technique of Master Johnson in erectile dysfunctions and sexual functions has come down considerably. But remember, still we hold on to the theory of sexual response cycle thanks to their explanation. I think they're in around 60s they have come out with this explanation, and even after 50 years we still hold this good. And if you see the excitement, this is how a sexual cycle goes. You have an excitement, then you have plateau, then orgasm. So these different chemicals are involved in each phase of this sexual response cycle, and our interest is which chemicals are involved, how drugs interfere this sexual response cycle. So then the sexual pleasure and sexual experience are the key components of any sexual cycle. Again here, why we are interested again here is that the psychotropics do interfere in this sexual pleasure cycle. After all, why we are involved in sex? For the pleasure. We all get pleasure out of a sexual activity. I think bearing children is a byproduct. We don't do sex just for getting children. Sex is we involve in sex because of pleasure. So this is where the psychotropics interfere. How the sexual gives pleasure is through reward system. So we now have what I can say is that triad of things. One, you have sex, then other you have pleasure, then you have reward system. This is exactly what the brain does. This is how brain acts, and this is where psychotropics create trouble to us. So you have excitement, orgasm, and resolution. As I said, if you take desire, basically it is related to either testosterone or an estrogen, depending on which sex we belong to. And in excitement, it is dopamine and acetylcholine nitric oxide, which creates either erection of penis in males or erection of nipples and secretions in both. Then you have serotonin and norepinephrine. Basically, dopaminergic system and serotonergic systems act in a different fashion. So here, ejaculation, emission, and contraction of vagina occurs. Again, we are interested in this table because our psychotropics are going to interfere with these neurotransmitters and chemicals, which again reflects our excitement, orgasm, and resolution. So again, as I said, just go through that. Desire is basically a fantasizing things, whereas excitement includes erection of penis, erection of nipples, or increased secretion of glands. Orgasm includes ejaculation and emission in male, and unfortunately, similar experience is not very evident in females. And resolution of, again, that is clearly demarcated in male, that is not the case with female. We are coming back to the reward system. Why I am interested in reward system is basically, as I said, I repeat, sex is basically a pleasure reward, an activity which results in reward of pleasure. So what are the methods or what are the mechanisms that are involved in getting this reward? This applies to any other pleasure activity, eating dosa, eating Nellore chapel pulso, whatever you do it, basically this reward system is involved, where you have a dopaminergic neurons, hypothalamus, amygdala, hippocampus, prefrontal cortex, ventral tegmental area, and opioid endocannabinoid system. Here the most important organ is ventral tegmental area. The moment you experience, I think you see that stimulus of pleasure seeking goes, this gets stimulated. And then comes into the picture the mesolimbic and mesocortical systems, where you have those dopamine receptors. So it releases dopamine, sends those signals, or you call it a dopaminergic stimulation, to different areas of the brain. So hippocampus does some work, amygdala does another work, you have nucleus accumbens in cortex does some other work. So basically, hippocampus is involved with something like memorizing things, whereas amygdala is physical activity controlling all these things it does, and you have prefrontal cortex as a planning. So once you do that, you have to plan something. I see good girl, a girl sees a good boy. So to do an sexual activity, you have to plan a lot of things. Even if it is your wife or husband, you have to plan things. You just can't say, and I want to have sex and want to have sex. So this planning and all is done by your prefrontal cortex. Whereas the memorizing things, that is where I think new memories create more interest. That's why we are more interested in other partner rather than in our own partners. So this is how the problems create. This is how the mechanism goes. So reward system is an important neuronal substrate as far as sexual activity is concerned. This is something what you have the human sexual behavior. You are talking about so all are involved here. Basically, the other parts are not as much important as I said before, because these are all the additional factors. Suppose if you take basal ganglia, you need coordination. You need thalamus, then your limbic system basically is involved. So pituitary is involved because all these hormones are released there, from there. So prefrontal cortex, amygdala, hippocampus. So these are the parts which are involved in human sexual behavior by and large. These are the same areas involved in the reward system. So whether it is sex or whether it is watching mobile or reading a newspaper, I think most of the wives complain, newspaper is your wife, not me. Reason being that the reward systems and the pleasure systems are stimulated more with the newspaper rather than with his wife. Of course, it would be a different story, a neighbor's wife. So then what we have are some chemical things which are, I think, to put everything in nutshell, desire related to testosterone levels in men, possibly increased by dopamine and decreased by prolactin. Same is the case with estrogens in women. Psychosocial context and conditioning significantly affect desire. Arousal influenced by testosterone in men, estrogen in women. That is what I said. Other potential mechanisms include, as I already repeated, this is only a gist of what I already said. Central dopamine stimulation, modulation, the cholinergic adrenergic balance, peripheral alpha-1 agonism, and nitric oxide pathways. Physical pathology such as hypertension and diabetes can have a significant effect. We'll come to these details later. Orgasm may be related to oxytocin. Again, we'll come back to this. Inhibition of orgasm may be caused by an increase in serotonin activity and raised prolactin as well as alpha-1 blockade. Because these are important because all psychotropics have an effect on every system which I have been mentioning. Prolactin is an important chemical for us, whereas serotonin activities and adrenergic activities are the basis of most of the psychotropic actions. So resolution occurs. So again, to put back the nutshell again, this is what I already mentioned. Whereas you have more important neurotransmitters, basically dopamine, serotonin, norepinephrine, and acetylcholine. Dopamine, stimulation of dopamine increases the desire, while blockade of dopaminergic system can increase prolactin, which again reduces our sexual interest. So the motivation, the reward, again it affects the reward system. It doesn't get the same reward, otherwise it would have got. When you come to the stimulation, serotonergic system, stimulation reduces norepinephrinergic and dopaminergic activity, resulting in a delayed ejaculation. Whereas 5-HT2C stimulation creates erection, so anything against that will get into a erectile dysfunction. Whereas 5-HT1A, it is related to stimulation. Coming to norepinephrine, you have arousal of norepinephrine. I think more of a emptying, it vascular action. So more the filling, better the erection. Lesser the filling, worse the erection. So that is what basic mechanism, peripheral mechanism of erection is. Fill up those penile sacs, and then when resolution happens, the filling gets defilled. So that is how it goes. Acetylcholine is involved with erection. So sexual dysfunction, what happens? So any reduction in either desire, libido, or arousal, or frequency of intercourse. So if they come down, we think that there is some sexual dysfunction. Or an undesirable delay or inability to achieve orgasm. So this is all common. I think not getting orgasm or delay in ejaculation, female not reaching the orgasmic state, this all can happen with psychotropics, the way in which I explained earlier the mechanism of sexual dysfunctions. So let us see what are the sexual disorders which we come across even otherwise. They have nothing to do with psychotropics, but in general, these are the common. This is not the classification which you see in ICD-10s and DSM-5s. It is more, as I said, I repeat, basically my talk is addressed to the general regular practitioner who doesn't understand, he is not bothered about DSM-5 or ICD-10 because basically he is practically more involved. So I think if you talk about mixed affective disorders or all those things, perhaps he is not much interested in those areas. Whereas if you see a practical way of looking at sexual disorders, we have hypoactive desires, whereas both in male and female, you have erectile disorder, premature ejaculation, delayed ejaculation, azoospermia, persistent genital anesthesia. These are the common male sexual disorders in clinical practice I am talking about. Again, you have poor nipple sensitivity, low vaginal lubrication, hypoorgasmic disorder, and persistent genital anesthesia, both places you have. So females, these are common sexual disorders we come across. This is again how frequently we see. This is, remember, these figures are quite, I would say, you don't know how much seriously you should take these figures. They are, I think, because different people use different scales, different screening methods, and on us, I think people say that only 10 to 15% of the people only report sexual disorders if you don't ask them, while the reporting goes up to 60 to 70% if you ask. So this is the question, because and also depend on type of scales which you use, the percentage differ. Whatever it is, let us have a rough figure of that. You have a prevalence rate of 30% in any sexual disorder in men, whereas 50% of that would be erectile dysfunction, whereas in a depression it goes up to 50%. Worsening happens if SSRIs or SNRIs are used. So in the females it goes up to almost 65%, whereas almost roughly you can say around 60% people do report sexual disorders if you use drugs on SSRIs or SNRIs. So as I said, history and clinical assessment is the basic. It is difficult for a regular practitioner to give a questionnaire, but only for the sake of finishing, I just put it. But your history and clinical assessment are the two most important aspects in deciding what the sexual difficulties you have. Just don't go by history alone. Some people tend to misrepresent their problem. Problem would be different, and what they have is different. Basically, I think if I remember a few years back, I had a doctor coming to me with erectile dysfunction. Then later on, we realized that after almost earlier we used to do this Master Johnson, almost 6 weeks or 8 weeks session, we realized that this problem is not with the male, the problem was with the female. She had vaginismus or something, so dilatation of the vagina and all cleared the problem. So we need to have a proper clinical assessment before jumping on to the history given by the partners. So both partners are important when you take a history. Just don't go with one partner and conclude something. Do ask the other partner. What are the sexual dysfunctions? Now you have iatrogenic versus idiopathic. Then you have mental illnesses, physical illnesses here, and also drug abuse. Basically, we should know that before starting the psychotropics itself, we need to understand that originally do they have any problem. That itself has to be cleared, because what happens is that mental illnesses themselves can cause sexual disturbances. If you don't inquire that before starting psychotropics itself, you are missing the bus. So basically, we should, because suppose if you have a patient with depression, patient with schizophrenia, you'd always have a sexual difficulties even before the drugs are started. Suppose they come out with that after 1 month after starting the drug, you do not know whether we should attribute that to the disease or we should attribute that to the drugs which you had given. So prior inquiry about the sexual difficulties before starting psychotropics themselves is an important lesson we all should know. Then about mental illness. Illnesses, as I said, I repeat again, that mental illness themselves can cause sexual difficulties. Even the treatment of mental illness can cause sexual difficulties. Today, that is the target of our discussion. Basically, psychotropics are used in treating mental illness. So we are now interested in what are the sexual difficulties and how to manage those sexual difficulties. So mental illness, you have to exclude mental illness, which could have become important question would be the duration of the sexual difficulties. If it started before the starting of the illness itself, then most probably that was due to the illness itself. It started after the psychotropics which we prescribed, perhaps we should attribute that to the drugs which we have given. Same is the case with physical illness. One, the physical disorders themselves can cause sexual difficulties. The many drugs which use for physical illness also can cause sexual difficulties. Again, here our knowledge is very, very important to know whether those drugs would have caused these sexual difficulties. Important because people are referred to us, and when we realize that they are on some antihypertensives, they are on antidiuretics, they are on some other drugs which are responsible for these sexual difficulties. Remember, all drugs interfere with the chemicals which we already mentioned. So if you see antihypertensives, most of them work on adrenergic systems, most of them work on serotonergic systems. So any drug which can cause a sexual difficulty has to be mentioned, and we have to find out the proper answer for that. So not only illness, the drugs used for those illnesses can cause sexual difficulties. And the most important area where we again have to deal with is drug abuse. Many drugs can cause sexual difficulties. Importantly, we all know king of all drugs, alcohol. Alcohol is one of the worst chemicals which can create problems as far as sexual activity is concerned. Added to that, you have other drugs, drug abuse, substances of drug abuse, including, I think, common thing in our area is ganja, and again nicotine, and of course we are not very fortunate to have other cocaines and all, but you have these drugs, and the combination of drugs is worse. Suppose alcohol alone or ganja alone, a combined alcohol with ganja, it seems, have a bigger role in causing sexual dysfunction. So we need to understand all that before going into the management. Let us see what are the drugs which we call. So psychotropics, again, this is no Stephen Stahl's classification. It is a simple practical classification dividing psychotropics into antidepressants, antipsychotics, mood stabilizers, anti-anxiety drugs, and others. Like we all use stimulants, Parkinson drugs. Mind you, all drugs cause sexual difficulties. Hardly there is an exception, except one or two. We will come to that a little later. All drugs cause sexual dysfunctions. The antidepressants, because I put antidepressants first because the importance of them has been very great of late. Till 90s, we were not much bothered about these sexual difficulties. Only after the advent of SSRIs, this has been a topic of great discussion. We started even inquiring about the sexual difficulties in our patients. Why it is important? Because, as I said, I think why they are important, because the very compliance will go down. If the patient has a sexual difficulty after starting the drug, so probably he may not use the drug which you had given. So compliance will be a big factor if the patient develops sexual dysfunction. So treatment dropouts will go up. Obviously, indirectly, the management of mental illness itself would become a big challenge. They relapse easily. They don't remit. So distress to the self and partner is obvious. So apart from that, the genetics and sexual side effects too are important. So that is why pharmacogenomics has come up quite high in nowadays. Earlier, we used to give drugs and just not bothered about it. But even the psychotropics causing sexual dysfunction has some genetic basis. So D4 receptor polymorphism significantly contributes to differences in libido, arousal, orgasm. Even SSRI-induced sexual dysfunction, why it happens in some, why it doesn't happen in some other reason could be some genotype. The details are still to be worked out. But remember, why all of us do not develop sexual dysfunction, whereas only 60% develop sexual dysfunction, in spite of the chemical being the same, reason being that their genetic predisposition or predilection. So sexual side effects are more frequent in men, sexual side effects are more severe in women. Spontaneous remission happens in 10%, and most common problems are delayed orgasm and ejaculation and decreased libido. Let us come back to that. So most incidence is around 50 to 75% with antidepressants. We all, as I repeatedly said, after the advent of SSRIs, we started looking for sexual dysfunctions more. Reduced desire, retarded orgasm, erectile dysfunction, these are all the list of sexual dysfunctions with all antidepressants. They are mostly with SSRIs, clomipramine, venlafaxine, whereas we have mixed results with duloxetine and desvenlafaxine. Either way, not much of research has gone into all the molecules, remember. But so because this information is only a case report, mostly case reports, remember that. We don't have any great surveys as far as these sexual dysfunctions are concerned. So least associated with mirtazapine, bupropion, agomelatine, macrolide, vilazodone, vortioxetine. Of all these drugs, I believe only mirtazapine is highly effective antidepressant. Rest are all, I think, I don't know what is the experience of a group, but rest drugs, we have not been, agomelatine has not been a very effective antidepressant. And so I think vortioxetine, the big halla is going on, and the cost of it itself could cause sexual dysfunction. So this is the problem with these drugs. So antidepressants with fewer serotonin effects tend to cause less. So serotonergic system seems to be the biggest villain as far as sexual dysfunctions are concerned. Depression itself can cause sexual problems, but sometimes it is difficult to differentiate. That's what we already discussed. So it is always important to try to get some idea of a person's sexual functioning prior to starting of the drug. Risk factors with antidepressants are old age, males, low education, unemployment, physical illness, multiple drugs. I really do not know why unemployment and low education has been put here. Probably they are aware, not being aware of that sexual function dysfunction can happen with this. So it could be the reason for that. So how do we manage? Most easiest way of managing is, best method is wait. Wait, because spontaneous recoveries are not uncommon. After a week or 10 days, some people do get recovered. If you can't wait, if you think low dose of antidepressants would be effective, then only reduce. If doesn't work, then add some other drug which can tackle the sexual dysfunction. Even if it doesn't work, then switch over to some other drug. Remember, switching is the last option because you may not know that there would be an effective antidepressant. Because once an individual responded to a particular antidepressant, it requires a heroic measure to shift over to some other drug. If you can find other methods of tackling sexual dysfunction, I think option would be to continue with the same antidepressant. Only when you fail on those, then switch over to that. Some people did suggest some non-pharmacological methods like acupuncture and CBT. I think they are there everywhere. Wherever you can't treat a disease, acupuncture comes in. So we do not know how much effective they are, but there are papers where they say that acupuncture did affect. But exercises before the sexual activity also, it seems, have some effect. The performance of the individual goes up if I have a half an hour exercise before going into sexual exercise. But it didn't have any effect on the post-sexual pleasure or orgasmic effect. So exercise does not have any effect on the orgasmic factor, whereas it does have a better effect on performance of the sexual performance. So as said, the last resort is adding on drugs. So what are these drugs? We have a big list, but most important, I will not read all of them. Important would be for us bupropion, buspirone, sildenafil. I think mirtazapine is missing here. Mirtazapine 2 is an important add-on drug. So basically, buspirone. So you have bupropion, whereas this is dopamine adrenergic effect. Usually, the SSRI induced dysfunction, it works, but the problem with it is that it can also cause sleep problems, concentration difficulties. We all know this again. So yohimbine and cyproheptadine are the last choices, whereas as add-on drugs. Importantly, we should concentrate on, as I said, bupropion, buspirone, sildenafil. Bromocriptine 2 is rarely used. These are what the drugs as far as antidepressants are concerned. Whereas coming to antipsychotics, we all now know that hyperprolactinemia due to blockade of D2 receptors in tuberoinfundibular pathway, muscarinic and alpha-adrenergic and serotonergic effects do contribute. In general, evidence suggests that newer prolactin-sparing antipsychotics are less likely to cause sexual dysfunction than older agents causing prolactin elevation. So, in general, our understanding is that older generation are worse as far as sexual dysfunctions are concerned, only exception being risperidone. Risperidone is equally problematic. So, this is high with first generation, low with second generation. Lurasidone seems to be the least causing drug, so most safest drug as far as sexual dysfunctions are concerned. As I said, second generation risperidone is an exception. Risperidone does cause sexual dysfunctions as badly as the first generation does. So it is right high on the list. So risperidone and traditional antipsychotics probably have highest incidence of sexual effects. And good thing is that olanzapine is one of the safest as far as sexual dysfunctions is concerned. So quetiapine is good, but unfortunately, I don't know again what is the experience of our audience. As an antipsychotic, it is not so much, if at all, it has to be used around 600 to 800 milligrams. By that time, again, your sex is down and out because you are very sleepy. Individual sleeps off. So where is the, in fact, one of the major complaints about the sexual side effects is that they do occur just because the drugs you gave them drowsiness. So his sexual desire, sexual performance, sexual interests have all gone with the sleep. So this is what the complaints are. So let us see what this first generation antipsychotic. I don't know how many new postgraduates know about phenothiazines, thiazolantines and haloperidol. I think if I ask my postgraduate, most of them don't answer this question at all. Phenothiazine, they can't give you the classification of older first generation antipsychotics. But anyway, and they're not using it either. So hyperprolactinemia, anticholinergic effects, thyroidism can reduce testosterone, priapism due to alpha-1 blockade. So this can happen with phenothiazine, whereas thiazolantines, arousal and orgasmic problems, haloperidol, same as haloperidol has an advantage that it has less anticholinergic side effects. Say if you come to the second generation, olanzapine, as I said, it is less due to lack of its effect on prolactin system. Very rarely can cause priapism. Good. Risperidone, potent elevator of prolactin, less anticholinergic effect, but high ejaculatory problems. So retrograde ejaculation can occur with risperidone. Sulpiride, again, most of us know it's quite a disturbing drug as far as prolactin is concerned. Especially even in females, I think we do get a lot of problems. Quetiapine seems to be good, but again, I have my reservations about its antipsychotic action itself. So then clozapine, again, another we should be happy about it is that low effect on prolactin, but again, the drowsiness itself can cause a problem as far as sexual dysfunction is concerned. And you have a hero here. Best performer in the entire band is aripiprazole. It seems to be low in prolactin, and also it's alpha-1 adrenergic system, so it doesn't cause. In fact, some people report that sexual function has gone up after using aripiprazole, even in normal humans. We don't know how much to rely on that. So add-on drugs are three drugs: aripiprazole, mirtazapine, and sildenafil is the add-on drugs. As for, again, remember, same principles here also follow. As far as adding a drug, before adding that, you have to try other things, including watch a drug holiday, then reducing the dose, especially after psychosis has come down. Perhaps you can think of reducing the dose to a minimum possible dosage for that. So then only you think of adding a drug, be it aripiprazole. Mirtazapine is effective. Remember, even for an antipsychotic induced sexual disorder, you have mirtazapine, very effective. Again, come to the mood stabilizers. Not highly well studied. Unfortunately, we don't have much information as far as mood stabilizers are concerned, but we know that anticonvulsant drugs like valproate and carbamazepine do cause sexual difficulties, especially reducing the testosterone level. So it reduces sex drive, and also it seems out of all anti-epileptics, probably lamotrigine seems to be the safest as far as sexual dysfunctions are concerned. So coming to the lithium, the most common drug which we use for as a mood stabilizer, you have case reports that lithium can reduce the libido. I think I'm running out of time. I just will go through the slides fast. So you have difficulty discriminate between drug side effect, phase of the disease, and a treatment effect, because remember, depressive disorders especially, and even in mania also, sexual desire goes up. But unfortunately, performance is not so much because of their poor attention and distractibilities. The performance may not be great. So their desire level will be very high. Anticonvulsants, already I told you about decreased libido, impaired arousal, then improved erectile function, epileptics on lamotrigine, that is what I said, seems to be the best drug. Carbamazepine increases serum hormone building globulin, thus decreases bioavailability of androgens. Oxcarbamazepine seems to be a better drug than carbamazepine as far as sexual dysfunctions are concerned. Again, coming to the anti-anxiety drugs, this is again a peculiar situation we have. When you take an anti-anxiety drug, sometimes it increases your sexual performance by the simple reason that it reduces the inhibition. The inhibition, initial anxiety, initial inhibition you have, that to start with, it might appear as if it increases sexual performance and sexual activities, but over a period of time, in the long run, erectile dysfunction starts. Then libido also comes down. Anorgasmia is benzodiazepine is reported, but not a common thing. But long run, it doesn't affect it. Same is the case with even alcohol. Alcohol also reduces the inhibition, reduces the inhibitory system. The production of dopamine will go high, and your performance would be better. But after a time, what happens is that all sexual dysfunctions start appearing. So the take-home messages are: sexual dysfunction is least inquired and rarely self-reported. All psychotropics have sexual effects which may lead to non-compliance. They're all good news about all this is mostly they're all reversible. And so importantly, you need a calculated risk as far as sexual dysfunctions are concerned. I'm sure, sorry for fast moving in the end. That is what happens when you're in a hurry in sex. So I think similar things may not be disastrous. So you need a good strategy to be a successful person in sexual activities. Thank you so much for your patient listening, and I hope you can have a good sleep after this.
We would like to thank Dr. N. Raju sir and Dr. Kota Suresh Kumar sir and Dr. GVS Murthy sir.
It was a nice presentation, Raju garu. Artipandu valchi andarki పెట్టేశారు మొత్తం పేజెస్ కి. Very understandable, very useful way. But once your slides, incidence and prevalence has been shown, it is really threatening to prescribe an antipsychotic with such high incidence of sexual side effects. Probably, as I mentioned earlier, and as you have also mentioned in your talk, the reporting of sexual side effects are minimal, and inquiry from the psychiatrist is also usually less. And we should encourage our postgraduate students from beginning to inquire about the sexual side effects. One question from Dr. GVS Murthy garu, co-chairperson, is what would the preference of antipsychotic for a 30-year-old newly married diabetic person? What would you start, sir? 30 years means probably a doctor. 30-year-old male, diabetic, schizophrenic. What is the first antipsychotic you would prefer, sir?
No, basically that's what we said. Olanzapine seems to be the best drug available to us. Which
Diabetes.
Sorry, I'm not getting the.
Non-diabetic.
Diabetes. Obviously, I think sexual side effects or already diabetes itself can cause sexual side effects. First, that's what we need to understand. And also, drugs used, don't blame I think the passion in the medical practice, non-psychiatrists, is that blame psychotropic whatever the individual gets it. So, the diabetic and anti-diabetics also ought to be inquired into before starting an antipsychotic itself. As I said, we do inquire about the sexual performance and if possible, rule out a sexual dysfunction before starting the antipsychotic. So aripiprazole seems to be a good drug, both for anti-diabetes and also not causing sexual dysfunction. So that could be the drug of choice even for most of us. If your schizophrenia has diabetes, I think aripiprazole would be the drug which we need to think about.
How about lurasidone, sir?
Lurasidone is, as I said again, as far as sexual dysfunctions are concerned, lurasidone is one drug which is quite promising. Again, the problem is that we are not very confident about its antipsychotic action, especially it has to be around 120 to 160 milligrams, which you can come out with EPS with that medication. And also cost is another big factor if you are using 140, 120 milligrams. But that is also a good choice as far as schizophrenia with diabetes is concerned.
Right, sir. When the sexual side effects are predominant and worrisome to the patient, I think even if it is hyperglycemia, we can control with the increase of the anti-hypoglycemic drugs or insulin and concentrate on the sexual side effects. That would be the ideal way in a young person, especially recently married. Ramesh Babu, sir. Any questions, sir, from Ramesh Babu? President, sir.
Unmute change.
Unmute change, sir.
One of my patients, he was doing very well on escitalopram, but he came back with problem of retrograde ejaculation. So how best I can treat this patient?
Hey, Balaji, you should come to my rescue.
Escitalopram having delayed ejaculation.
Retrograde
ejaculation.
I think already we discussed about it. I think basically you mean to say that escitalopram induced sexual dysfunctions.
Yes, yes. Especially retrograde orgasm.
Yeah, basically, as I said, the escitalopram is one of the drugs which is the worst as far as sexual dysfunctions is concerned. It is almost either equal or second or better than, worse than paroxetine. So basically, as I think we already mentioned about this, is that if you can wait for some time and see, that is one option which you have. or reduce the dose as in see if it is effective. Finally, if it doesn't work, I think add, if it is a male, if erectile dysfunction, maybe adding sildenafil, or if sleep disturbances are there, adding mirtazapine could be the method which we adopt if it is acetylcholine induced sexual dysfunctions.
Excellent talk. Congrats, Dr. Rajagaru. Excellent talk. Very informative talk.
So we have a feedback from Dr. Nagireddy sir from Kurnool. He says that even though amisulpride is a potent prolactin elevator, men are not complaining of more sexual side effects as we expected.
They're not there.
Yes.
But amisulpride is known to cause sexual side effects as much as may not be as bad as, because the advantage with amisulpride is that it is one prolactin elevator, true, but other drugs also have an action on both adrenergic systems and serotonergic systems, where amisulpride doesn't have so much on serotonergic system. That is one reason could be that amisulpride people may not report as much as they do with other drugs. Another advantage with amisulpride is that it doesn't cause drowsiness as much as other drugs cause. Reason again being that its effect on serotonergic system is not as much as we have with risperidone or we have with other antipsychotic drugs. This could be the reason for that little bit of better reporting as far as amisulpride is concerned.
Dr. Mohan Sunil sir, your experience, sir, your expert comments, sir.
I think very practical talks. I learned a lot through the session. In fact, the knowledge has to sink in for me to even ask any question. But I think, as he rightly mentioned, we hesitate to ask about sexual dysfunction in the patients. If we ask more, we get to learn more from the patients itself, which molecule works better and those things. So as Sir mentioned, bupropion is less utilized for sexual dysfunction. Mirtazapine is less utilized in sexual dysfunction. Vilazodone is less utilized for sexual dysfunction. So maybe these are molecules which we can consider in our routine clinical practices, sir.
Thank you, sir. Thank you.
Sir,
One have question here. Just, yeah.
Sir, from our side, can a hysterectomized woman get the same quality of orgasm when compared to her previous experience? Hysterectomy. After hysterectomy, what about the orgasm of the female? Is having the same quality as before?
I think basically hysterectomy should have nothing to do with orgasm or sexual function as such. If you see the mechanism of sexual system, hysterectomy should not, but you have, as I said, we can't go by just the brain, chemicals and those things alone. You have the social, psychological, cultural factors also involved. But as far as scientific explanation is concerned, I see no way hysterectomy can pose problems.
Sir, along with hysterectomy, the oophorectomy is also done actually.
Then obviously it will have some effect because of the, as we said, the estrogen, and this all depends on how the system has been damaged. So if you have the sex hormone problems there, probably they will have a relevant sexual dysfunction, isn't it? So,
one more observation with paroxetine, because the paroxetine, it is normal with some people. Those who are having high level of anxiety, they are not complaining of much sexual side effects, according to my experience. And fluoxetine is the best SSRI when compared to other, having less side effects. So your comments.
So basically, I think what I can understand is that suppose with the high level of anxiety, the sexual side effects are high themselves, the anxiety itself being causing. So once you have anxiety comes down with paroxetine, they will have a lot of relief. Basically, they feel, basically sex is, as we say, is not just a physical activity. We all tell our patients sex starts in the from a cup of tea itself in the morning. It doesn't start on the bed at 9 o'clock in the night. So your relaxed mind, a relaxed body, relaxed, pleasurable being. I think with paroxetine, if his mood gets elevated, obviously his sexual activity will go up. Whereas in a less anxious people, treating them is not easy. We are not too sure whether they are normal or anxious. So the effects also will be equally less perceptible if you have anxiety less.
Regarding mania, sir, the disinhibition itself looks like as they are having more desire, or really is there any increase in testosterone?
There will be an increased desire because basically it is a hyperenergic system. So we all talked about, again, yes, I want to tell you here one thing. Even though dopamine is implicated in pleasure, in desire, in drive, recent research says that we are not true. It seems that dopaminergic systems are fired even before thought of getting the reward is perceived. So that means dopamine is more involved in planning, in exclusion, in making a choice. I have 3 choices here. I pick up a choice which I want. So perhaps there dopamine has got a better role than the traditional teaching till yesterday. Till yesterday, I'm telling you, I still believe that I teach this only, but there is some rider here that dopamine system may not be the exact system as far as pleasure and reward is concerned. Anyway, that controversy I put away. Coming back to the question which you put, mania basically goes high everywhere. Everything is hyper. So obviously desire, sexual desire too goes up, and his grandiosity, his confidence also. I'm sure our own personal experiences, we lost a lot of opportunities because
Sir,
we were.
I am talking about research about testosterone in maniacs. I mean, is there any really high testosterone, or because of disinhibition?
No, I don't think we have any data to say that testosterone is high in mania. No. Anybody tells it, I don't know. To the best of my knowledge, no.
So, well explained, Rajagaru. One personal thing which I wanted to share was we come across a lot of sexual problems when we inquire with patients who are on psychotropic drugs. But majority of the cases doesn't require the sexual stimulants, the drugs which you have mentioned like alpha-stidil or sildenafil citrate. What I generally do is once I withdraw, I reduce the medication or change the medication. Majority of them respond. I think only a very minuscule percent needs this alpha-stidil or sildenafil citrate. What is your comment, sir?
No, basically, again, cultural factors play a lot of role. Basically, I think how many females would complain that the husband sexual performance has come down and they want it coming back to the normal, or the other way around. How many males, especially in our patient population? So, I think treating the primary condition itself is a troublesome thing for us, and adding some other for an effect which is not a priority of them. Especially suppose if you take a manic, the moment he becomes normal, they are happy, very happy that you look like a god. For a disturbing patient, you made him absolutely normal, and adding sexual dysfunction and then treating it. I don't think culturally we are tuned to such an extent that we add sildenafil to treat sexual dysfunction in a manic or a schizophrenic. So most probably the cultural, socio-cultural factors play a role in this. So yes, they do. People, I mean, we do have rarely where we need to add. But as you rightly said, situation may not be that we treat these dysfunctions adding drug now and then.
Thank you, sir. We have also another psychiatric icon, Dr. Bhagyarao, sir. Your personal experience or comments, sir. Bhagyarao, sir.
Thank you, sir, for your presentation. I would
Bhagyarao, sir,
request the
you can
second
share your
chairperson.
experiences.
Yes.
1 minute, Bhagyarao matter.
We frequently come across the sexual dysfunction in psychiatric patients who are on antipsychotics and other antidepressants. As Dr. Raju is telling, it is a multifactorial, not only just a physical problem, but at a psychological level, social level, at all levels there will be a problem. But I personally feel that giving a sildenafil has helped some people. So we should not have any idea against that. But as you also said, we can try to alter the medication which has a sexual side effects, like from a tricyclic or to going from to a SNRI, or some alteration we can make so that the drugs with sexual side effects can be altered.
Good, sir. Thank you very much.
Thank you, sir.
Organizing committee for giving me the opportunity to chair our President-elect session. And now I leave it to co-chairperson Dr. Murthy Garu to wind up the session. Dr. Murthy, sir.
Thank you, Dr. Suresh Kumar Garu. And I must thank Dr. Anand Raj Garu for his excellent presentation and very lucid explanations about how the psychotropics work in sexual dysfunction and what are the hormonal pathways which are involved in this. Nice presentation, sir. We are all very happy to listen, and we are happy to chair your session also. Thank you. And with this comments, I'll end this session. Thank you, sir.
Thank you, sir. I would like to request Dr. Gangadhar, sir, the senior most psychiatrist in Nellore, to hand over the momentum to Dr. N.N. Raju, sir.
Dr. N.N. Raju, we are really blessed of you being here, sir. You played the double role here as chief guest and speaker. Delivered very nice lecture.
Murthy Garu, మీ మొమెంటం కూడా పట్టుకోండి సార్. Display చేయండి.
Momento is on the way, sir. On the way.
It has reached us 3 days back.
Good.
Thank you, Kota Suresh Kumar Garu.
Thank you very much.
And GVS Murthy.
Thank you, sir. Thank
both of you for conducting this session excellently.
Right.
Thank you, both of you.
Thank you.
Thank you, Murthy Garu. Okay. Everybody, bye.
Now we move on to our next topic. It is about art of weaning psychotropic medications. And I invite our chairpersons, Dr. B. Ramesh Babu sir and Dr. G. Suresh Kumar sir, who will join us online. And also invite our speaker, Dr. Mohan Sunil Kumar sir, who will join us online. Welcome, sir. A brief on Dr. Ramesh Babu sir. Sir has done MBBS in Kurnool Medical College, DPM and SV Medical College, Tirupati. Worked as senior resident and prestigious CIP Ranchi in the departments of child psychiatry, EEG, and female psychiatry. Currently, sir is a chief consultant at Manasa Psychiatric Clinic in Kurnool. Currently, he is the president of IPS APSB, doing charity services through Avopa organization and also to blind school and old age home in Mets. Sir has worked as joint organizing secretary, treasurer, and organizing chairman during AP Secon 2000, 2007, and 2015 respectively. Served as executive member and general secretary in IPS AP State Branch and as vice president as well. Sir has areas of interest in child and adolescent psychiatry and substance use disorders. We welcome you, sir.
Thank you. Thank you.
A small brief on Dr. G. Suresh Kumar sir. Sir did his MBBS and BG from Andhra Medical College and DNB Psychiatry from National Board of Examinations and MBA in Human Resources Management from Andhra University. Currently, sir is Associate Professor of Department of Psychiatry in Andhra Medical College, Visakhapatnam and Honorary General Secretary, IPS South Zone. And past designations are Past President of Indian Psychiatric Society, AP State Branch, and IPS South Zone Representative to National IPS 2017 and 2020, and Vice President of Visakha Psychiatry Society. And sir's areas of interest are de-addiction and rehabilitation. We welcome you, sir.
Thank you, ma'am. Thank you for the nice introduction.
Very nice conference. I congratulate the organizers, Dr. Uday Kumar and his team, Dr. Ramesh Balaji, and chairman being Dr. T.P. Sudhakar sir. Actually, the team is very excellent. Red flags in psychopharmacology. They selected the topics just in sequence. Initially, the management of after mixed affective states, then psychotropics in psychosomatic illnesses, and then sexual side effects of psychotropics, then coming slowly to weaning of psychotropic medications. So it is excellent. They planned very nicely, very meticulously they planned. this weaning of psychotropic medication is very challenging, very critical decision in our day-to-day practice. Usually, in our day-to-day practice, all of our patients, they will ask from second visit itself, sir, how long I have to take these medications? But this question is very, very difficult to answer. It depends, weaning and tapering of psychotropic medication, it depends upon so many variables like nature of illness, then severity of the symptomatology, the inter-episodic interval, and the tolerance level of the patient of the side effects, and then coming to plasma half-life, elimination half-life, and the drug metabolism. Like that, so many factors. For example, paroxetine is there. Paroxetine has it leads to so many withdrawal features because of this auto-inhibition problem. That is, it depends upon that cytochrome P2D6 enzyme. So all these factors we have to take into consideration. In my clinical practice, though I have taken all the precautions, and considering that patient was totally all right for the last 1 to 2 years, for some of my patients whom I have tapered the medications, then slowly he came back with a severe relapse. So I was very guilty on those occasions. So all these factors now, I think, will be enlightened by our speaker, Dr. Mohan Sunil Kumar. Dr. G. Suresh Kumar will give introduction of Dr. Mohan Sunil Kumar.
Thank you, Ramesh Babu, for co-chairing this session. It's an important topic. I think it is a highlighting topic of today's entire pharmacology. Everyone has the dilemma to which drug is to be weaned. If it is, there is a non-professional colleagues are usually have the common myth and misconceptions about the drug that which has it is only a sleeping pill. How long you will have to continue? And this is the big dilemma. I think Dr. Mohan Sunil, today's speaker, went to wean these topics. He did his DPM and postgraduate from a prestigious institute in NIMHANS, and he is a recipient of Ramchandra Murthy Foundation Award, a fellowship in his in career. He is a fellow of Indian Psychiatric Society and Indian Association of Private Psychiatric Society. He is actively involved in teaching, training, digital breakthrough in the area of mental health, and the most important official positions as in the national and international association. As majority of the time, he is a multilinguistic person. He is conversed fluently in addition to his mother tongue, English, Hindi, and we are fortunate he knows Telugu and Tamil also. He is the co-creator of Helpy, India's first online community suicide gatekeeper. He is actively involved in teaching, training, and digital breakthrough in the area of mental health and in the areas of interest in the public mental health, neuroeconomics, use of technology in mental health space. Actually, he is the South Zone website committee chairman. He is meticulously doing his job. We are every time the updates and keep on the emails, whatever the South Zone, we are updating the social media, whatever he is up to date. He's in the way IPS South Zone, we are fortunate to have the website committee chairman, Dr. Mohan Sunil. In addition to most of the newer postgraduates are well aware that Dr. Mohan Sunil is he very lucid presentations through his presentation, the PG training, those who are undergoing NEET training, PG education, his lectures through via YouTube and books. He presented various topics, very clear, the very tough areas. He is very nicely elucidated. I am very fortunate to have these lectures. I had here 1 or 2 lectures in this. I think Mohan Sunil will do a nice job. I think I'll go ahead to the Mohan Sunil for his topic to proceed. Thank you, sir.
Thank you. Thank you, sir. Thank you. Yes, I am allowed to share the screen now. I'm sharing the screen. So I guess all of you can see a screen, right? With one single slide out. So can anybody confirm you're able to see one slide?
Yes, it is visible, sir. Visible.
Okay, sir. Thank you very much. So, without much ado, we are now 3:18 already. So, let's go ahead into the discussion. I'll try to finish quickly so that we'll have some discussions because I think we have to learn together here. I'll try to put a platform for that. If people are worried about the way you are practicing, and if you don't want to change the way you practice, I think you should not listen to this lecture because I am sure I will be forcing you to think differently after this lecture. I can guarantee you that much. That's something which is going to happen. So if you are not keen in changing the way you practice, maybe you should not listen to this lecture. This is a very unusual topic. I don't think you would have had people talking about this in any of the CMEs, where you're talking about how to remove medications. When you're talking about psychiatry, the perception we have is very simple. Can others unmute so that it is? Yeah, thank you. A psychiatrist is perceived to be a very different person. Psychiatrist is perceived to be somebody who is kind of specialist in mental health. But the reality is very different, right? How do they perceive psychiatrists? They perceive psychiatrists mostly as a pill pusher. They think, okay, if you go to a psychiatrist, he's going to prescribe some medicine, we are going to sleep fine. If I go to a psychiatrist, he's going to put me on medication. So most of the times, if we have seen, people don't meet us. And the reason they don't meet us is because they think we are going to prescribe medication and send them back home. And they also believe the medications are addictive. They believe the medications are only for sleep. They believe medications are sedatives. They also believe they'll become groggy, zombie. They will not be able to function. This is the reality of how a lot of times psychiatrists are perceived by the community. Unfortunately, some of us knowingly or unknowingly live up to this expectation also. That's the reality we all have to accept. And I think it is important for us to understand one simple point here. Before we talk about removing medications, I have no doubts to say there are beautiful, excellent, effective medications which are available for us, which can be really life-saving for a lot of individuals. There is no second thoughts about it. Medications have a very, very useful role to play. So it has to be used judiciously in many, many places. Second point I would like to make here is psychiatric illness is kind of a confluence of a lot of factors, things which we know, things which we don't know. But we all know as practitioners something. We know psychiatric illness is recurrent. We know psychiatric illnesses generally are relapsing in nature. It comes again and again. Psychiatric illnesses are quite resistant to treatment. Psychiatric illnesses are quite disabling. And of course, psychiatric illnesses are quite chronic. So we do know these factors. As practitioner, I'm sure we also know people who have psychiatric illnesses are more prone to have medical comorbidities. People who have a lot of medical comorbidities are more prone to have psychiatric illness. So this complicates the kind of patients whom we deal with on day-to-day practice. What is even more important for us to understand? The psychotropics can affect the illnesses in different ways. The psychotropics can also play a role in medical comorbidities. We know of antipsychotics causing a lot of metabolic toxicity, causing a lot of neurotoxicity. We know of antidepressants causing a lot of other weight gain and dyslipidemia and other issues, sexual dysfunction, the previous session which was discussed. So we know we are in midst of a lot of chaos around, where patients are also putting a lot of demand of, can I stop this medicine? From 5 medicines, can we make it 2 medicines? Can we stop this medicine? I've been taking it for 2 years. So we are going to constantly have these questions. So let me also ask you this question. Let's give about 10 seconds and ask yourself this question. Irrespective of whether a new practitioner or a seasoned practitioner, ask yourself this question. In the last 1 year, how frequently have you tapered and stopped medications in your patients? How many patients have you actually tapered and stopped the medication in the last 1 year? Ask yourself this question. Also ask this question, how many of our own patients in the last 1 year are on 3 or more medications? 3 or more psychotropic medications I'm talking about. If you ask this question, you will have an answer. And many, many times we know for the first question, how frequently we have tapered and stopped, irrespective of how big practitioner we are, we might be having only handful of people where we would have tried to even reduce and stop the medication. That's the reality. That's the reality we are dealing with. Have you wondered one more thing? Sometimes you don't need to, you might get a patient who comes in with a prescription. If you see the prescription, you can say who is the psychiatrist who would have written that prescription. By the way, they would have written some comic combinations. You can say, this is the psychiatrist. You will be able to guess, right? Have you noticed that patterns in us? What does it mean? So, knowingly or unknowingly, we have a method of prescription we develop. Now, is it effective? Is it efficient? Or is it the best way? We do not know. I think only when we ask questions, we start thinking differently. So when do we ask these kind of questions of even stopping medication? Like Dr. Ramesh in the introduction said, he stopped medication after about 2 years of maintenance and the patient was doing fine. Unfortunately, he had a recurrence. So we do think of stopping medications typically when patients are stable over a period of time, then we think about it. Or we think of stopping medications when there are some adverse effects or side effects and patients are constantly complaining, sir, weight gain, sir, weight gain, sir, weight gain, sir. So you think, okay, let me remove this medication. So you think about it. Or sometimes we also think of removing some of the medications when the patients become older. Why? Because as they become older, things change. So let me highlight to you the plight of old people who also get into mental illnesses. If you take older people, as they age and progress and they become older, you need to understand they start having a lot more comorbidities. Medical comorbidities, psychiatric comorbidities, neurological comorbidities, all of them start increasing as the age progresses. The number of drugs they are going to be on invariably increases. I'm not just talking about psychiatric drugs. The number of drugs they are going to be on otherwise also increases. They'll be on some anti-cholesterol medications. They'll be on some dyslipidemia medications. They'll be on some diabetic medicine. A lot of combinations, right? We also know as age progresses, pharmacokinetics can change. The renal functioning can come down. Their liver functioning can change. So all of this makes it quite difficult. So this is one place where we start thinking of, should we be reducing some medicines or are we loading this patient with too much of medications? My whole talk will be about asking yourself sometimes question, are we really giving more medicines or should we cut down some of these medications? If we try to cut down, what is the challenges we should expect and how should we be kind of able to address these challenges? That is what we are going to talk about. I'm sure we all know this symbol, right? This is the symbol for treatment. We put this and prescribe medications all the time. So for the first time, let me introduce a different symbol, which is mirror image to this. This symbol, which I'm introducing to you, the term for it is there, but the symbol was not there. But I got this idea. I thought I'll share it with you people out there because this is one of the best platforms of allied people in mental health. So I thought we'll use this thing. We can call this symbol as symbol for deep prescription. Now, what is deep prescription? We know what is prescription. Prescription is giving medication. Now, deep prescription is reversing that process where you reduce medicines, where you stop medicines, where you discontinue medicines. That's the whole point we are going to talk about in the next few slides. So when you're talking about deep prescription, a few interesting points we need to understand is, especially in elderly people, we have seen a lot of people in our practice who are taking proton pump inhibitors, some antacids for many, many, many years. They are just taking it. And if you ask them, why are you taking this? It's a gas problem. And they keep gulping and taking it. Nobody knows what can happen. In fact, over years, some studies do say proton pump inhibitors have its own negative effects. So it is good to discontinue and give holiday wherever it is possible. So proton pump inhibitors can be a quite good target for this prescription. There are a lot of studies now coming up to say whether patients need such long dosages of aspirin. Is it really preventing? People are questioning that. AC inhibitors have been put and never removed. Beta blockers have been put and never removed. Statins have been put and never removed. And now people are slowly asking, should we be just continuing it? Does it actually add advantage or not? These are questions which are being asked by bunch of deep prescribers. And a lot of this research is happening in elderly population and general medical condition, not much in psychiatry. One of the other areas where we'll be having this challenge of removing medications is tapering of anti-epileptics. A lot of our neurology friends and even some psychiatrists treat epilepsy conditions, right? Especially in rural population, because of lack of neurologists, they come to psychiatrists. So very commonly they'll come and say, sir, I've taken this medicine, no fits for last 3 years. Can I stop the medicine? I've taken this medicine for 5 years, no fits. Can I stop the medicine? So constantly they're going to bombard you with this question of stopping medication, and stopping medication. So we know we have our own experience. At least there, some interesting things we do is we get a EEG done. We see whether there are EEG changes or not. If EEG changes are there, we cannot stop medicine. EEG is absolutely normal. If structurally everything else is okay, you can think of slowly tapering and stopping after 3 to 5 years. That's what neurologists typically do. So that is, we can learn some lessons from them, how they do it. And we can also try to do similar things in psychiatry, where we are thinking of tapering and reducing medications. Commonly, some of the challenges we might have is antipsychotics and antidepressants need to be de-prescribed. So if you think of stopping medication, if you think of tapering of medication, immediately the first concern we have as a professional is, will this patient have a relapse or a recurrence? Is the question we have. But you also need to understand that doesn't end there. With antipsychotics, we have two other important concerns. If we continue medication, there is a challenge of neurotoxicity. If you continue the medication, there is a chance of metabolic toxicity. If you stop the medicine, there is a chance of relapse and recurrence. When you're talking about antidepressants, two specific concerns we can look at. Weight gain can be there when patients continue to keep on taking antidepressants, right? Sexual side effects, which was the whole session previously, right? So if you continue medication, you have challenge. If you stop the medication, you have a challenge. So you have to constantly be fighting out to ask yourself, will this patient have a relapse, or is there toxicity so much that I have to stop the medication? That's going to be a challenge, and you will never have a clear answer ever. If you look for clear-cut answer, okay, after 2 years you should stop this medicine, you will never get such a kind of guideline. But on a case-to-case basis, we have to take clinically healthy judgments. That is where I will show you some nuggets where how we can kind of try to take healthy judgments in helping these patients in deep prescription. Now, I have a simple question in head. What do you think is going to take more time? Prescribing medication or de-prescribing medication? If I have to prescribe medication, will it take more time? Or if I have to de-prescribe the medication, will it take more time? What do you think would be the answer? If you think about it, I'm sure you will understand one of the reasons we hesitate to stop a medication in a patient who is doing fine is because we are worried. He's anyways doing fine, he's not having complaints. We just write the prescription and send him back home. Now, if I try to stop the medicine, patients will always ask us questions. He will ask, okay, sir, if the problem comes back, what do I do? If the problem relapses, what do I do? Will I have recurrence? And unfortunately, we don't have concrete answers on that. So we know if we have to de-prescribe, we have to talk to the patient, convince the patient, get the patient on board. So de-prescription will always take more time than prescription. That's one of the challenges we will have. As a psychiatrist, when we are prescribing medications, we have three dilemmas to face. One, when we start medication, we should counsel patient why we should start the medication. Patients don't want to take medications, so you have to convince them, telling, see, this is the reason medications might be helpful and you should be taking medicine. Once they start medicine, we want them to be compliant because we don't want them to abruptly stop. So we have to constantly counsel them, telling, man, please take this medication regularly. So we have to constantly work with them. When they're doing fine and you think of de-prescribing the medication, again, you have to still counsel them, talk to them and say why you think it's a good idea to taper off and stop. So as a psychiatrist, our challenge never stops. Whether we start the medication, whether we are maintaining or whether we are de-prescribing. So our challenge as a psychiatrist will always remain, and the best interest of the patient should be the most important criteria on which we should take this decision. The challenge for the psychiatrist here is, at least for start and maintenance, there is a lot of evidence and guidelines. There is a lot of guidelines which says you should give medicine for so long, you should keep maintenance dosage, that this and all. So you feel quite strong and convinced. You are saying, okay, see, as per research, this is what it is. So you should take this much dosage, and you keep quiet for starting the medication and maintaining the medication. Moreover, when you are starting the medication and maintaining, patient also has distress, right? Patient is discomforted. He has severe anxiety, suicidal ideas, depression, other symptoms, and the family members are worried about his psychotic symptoms. So they all want treatment at that time. So it's easier for you to convince them and put them on medications. Relatively easy. But when you're going to de-prescribe, you have a big challenge. What is the challenge? First of all, patients would have got into a kind of a comfort zone. Patients would have got into some kind of an ease zone of taking medication for months, weeks, years together. Moreover, where is the evidence? Where is a guideline which says how to de-prescribe medication? If you see any guidelines, whether you are teaching depression guidelines, bipolar guidelines, schizophrenia guidelines, they're very vague. They say as long as possible, lifelong medication, especially I'm talking about recurrent illnesses, not one episode. I'm talking about recurrent illnesses. They say at least 2 to 5 years, as long as possible, like that. So this kind of vague descriptions and lack of evidence makes it quite a big challenge for us in the prescription. Getting it? So this is what makes us hesitate to think of tapering and stopping the medication. This is what makes it quite a challenge for us as professionals. Another important point we need to understand is, even though we are taught or we teach biopsychosocial model, as practitioners, sometimes we end up forgetting the whole biopsychosocial model. Like just in the previous session, multiple times, I think multiple times, Dr. Raju sir was actually emphasizing the fact that it is just not about chemicals, it's just not about medicine. A lot of other factors play a role. As practitioners in our busy practice, do we really think of all the aspects in a collective way? If you start thinking in a biopsychosocial model, then the option of de-prescription looks like a reality. Otherwise, we will never be thinking of stopping medication in any of the patients. And most importantly, the reason you should think of de-prescribing at some point of time in patients is also because it gives a great opportunity to get your patient to participate and take responsibility for his or her illness. It's a collaborative decision making. You as a psychiatrist cannot say you stop the medicine. You have to talk to the patient, convince them, make them understand the pros and cons. Once they are ready is when you can think of taking off the medication. So it needs a lot of collaborative decision making. Sometimes de-prescription is very easy. For example, if you have serious side effect, you don't think of whether I should continue medicine or not. First thing you do is stop the medicine. If patient is in toxicity, if patient is having serious life-threatening adverse events, you don't even think twice, you just de-prescribe, you stop the medication. So that's pretty easy for us. But life is never easy, right? So we have challenges. So let me keep it very easy for us to understand. I'm not going to talk about different illnesses, but I'll give you a context on which we can understand complexities and practice much better as clinicians. If you see illnesses, some illnesses are very episodic in nature. It comes, it goes. It comes, it goes. A simple example could be patients who have repeated panic attacks. They don't have much of any other problem, but they have very bad panic attacks which comes and goes off. In that patient, many times they might be okay to take an episodic treatment, like an SOS clonazepam. When they have a panic attack, they're okay to take. And this panic attacks, imagine, happens only 3 times in a month or only 2 times in 2 months' time. They're lucky enough that they can only take an SOS medication rather than be on regular medication. So that's a good idea for us to think of an episodic treatment rather than a continuous treatment process. Sometimes there are patients who have chronic symptoms, but you might need to consider daily medication, especially if the episodic condition is very frequent. If the panic attacks are happening twice a day, not 2 times a month, if so many panic attacks are happening and the patient is constantly suffering, you have to give some SSRI, small dosages, and those. You cannot only hope to give SOS medications. And in them, they might start abusing the medication if you give only SOS medication. So daily medications might become necessary. If the patients have chronic symptoms also, sometimes daily medications can become necessary. So this slide will give you an idea of asking yourself, what kind of problem am I dealing with? Am I dealing with the patient with an episodic problem, or am I dealing with a patient with a chronic problem? With an episodic problem, as a clinician, can I give medication only to treat episodes, or is the patient needing chronic medication? So asking ourselves these questions will help us to kind of help these patients in a much better way. Patient's preference is a very important aspect. Let me tell you one interesting point here. Let's imagine we have two patients who come, patient A and patient B. Now, patient A comes and says, sir, I'm not sleeping for last 3 months, sir. You do whatever you want, you give any medicine you want. I want to sleep nicely. Please give me some medication. This is one, patient A. Patient B is a patient who comes and says, sir, I'm not sleeping well for last 3 months, but I don't want you to give medication which will make me sedated through the day because I'm working. I don't want to be feeling zombie. I don't want to feel too sedated, but I want medication to be treated for my sleep. If given a choice to choose the patient, which patient would you choose? Would you choose the patient A to treat, or would you choose patient B to treat? Obviously, it is much easier for us to treat patient A because he gives us enough room for making error. He says, I want to sleep. Even if I sleep more, it's okay. Whereas patient B says, I want treatment, but this treatment should not affect my sleep more. It should not affect me. There are patients who come and when they talk to you itself, they come and say, I don't want a medicine which will make me sleepy. I don't want a medicine which will have sexual side effects. I don't want to take medicine which will cause weight gain. Imagine if he says all these three things, 90% of the psychiatry prescription drugs are out. What will we give is the question. And please understand, this kind of patients are increasing. Not even in rural population with all the YouTubes and other available resources now, even rural population, people come and ask you these questions. So it's not just the elite crowd, the other people are also going to ask these questions. So as young practitioners, we have to get ready to learn psychopharmacology as well as counseling these people and making them understand our real dilemmas. Where what we don't know, we need to say, this is something we don't know exactly, we need to give a try, and this is how we have to work towards. So when patient's preference is there, I always ask my patient, what do you want? Do you want your symptoms to get better, or side effects is your biggest concern, or you want the medicine to be very, very effective, or you are worried about taking long-term dosages or maintenance dosages and those things. So what is your concern? Are you worried about long-term medication? Are you worried about how much dosage, what dosage, effectiveness of the medication? Are you worried about side effect of the medication, or are you worried about symptom relief? What is your priority? I try to ask this question. And once I get an idea of what is their preference, then I try to bring in a molecule and talk to them and say, maybe this is a molecule which could be very helpful to you. This makes us give them what they want rather than give them what I want. Now, my idea is mostly to go with the patient's preference. If the patient's preference just doesn't suit, and if it is against I feel ethically the way I have to treat, then I have to say, no, this is the right way to treat. This is the medication you need to take. But many times you can actually kind of collaborate with the patient and make some sense and talk to them and get them to deal with it. Let me highlight an interesting point here. One of my patients who actually had schizophrenia symptoms was on risperidone. And when she was on risperidone, she actually had a lot of agitation, restlessness, and she was also taking a combination of propranolol and clonazepam to reduce the akathisia. She was on risperidone for her psychosis. She also was put on propranolol clonazepam combination to reduce the akathisia. After about 3 months, right, the patient came back and told, Doc, I don't like this risperidone. You please stop that. I'm okay. I love this propranolol and clonazepam. It is working nicely for me. Please continue this. Now, the patient doesn't realize I'm okay to stop propranolol and clonazepam, but I'm not okay to stop risperidone because that is the only treatment I think is needed. The risperidone was the only drug which was needed. Propranolol and clonazepam was added to treat the side effect of risperidone. But the patient says the patient wants to take this medicine, but not this medicine. I'm sure you will have these kind of dilemmas which comes in your practice. So these are kind of situations where we have to think of how to talk to the patient and put across and deal with it. So when you're thinking of de-prescribing, it's not a bad term. That see, the moment we are talking about stopping medicine, the first thought which comes to our mind is patient will become again suicidal, patient will develop schizophrenia symptoms again, will become depressed again. It can happen. It can happen. But de-prescription is not all about that. It is also about reducing side effects. It's also about reducing drug interactions if they're taking multiple medications, reducing finances. The cost of medication is huge for many of our patients. Many of our patients cannot afford, even if it is looking low for us, they cannot afford. So if you reduce even 5 rupees per day medication, it saves them a lot of finances, which makes them become compliant on other medications, which are very, very important for them to take. So that is why we need to consider the prescription sometimes. We can improve compliance. If patient has to take one medicine, the chances of them being compliant is going to be much higher rather than 7 medicines or 8 medicines. So increasing compliance could be a part of de-prescription. So de-prescription also increases engagement. You talk to your patient. You also give a hope that maybe you're getting better because they feel the number of prescriptions, the prescription is lighter. They feel much, much, much better to kind of deal with the scenario. Why I'm emphasizing this fact is because whenever we talk about stopping medicine, immediately we feel what will happen when the recurrence happens. See, please understand that is a possibility, but please understand there are a lot of other things which are important components of de-prescribing. You also have to look at other aspects, and this slide emphasizes on that. So when you're looking at de-prescribing, please understand 5 simple steps are required. You have to ask yourself, is it the right time for you to remove or reduce any medicine which is there on the prescription, whichever medicine it is, whether it is a physician who's treating or a psychiatrist who's treating? If you want to remove a medication, as simple as even a vitamin combination, if you want to remove it, is it the right time for you to remove? Is the first question. Second is get all the drug details, why it was given, from when it is being given, and what are the other medications which are being taken, so that you can actually decide which medication to be removed. Most importantly, discuss with the patient what is their preference out of the list. Many times when patients are on multiple psychotropics, I ask my patients, okay, out of all the medications you're taking, which is the medicine you hate the most, you don't want to take? Many of my patients say, sir, that lithium is there. No, sir, you please remove that lithium. I ask why. No, that lithium makes me very, very slow, sir. So I don't like that medicine. Now, in some patients, like recently one of my patients was manic, and lithium is the only drug which has kept him stable, and his impulsivity has come down significantly. I said to him, man, I really understand that I would love to remove lithium because you're asking me, but you need to understand one thing is, many medications were tried, nothing helped you as much as lithium. The moment you started lithium, I know you have become slower, but you have become less impulsive. You have stopped binge eating. You have stopped binge watching. You have stopped getting into unnecessary chat sites. You've got unnecessary sexual behaviors. You have stopped. Have you seen so much of help it also has created? Could we try to continue? Now, after a couple of discussions, he realized maybe that is the treatment and not a side effect of the medication in him. So because he has to realize why is he taking this medication. So sometimes we have to talk and discuss with these patients. We also have to choose out of the list which is the first drug we want to remove and which is the drug which patient is willing to remove, and plan and execute and start tapering off the medication. When you start tapering off the medication, if you read any guideline, no guideline will clearly say remove medications like that. Every pharmaceutical company person will come and meet you, will say, sir, first 1 week give 50 mg, sir. Next onwards make 100 mg, sir. No pharmaceutical company person will come and say, sir, this is how you have to remove this medicine, sir. From 100 mg make 75 mg, sir. Then make 50 mg. Nobody will talk to you about de-prescription. For a simple reason is because prescription adds market value. De-prescription does not add market value economically for them. But for the patients, it can be life-saving. It can be quite helpful. Sometimes it can change the quality of life better when you have reduced the number of medications which patients are taking. You have to take it into the context and deal with it. So when you're doing de-prescription, 2 important people are there. It's just not about you as a professional. We need to understand the prescriber and the patient. Both are very important. Both priorities have to be taken, and it has to be a shared decision making. It has to be a shared decision making. Otherwise, deep prescription will simply just not work. So next time, whenever you start prescribing a drug, when the prescription is being written, it's good to ask ourselves, what's the primary reason I am prescribing this particular medication in this patient? Why am I writing this particular drug? Is there any current side effects? What is the current effect or side effects which I'm looking at? And also looking at, if you're going to remove it, what is the reason for deep prescription and the expected challenges? These are all things which you should bring in the collaborative discussion. When you're talking to your patients, the reason why medication was given, what are the effects and side effects which are happening? Why are you thinking of deep prescribing or stopping the medication? And what are the expected challenges? Like, for example, if there is a possibility of recurrence, we need to talk to them about recurrence. And we need to say them how early they can come and meet us. You should train the family members telling, see, these are the signs of recurrence. If he's not sleeping well for a few days, bring him. Don't wait till he becomes very sick or very violent. So if you can talk to them much early about early warning signs and prepare them for a relapse, that's the best thing you could do. If a patient had been earlier suicidal, now no guarantee that patient will never become suicidal again. So you can always say, if you by chance become suicidal, don't wait, come and meet us immediately. And you also need to document why you have deprescribed, and you've also spoken about relapse and recurrence chances. So if you have done your homework, and if all these things are done, most of the times it's a collaborative decision. Patients then don't hold us for removing the medication because they know it's a collaborative decision. Unfortunately, some things didn't work for them. So deep prescribing is an engagement process. It's a support process. It's a realistic process. It needs a lot of insight. It needs insight and understanding between the prescriber and the patient. It needs an open discussion. It needs collaborative kind of discussion. If you do all these things, is when things work. I will talk to you about deep prescription, but before that, I will also highlight you something very important. There will always be some small percentage of our patients. All of us as psychiatrists know there are few patients of us. We know if that prescription goes to some other psychiatrist, that psychiatrist will laugh at us. He will wonder whether we are psychiatrists also, because the way we would have written some combinations, nobody else will write. So there will be some patients who will need unconventional needs. For example, there are a couple of my patients who are taking 60 mg of escitalopram. Now, say 60 mg of escitalopram is not given routinely, but that patient responded only on escitalopram. He tolerated escitalopram, and we went till 60 mg for him to be the best. Now, if you see that patient's prescription, you will wonder what Sunil knows. He doesn't seem to know psychiatry. There are some combinations. One of my patients is on zolpidem, 12.5 mg. Patient is on clonazepam, 2 mg. Patient is also on quetiapine 100 mg for sleep issues. Now this is because we have tried everything else on the earth possible. Nothing has helped the patient, and this is the ultimate combination. For last 2 years we have to continue. If you stop it, you reduce it, it is not working. On any textbook basis, on any other psychiatrist parameter, it will look, I am the most useless psychiatrist for it. But for that patient, it's life-saving. She's been doing absolutely fine for many years now. The point for you to understand is there will be unconventional patients who will need unusual drugs, unusual combinations sometimes, but this should not become the rule for all, but this should be the rule for minority, as small number as possible. That's what we need to look at. So let me highlight to you about few common psychiatric drugs and challenges which can happen as part of deep prescribing. If you're talking about antipsychotics, I will keep it in generic so that it's easy for us to understand. We should understand when you're tapering, stopping antipsychotics, we should look for 3 important rebounds. What are the 3 important rebounds you should look for? One is you should look for psychosis itself getting rebound or worsening. Second thing we should look for is cholinergic side effects. A lot of antipsychotics have anticholinergic property, and many times they are also giving triacylphenidal as a add-on, right? So when we remove antipsychotics, we also remove that many times. So as a load, cholinergic effect increases, that's another rebound which happens. Antipsychotics are anti-dopaminergic. So now when you stop antipsychotic, the dopaminergic activity becomes more. So rebound psychosis can happen, cholinergic symptoms can worsen, dopaminergic action can happen. What does it lead to? It leads to significant challenges. One of the important thing, especially about cholinergic side effects, is these three drugs which are very commonly prescribed by practitioners are culprits for causing rebound cholinergic side effects, which are the three: clozapine, olanzapine, and quetiapine. Clozapine, olanzapine, and quetiapine are three common drugs we prescribe and can cause rebound cholinergic side effects, especially when we are tapering and stopping off this medication. So how do you pick up this cholinergic side effects? Patients would be having restlessness, agitation, anxiety. Now the problem for us is we are psychiatrists, right? When we see patients restless, agitated, and anxious, immediately we think psychiatric problem, we hike up the dosage. It could just be a withdrawal symptom. It could just be a withdrawal symptom and a cholinergic load. So what you need to understand is, if it's a withdrawal symptom, if you again get him back on antipsychotic, maybe you will never be able to remove the medication. Maybe the patient has to be counseled that this is a withdrawal symptom. How will you get convinced that this restlessness, this agitation, this anxiety is withdrawal symptom and not primary problem? How will you get convinced? Who will tell you that? That is where it's a good idea to take a little more detailed history and ask them what are the problems they're facing. Patients also will have insomnia, increased sweating, rhinitis. There is a lot of cholinergic side effect which happens. Diarrhea, myalgia, nausea. So autonomic nervous system side effects. If the patient is having autonomic nervous system, then you get an idea, okay, it's not the psychosis which is worsening. It is possibly a withdrawal symptom, maybe because we are reducing the dosage. So I think it's important for us to talk to the patient and say a withdrawal symptom is very different from relapse or recurrence of the whole condition. A withdrawal symptom can happen, will happen most of the times. Whenever a psychotropic is given for 6 weeks and more, you should expect withdrawal symptom. So patient is not going to have an honeymoon time once you stop medication. He is going to find it little difficult, but you have to talk about the benefits and put it across. When you're talking about antidepressants, whenever antidepressants are continued 6 weeks or beyond, you need to expect patients developing withdrawal symptoms. It is good to prime patients about withdrawal symptoms and tell them they can have withdrawal symptoms. Also tell them abrupt stoppage of antidepressants, that too early stoppage can only impact the illness further and further, and explain them why they should not stop much early, and kind of prime them about potential withdrawal symptoms and impact on illnesses so that they don't stop off by themselves. When you're talking about withdrawal symptoms, two important culprit drugs you should remember in routine clinical practice is venlafaxine and paroxetine. Two drugs which are very difficult to remove would be venlafaxine and paroxetine, because patients have quite a bad amount of withdrawal symptoms. In fact, your patients will come and say, especially if you see patients on desvenlafaxine or venlafaxine will come and say, sir, one dosage if I miss, sir, I cannot tolerate, sir. Even half an hour late, I feel very uncomfortable, I take it. So they actually notice a lot of problems, especially with these two drugs. So when you're talking about withdrawal symptoms, it's a good idea for you to understand antidepressant withdrawal symptoms can be typically flu-like symptoms, irritability, insomnia, nausea, lethargy, anxiety, vividness of dreams, and all those activities. So a lot of non-specific symptoms typically happen with antidepressants. Now, the biggest challenge here is you will never be able to say whether it is the anxiety problem which is coming back again, or whether it is the depression which is coming back again, or it is a withdrawal symptom. It needs a lot of pros and cons discussion with the patient. You have to see why have you been reducing the medicine, and then take a decision based on the best clinical acumen you have. When you're talking about mood stabilizers, it's very clear. When you put a patient on a mood stabilizer, especially patient on lithium, first thing you should tell them is don't abruptly stop the medicine, even if you're better, because one thing is known very well. Mood stabilizers abruptly stopped worsens the bipolarity, cycling, and those, especially with lithium. So every patient who is on a mood stabilizer, especially on lithium, should be explained abrupt stoppage is completely no, until unless it's a medical serious condition where they have to stop the medication because of some lithium overdose or anything like that. Otherwise, abrupt stoppage is a complete no-no. It has to be slowly tapered and only stopped. And also, whenever we taper medications, it's a good idea for us to talk to patients. See, withdrawal can happen. That doesn't mean relapse. Withdrawal is different. Relapse is different. I am worried about relapse. I am not worried about withdrawal as a practitioner, because relapse means the patient has to come back on medication. Withdrawal is temporary. We can handle it for a few days, few weeks. If the patient can be helped through that time, they will be able to handle it. This drug, benzodiazepines, is one of the biggest challenges we'll have. We know many times we feel guilty of writing clonazepam or any other benzodiazepine on our patients. We know the patient might not be needing it, but we write it because the patient cannot stop it also. He finds it very difficult to stop. We are not able to kind of de-prescribe or reduce or stop the medication. There are so many of our patients who find it very difficult to stop it. It's very commonly prescribed. It has great amount of abuse potential. We know it has a lot of withdrawal symptoms. That's also something we know. When you're talking about benzodiazepine dependence, something very interesting which I would like to emphasize for practitioners, all of us to know, is some of us can be dependent on something called as a therapeutic dose dependence. Means what? We write 0.5 mg clonazepam or 0.25 mg clonazepam. It's a very small dosage. Patients don't become like other alcohol or other substance use. They don't take much higher dosages. They take whatever you have given, but they need that dosage. You stop it, they feel withdrawal symptoms, psychological, physical withdrawal symptoms start happening. So that is called as therapeutic dose dependence or a reliance which happens. So they will not abuse the drug, but they will continue at the therapeutic dose. The next, another interesting point I would like to make about benzodiazepines is there is something called a quasi-therapeutic dose abuse which can happen, dependence which can happen. What is this quasi-therapeutic dose? These are patients, they will, as you have prescribed 0.5 mg, that is what they will be taking. But suddenly some fight happens, 2 tablets, 3 tablets they will take. After a few days, they'll be taking the same dosage what you have prescribed. Suddenly some stress happens, 2-3 tablets on that day they'll take. So quasi-abuse means what? Little bit here and there they will abuse, but otherwise they'll be taking whatever therapeutically we have given. The other dependence which can happen in benzodiazepines is the intentional abuse people. These are people sometimes we see in clinical practice, right, who are taking 20 tablets of alprazolam, they're taking 20 tablets of diazepam, they're taking huge amounts of, this is as good as any other substance dependent people. So that is different population. So it's a good idea for you to ask yourself, if a patient is on benzodiazepine, is he on therapeutic dose dependence? Is he on quasi-therapeutic dose dependence? Is he on intentional abuse? If it is intentional abuse, you have to intervene and do something about it. It is quasi-therapeutic dose, counseling the patient, talking to the patient, you can at least get them to the therapeutic dose level. Once you get them to the therapeutic dose level, working with them on drug holidays and those might help. Okay. Now, this de-prescription challenge could be very high with the therapeutic dose and the quasi-therapeutic dose. Do you know one interesting point? Benzodiazepines looks like a very difficult treatment. A lot of people are dependent on alprazolam. A lot of physicians would have prescribed alprazolam, and when as psychiatrists we see they would be taking 0.5 mg or 0.25 mg for last 10 years, 5 years, whatever it is. You need to understand minimal intervention itself works. What is this minimal intervention itself works? Simple minimal intervention, empathetic, assertive communication. Listen to the patient why they are taking and very assertively tell them, it is not okay to take this medication and you have to stop the medication. If you assertively put it across and write it on a prescription, it is known to be many times effective. A lot of our patients actually reduce and stop it, or at least start thinking of tapering and stopping it, or start feeling guilty, oh my God, I'm taking, and they start thinking of getting away from medication. So minimal intervention itself works in benzodiazepines. Let's not lose heart. It's difficult to treat. It is sometimes quite possible to help these people. Systematic discontinuation is a strategy, especially with benzodiazepines. When you're trying to remove benzodiazepines, systematic discontinuation, step by step discontinuing over small dosages, 15-20%, you can reduce over two weeks, two weeks, slowly you can reduce in a way. This planned systematic discontinuation, the word planned is emphasized by me here because you have to talk to the patient, get them to understand and deal with it. Educate the patient why we need to taper and stop benzodiazepine. Taper and stop slowly, as slow as possible, and trying longer acting is one strategy which works. Now, of course, there is conflicting evidence. They say shorter acting drug like alprazolam or longer acting drug like diazepam works the same. But I personally think it is little easier for us to remove a longer acting drug rather than a shorter acting drug. So given a choice, I would consider prescribing medication like instead of alprazolam, I would ask physicians to prescribe clonazepam. The reason is because clonazepam might relatively be lesser abuse potential, and because of its little longer action. There is a way of planned systematic discontinuation which I use in my routine clinical practice. Now, since my practice is outpatient based, where I cannot do heroic things of stopping medication, admitting and seeing, one of the things which has helped me a lot in my clinical practice is patient-tailored reduction. What is patient-tailored reduction? I tell the patient, see, you're taking 0.5 mg of clonazepam. According to me, it has done its job. We should be tapering and stopping. You take 6 weeks to 8 weeks time. Take your time. Slowly reduce and stop the best way you can. Maybe 1 day in a week, make it half. Then 2 days in a week, make it half. Then 3 days in a week. I give some idea for them and allow them to play around. They themselves take their time and patient themselves slowly reduce it and stop it. The best part of it is they feel very nice about it when they come out of that medication. They feel very much in control of their own lives and the way they deal with it. So when you're talking, I'll just finish in few minutes so that we'll have some discussion which is possible. So managing withdrawal symptoms is something which is very important. Now I've put withdrawal symptoms in general, whether it is antidepressant, antipsychotic, because whenever you're handling withdrawal symptoms as a practitioner, for our clinical practice, it could be ask ourselves, okay, is the patient having mild withdrawal symptoms, moderate withdrawal symptoms, or severe withdrawal symptoms? If the patient is having mild withdrawal symptoms, don't go back to the medication. Sometimes reassure the patient and say, see, I've been taking this medicine for last 2 years. It's okay, relax. You don't have suicidal ideas. You don't have too much of sleep problems. It looks like you're a little anxious and restless. It could be just a withdrawal symptom. Let's wait and see. Now, sometimes reassurance, they settle down. They kind of actually don't need to get back to medication sometimes. If it is moderate, symptomatic treatments can work. If there is a lot of body pain and those, I consider sometimes giving patients simple paracetamol 650 mg works pretty well to reduce their myalgia, body pain, and those things. We also know emotional pain, sometimes paracetamol works. So what you need to understand is sometimes if it is symptomatic treatment requirement, you try symptomatic treatment rather than restarting the medication, because every time when you restart the medication without the real need of the medication, you will never be able to de-prescribe. Recently, one of our patients was on escitalopram for a long time. He had got into depression because of his alcohol-induced mood disorder, and unfortunately, his daughter had epilepsy, which was newly detected. So he had got into a depressive episode. We treated him for a very long time. He stopped alcohol for more than a year now, and his depression symptoms have not been there for the last 2 years. He slowly tapered and stopped escitalopram. Now, when he stopped it completely, he started having a little bit of giddiness feeling. I spoke to him. I said, do you want to go back to 5 mg of escitalopram and continue it for some more time and reduce and see? Or can we try something like, since you have just giddiness, we'll try some symptomatic anti-giddiness kind of medication like beta-histine. We gave SOS. We waited for 2 days, 3 days, it settled down. It has been more than 2 months now. He's not gotten back to escitalopram as of now. So why I'm giving you these tips is because there's no way, clear-cut method to handle these things. But you have to ask yourself what level of problem is there and how do you want to do. When it is severe withdrawal symptoms, then you have to ask yourself, do you want to reintroduce the medicine or do you want to symptomatically treat it? Kind of talk to the patient and then deal with this scenario. Now, I want to highlight a simple point. Why is deep prescription so difficult? Why is deep prescribing not discussed in CME so much as much as how to treat? We have 10 topics on how to treat, but very few topics on how to remove a medication. For a simple reason is because there is a gap in evidence. There is a lot of evidence for treatments, but there is a gap between treatment and deep prescribing. Nobody talks about stopping the medicine for a simple reason is because we don't systematically research these things. And as practitioners, we also have to accept some challenges we have. We have a trap of therapeutic illusion. We believe the prescription which we write helps these patients. We believe the medication I have prescribed helps these patients. The patient is today better because of my prescription. Is a kind of trap in therapeutic illusion, which can happen in some of us. Not all of us think like that, but some of us can think like that. And as a doctor, we want to err towards caution. A patient is tolerating the medicine well, it is costing very less. What is the worry? Let him take it. And patient is okay, we are okay, we keep refilling the prescription and continue it. And especially the erring with caution becomes even more higher as an outpatient practitioner. Because when I'm practicing outpatient, right, if the patient becomes sick, he's not going to come back to me. Second, he's going to badmouth me and say, oh, this doctor stopped the medicine. I went back sick. I got admitted in a hospital. So I'm in a worry that I don't want patients to badmouth me unnecessarily. So sometimes I say, okay, patient is not complaining. Let him take on medication. So these are also some reasons which can happen. See, I'm not telling all of us practice like that. Some of us unknowingly get into these traps. We should think about these things. How about this? Some of us are psychologically oriented. We would have spoken about countertransference. Let me highlight to you here. We have countertransference prescribing also, which happens. What is this countertransference prescribing? In therapy, countertransference. Countertransference prescribing is, there are some patients who sometimes will say, sir, you said I will sleep nicely. You gave me some medicine. I did not sleep 1 hour also. Then what do? Immediately in your head, you feel, okay, he has not slept. So let me give much higher dosage. So sometimes we dose him pretty stronger because he says he hasn't slept. So we try to challenge the patient sometimes. Family members come and say, sir, what, sir, we are coming to you. He's still agitated. He broke TV last week. So we want to, countertransference can be making our prescriptions much bigger. Until we don't ask these questions, we will never be able to think about it. So always think about these things. Please avoid abrupt stoppage of any medication unless it's an emergency where you have to stop the medication. And please understand, when you're trying to stop medicine, it's not easy because when patients have taken medication for longer than more than 6 weeks, there's a lot of psychological conditioning. They've been taking medicine every night or every day morning, so they have got with it. So it's good to learn to deal with the psychological conditioning also. How do you deal with psychological conditioning? You have to constantly talk to the patient and say, see, your improvement is because of biopsychosocial changes, not because of only prescription, because of the changes you brought in the social system, psychological changes, the therapy sessions you attend, the psychological makeup changes you have made. We try to emphasize the biopsychosocial model. Second thing is we try to kind of focus on self-efficacy. We try to tell the patient, these are the right things you are doing now, which has helped you. You have stopped drinking alcohol these days. It's helped your mood state. You have stopped smoking too much. It has helped your anxiety. So trying to build his self-efficacy will help him not to kind of become too dependent on medication. And also constantly prime him for a change. Tell them, see, I will be continuing medication. At some point of time, we can always talk about the need for stopping the medication. And also, say it is going to be a challenge if you try to stop medication. There will be some discomfort which can happen. Please remember, deep prescription failure, or when you try to taper and stop, if you fail or if there is a recurrence or a relapse, it doesn't mean it is a life sentence. You should never remove the medication. Sometimes after a few months, few years, depending on the context, you might need to consider deep prescription. So deep prescription failure doesn't mean don't deep prescribe never. You can retry with a different molecule, or you can retry with a different strategy at a later point of time when time arises. Always be careful about risk behaviors, suicidal behaviors, harm, and those. Be careful about recurrence, hospitalization need. Also look for response and preference when you're dealing with it. Now, when you're trying to do deep prescription, it is also important to emphasize the patients that it doesn't mean they don't need treatment or there is no treatment necessary. You're telling them why they don't need this particular medicine. That is what you are going to emphasize. And please understand, it is never easy as a practitioner because evidence to initiate medicines, lots are there. Evidence to de-prescribe, very few. I think I learned through this session, when I was preparing for this session, I learned many things for myself for the first time. I hope we have more discussions on this in many more CMEs and many more people talk about it and things will make a lot of difference. So the evidence has to change from evidence to initiate, evidence to de-prescribe should increase. So before we wind up, I would like to tell few important points here. One, next time before we prescribe any kind of medication, it's a good idea to be cautious. Ask ourselves, does this patient require the medication? Because before we start a medication, it's easy to stop. Because after we start, it's very difficult for us to stop the medication. So before we start, let's be cautious to think about it. I want us to develop, all of us to develop some kind of a prescribing inertia. Means what? Some kind of a, does the patient really require medication? No. When we develop this inertia, it will help not just us, it will help the quality of our practice, it will help the quality of the patients, and a lot of stigma against psychiatrists would also come down because patients realize we're not prescribers and we're not putting prescription just because some pharmaceutical company is asking us to prescribe. We are prescribing because there is a real need we think is there to prescribe. So please give permission to talk about medication. Tell the patient, if you have anything about the medication, don't stop it. Come back and talk to me. And I also ask them to come back and talk to you about alternatives they think which will work for them. Because when they come and talk to you, it is much better because you would have helped these people and addressed these people. So with this, I would come to end. I think I've taken about 57 minutes. 1 hour was allotted. I think 3 minutes we have saved. Thank you very much, sir.
Thank you, Mohan Sunil. It is a nice presentation.
Thank
We'll
you,
in any questions from the audience. I think we'll expect. I think it is very clear presentation. I think everyone has that problem from the patient point of view, or the caregiver point of view, or physician's point of view, or various other comorbidities issues you cannot taper. However, you can have a lot of anxiety towards the, as you are prescribing medicines. It is one thing how to taper and all. It is an individually tailored medication for each patient. Have choosing a patient is an individual tailored mechanism. We cannot say all, cannot generalize the issue as such. Sometimes the people in the, particularly in the COVID situation, the patient not turned up. They're continuing the medications, yes, all the over the year. They won't turn up. I am happy with the medication. We don't know what to do. They don't come and they don't ask. As you suggested, so many discussions over the patient wants to they just continue on his own, so that we have a lot of problems, where to taper, when to taper and all. Ultimately, they'll develop a tolerance or resistance, whatever you call, or withdrawal or something else. Now I request our co-chair person to discussion. I don't think have any questions, so I'll hand over the mic to Dr. Ramesh Babu. Unmute, sir, please unmute.
Thank you, Dr. Mohan Sunil Kumar, sir. Very excellent presentation. You dealt with a very nicely regarding de-prescription and its how to deal with different types of patients. As you said, de-prescription is very difficult than to prescription medicine prescribing. Actually, in my own practice, someone will ask the patient, you need this first episode, shorter duration illness, we need to take this medicine 1 or 2 years. After 1 or 2 years, he will come back. Sir, can I stop this medicine now? And then I will very panic what to tell to him. If I stop medicine, he may have a relapse. Then again he may question me. He asked me to stop medicine, I have a relapse. So he may question me. So for this deep discussion, it has to tell from patient to patient. Very nice we have dealt with this topic. Any questions I will see in the chat box.
I saw a question Dr. Nagireddy sir has asked on why don't we think since relapse is the or recurrence is the pattern, why don't we take it like hypertension or diabetes where lifelong medications are recommended? In fact, that's a very interesting question which is asked, but I would also recommend our fellow practitioners to actually go to internet and type deep prescription and read. A lot of now research is happening in diabetes, hypertension, dyslipidemia, and they are asking questions like, do we really need to continue lifelong medications there only? And it is not meaning stopping all the medicines. It is stopping unnecessary medicines or reducing the dosage of medicine. Please, let's understand that the reduction of dosage is also deep prescription. Stopping one of the medicines also deep prescription. So a lot of research is in fact happening in those areas, and maybe as time goes on, psychiatric illnesses also a lot of research might happen where maintenance. Another interesting point I saw in the chat box in the question section was somebody has mentioned a lot of people require small dosages of medicine. Is it okay? And those things, and excellent things can be done. In fact, one of my patients gave me this idea. We spoke about paroxetine and sexual dysfunction just a few minutes back in the previous session. I didn't think about it. My patient gave me this idea. This patient had sexual dysfunction because of paroxetine, but her anxiety was absolutely fine and she didn't want to stop the medicine. What she did was she herself did some Google search. She realized it's a shorter acting drug. She used to skip that when she knew that she might be sexually active on a particular day. She would take the medicine next day morning rather than take it in the night. She said that helped her. Now, please, let's understand that might have helped only one person, that might not be coming into any guidelines. But since they're dealing with real practical problems of day-to-day life, sometimes when we talk to our patients, tell them, see, we don't have clear-cut answers, you try these things, they understand they're dealing with human beings. Then they become very realistic in their expectations from us. Otherwise, they will obviously accuse us whenever there is a problem, they put us in trouble. So I think getting people to have conversations with us is a skill. So I think if we can do that more and more, I think we have done justice to our practice, and there be it, sir.
Any more questions, Suresh? Chat box?
No questions, sir. Very nice presentation, sir. Mohan Sunil. I think with this, handing over the mic to organizers for.
I thank the organizers for giving me this opportunity. So we will end up this session now.
Mohan, Sunil Kumar Gar, excellent presentation, sir. Your topic has been the long standing doubt of anybody who are here. You have made very clear. I think you have cleared all the doubts. Thank you for being with us as a speaker, sir. You delivered very nice lecture, sir. I thank Ramesh Babu Garu, the president of AP State Branch, and South Zone Secretary Suresh Garu. Thank you for conducting this session very nicely. Thank you, sir.
Thank you.
The mementos have been sent. Dr. Suresh Kumar, sir, your memento will be reaching in some time.
I received it 3 days ago. I thank all the organizers for sending me this memento. Thank you, Uday.
Thank you for the presentation, sir. We move on to the next session. Medico-legal litigations related to psychotropic medications. I invite our chairperson, Dr. Kariram Reddy, sir, and Dr. K. Narsimha Reddy, sir, and the speaker, Dr. Suresh Baramat, to preside over the session. A few words about Dr. Karirama Reddy, sir. He has completed his MBBS, MD, and PhD. In a nutshell, he is not only a psychiatrist, but a computer engineer, academic lawyer, management professional, a journalist, teacher, and an educationalist. He is director and consultant psychiatrist at Manasa Hospital in Raja Mahendravaram, and he is recipient of highest and most prestigious Dr. B.C. Roy National Award. He has entered into the Limca Book of Records 2009 edition for most varied educational degrees and has more than 50 awards or titles. He's also the recipient of Dr. DLN Murthy Rao Oration Award, and he's achieved Professor J.K. Trivedi Lifetime Achievement Award and Dr. Amit Bora Oration Award. He has worked as a past president of IPS South Zonal Branch, past editor of Indian Journal of Psychiatry, Medicine and AP Journal of Psychiatry Medicine, has more than 4,300 publications on health education and socio-political issues, and has treated more than 1,38,000 psychiatric patients. We welcome you, sir.
A brief on Dr. Narasimha Reddy, sir. He completed his education from MBBS and DPM from Andhra Medical College, Visakhapatnam, DNB from National Board of Exams, New Delhi, currently working as a professor and HOD of Psychiatry, MEMS, Vijayanagaram, retired as a professor of Psychiatry, Andhra Medical College and Superintendent, Government Hospital for Mental Care, Vizag. Sir has achievements of clinical experience in psychiatry, more than 36 years, recipient of Dr. D.S. Raju Memorial Oration Award of IPS AP State Branch 2016, has several publications in indexed journals, founder, secretary, president of Vishaka Psychiatric Society, vice president and president of IPS AP State Branch 2001-3, honorary treasurer, Behavioral Medicine Society of India, organizing secretary of IPS South Zone Midterm PGCME 2005, organizing chairman for AP Psychon 2010 and IP Psychon 2011. We welcome you for the session, sir. We hand over the sessions to the chairpersons. Thank you.
Good evening, all of you. Usually, the last session is kept for the star orator because he has to maintain the tempo of the session. Today's star orator is none but Suresh Badamat. His name contains Bada. He has got many Badas, like Bada qualifications. He is a doctorate in psychiatry, doctorate in law, doctorate in everything. And he is a professor of psychiatry, professor of law, professor of foreign psychiatry together, professor of telepsychiatry. He is a pioneer of telepsychiatry, and he is the advisor for the central government in framing the rules for Mental Health Care Act. And also, only one thing Chota is, his age is Chota. That is the only thing Chota what I feel. And the topic also is very important topic. After all, psychopharmacology is the bread and butter of all the psychiatrists. With the drugs only, we will be surviving. Daily we see hundreds of patients and we don't find time to talk to them even and feel like writing the drugs. But unfortunately, the situation is like that. Drugs will have not only the placebo effect, but also nocebo effect also. So many people would be there on prowl. Anti-psychiatry is going on in leaps and bounds. There are people like survivors of psychiatry. We are still surviving in spite of psychiatry, the people say. So they are all the potential litigants. And also many side effects we expect with many drugs. And unfortunately, how far we are responsible for that one? How to protect? And in the previous lesson, lecture itself, we found when to stop. Usually they dub it as not as withdrawal symptoms, but as dependence. And many people think that these are all sleeping pills only, and they many Google masters also are the problem creators. And negligence in the form of not just carelessness, but recklessness sometimes we find among ourselves. So many issues are there, and Dr. Suresh Badamat is the appropriate person to enlighten us. I request Dr. Suresh Badamat to say. Before that, my co-chairperson, Dr. Narasimha Reddy, very good administrator, very good experience. Meticulously, he drafts all the things, and he is the appropriate person to co-chair this session. Narasimha Reddy garu, kindly.
Sir, thank you, sir. Thank you very much, sir, for your kind words. As you said, I think Dr. Suresh Badamat session is going to be the highlight for today's CME program. I would like to introduce Dr. Suresh Badamat formally. At the outset, I would like to convey our sincere thanks to the organizing committee people for giving us this opportunity to chair this session. Dr. Suresh Badamat is the MD and DNB from NIMHANS Bangalore, and he has his qualifications in PG DMLA, that is a PG diploma in medical law and ethics, and he has also PG diploma in human rights law, and he did his PhD in law from National Law School, India University, Bangalore, and currently he is the professor and head of the forensic psychiatry of NIMHANS, and he is also the head of the telemedicine center and Unit 5 General Psychiatry of NIMHANS Bangalore, and he has a lot of awards for his credit, and he has received Professor Raghuram's Young Teacher Award and also the prestigious Dr. C.V. Raman's Young Scientist Award. And surprisingly, I think we all know about his performance in several scientific articles and all that. He had 287 published scientific articles in indexed journals, and he is also the editor of 7 books. And he is the visiting faculty for National Law School, India University, Bangalore, and Karnataka Judicial Academy. He is also a visiting faculty for that. And he is also the visiting faculty for State Human Rights Commission, Bangalore. And when it comes to the positions he held, he is a member of the committees constituted by the Minister of Health and Family Welfare, Nirman Bhavan, New Delhi. And he is also a member for the Central Rules Drafting Committee for Mental Health Care Act 2017. And he is also one of the members for the Task Force for Mental Health Care in Primary Health Centers. I think we all know about his contribution, especially during the COVID-19. He has done excellent job in releasing the telemedicine guidelines under the leadership of the then Director and Vice Chancellor of NIMHANS, Professor Dr. B.N. Gangadhar. And during COVID-19, we all know, COVID-19 pandemic, we all know the first lockdown was declared in India from 24th of March. And these people are very instrumental in bringing about telemedicine guidelines on the 25th of March itself. The very next day, they have released the telemedicine guidelines, I think, which has helped almost all the entire fraternity, and not only the psychiatry, but also the all medical fraternity. It helped us in managing the patients through online. And we all know about his YouTube presentations. I think several of his YouTube presentations were seen, and they are very much useful for the budding psychiatrists, especially the newly residents and the senior residents. And topics like clinical assessments in psychiatry, disorders of thought, disorders of speech, assessment of cognitive function in clinical setting, stigma, empathy in psychiatry, catatonia, counseling, legal issues in telemedicine practice, and Mental Health Care Act and resilience. These are some of the topics. I think he has covered too many topics. I too hear most of his topics just like a student. I'm very much thankful to Dr. Suresh Badamat for his excellence in presenting all these topics in the YouTubes, which are very much helpful for the psychiatrists, especially the younger generation. So with these remarks, I would like to hand over the mic to Dr. Suresh Badamat for his excellent presentation. Thank you. Thank you, one and all.
Thank you.
Thank you, sir. Thank you to the chairperson and also the co-chairperson. At the same time, I would like to thank the organizing committee for inviting me. One of the other important thing of this is I received my memento before this talk, and also it came 3 days earlier. Thank you very much for the organizing committee for making sure that it reached us before in hand. So Uday Kumar sir and his team is doing excellent job. Thank you very much for that. And before I start my presentation, I would like to have a disclaimer. This is for academic purpose only. And if you would like to have any legal opinion, please do contact a professional advocate. This presentation is for academic purpose only. So conflict of interest, none. With this, today you are expecting to have various legal answers, but I have more questions than the answer. but we need to join together to find certain answers. Those answers may not be black and white, they may be in the gray area. So need to find a reasonable answers. So that's what I'm going to do in the next 45 minutes. So if you look at the medications, especially in psychiatry, they fall into 5 categories. One is consent for treatment and capacity. That is basically how we took the capacity, how we took the consent, whether he had capacity or not. If he had capacity, we need to follow his will, that is his consent. If he doesn't have capacity and you have taken the consent, it becomes invalid. So it's a double-edged sword. At the same time, you're giving medication, but any time you admit him. So invariably, illegal detention and treatment. I'm sorry to say this word illegal detention. Many of my colleagues will feel offended, but in the legal arena, they call it as illegal detention, whether it is in the hospital, whether it is at home. If you detain somebody against their wish and will in a room, in a home also, it is considered as illegal detention. But however, we may call it as admission into the hospital. That is the first. Second one will be side effects related litigation. I'll be talking about a couple of cases with regard to that. And also off-label prescription is the third point. The last 2 points, that is prescribing the NDPS drug, especially with regard to teleprescription, and child and adolescent psychiatry, that is the 5th point, along with perinatal related litigations. The last 4th and 5th, the data is very less with regard to legal arena. That means the cases are less. I'll be taking individual questions because there is nothing called as black and white here in the 0.4 and 0.5. But however, the first 1, 2, 3 I'll be dealing. So NDPS drug and perinatal and child and adolescent psychiatry related litigations, there are very minimal. With this, I'll start with the consent for treatment, that is consent, capacity to consent. Actually, all of you know, it is the Section 4 of Mental Health Care Act talks about mental capacity or capacity to consent for treatment. By default, it says everybody has capacity. If they do not have capacity, that means the person who says they doesn't have capacity has to prove that he did not have comprehension, he did not understand the weighing of ability, weighing risk. The third one is communication. So that 3 points he did not have. Then only we'll say he doesn't have capacity. The burden lies on the person who says that he doesn't have capacity. With this, we will take one first case which has happened in Canada, and it was Starson versus Weiss in 2003. Actually, Starson is the name he has chosen in 1993. Actually, his original name is Scott Scudsman. He is a very brilliant chap, and he has done his engineering. He did his electronic engineering and was passionate about physics. He graduates in 1985. He starts having mental illness. That's basically he develops bipolar disorder. Before the bipolar disorder, he had published several articles in physics, collaborating in US with various universities. Imagine, he is a electronic engineer and also passionate about physics. He is highly brilliant chap. He is called as professor because of his intellect, not because of he has got a title because I'm just in Nimans, I got professor. It is not like that. He has got because he is doing very well in the intellect arena. So he got professor. His fellow colleagues used to call him as professor. So he develops bipolar disorder, and he has multiple episodes from 1985 till 98. He had 15 hospitalization. And every time he stops medicine, because he feels that medicines is stopping him thinking sharp, feeling what we call it as liberated. So in one of the relapse in 98, he stops medicine. He becomes severely ill. He starts threatening his colleagues, neighbors in his apartment. At the same time, he needs to be admitted for medication. But at what happens here, he is taken to the court because he has threatened neighbors and colleagues. So there, one is he's been taken to the police. Under police, a case has been pressed against him for threatening. Second one is, at the same time, they said that he needs to be treated. So what happens is, in the court, they say he's not guilty because of insanity in January 99. It happened in December 98, 24th. During that time, he was threatening everyone. He is admitted as per the court order, telling that he has to be admitted and treated. He was admitted in the well-known center at the Toronto CMH. that is Center for Addiction and Mental Health. There, the two psychiatrists will examine him, Swaz and Posner, telling that he needs to be treated against his wish and will because he doesn't have the capacity to decide for himself. He says, no, I don't want medication. He refuses to accept he has illness initially, and he says, I don't want medication. He gives all the long list of medications, side effects. He says, I would like to treat myself. I would like to do meditation, various things he says. So now the Dr. Swayze challenges his decision and takes him to the review board. Similar to our mental health review board, they have something called as consent capacity board. There in the consent and capacity board, the board decides the doctors are right, we will give permission to treat him. That is under Healthcare Consent Act of 1996, where it talks about only two criteria. It is comprehension criteria and appreciation of risk. Whether he is able to communicate or not is immaterial there. Only two criteria. In this, both the criteria, they felt he doesn't have the capacity, so we will give the permission to treat him against his wish and will. And they applied something called as best interest principle, and they give a permission to the psychiatrist to give treatment. But at the same time, this Healthcare Consent Act of 96 gives permission to the patient to appeal. So he appeals to the Ontario Superior Court. There, the Starson presents his case telling that, see, I am such a well-learned person. I have some problem regarding thinking, my attitude. That doesn't mean that they can give me drugs. He's able to argue. And there, the Judge Molly, the person who had made him to consider that his capacity he is not guilty because he's threatening, and she's a lady who had ordered him for admission. She says, yeah, he has capacity. How can you treat him? Because this is a fundamental liberty. If you look at US and Canada, the way they got freedom, it is based on the liberties. That is the reason the Statue of Liberty is there. And the way they got the freedom is, basically I'm talking about the history. They got based on the gun culture. That is the reason in US you will not be able to remove the gun, because they got freedom on the, what we call it as on the point of the gun point they got. That is the way it has been explained. That is the reason it is very difficult to remove the gun culture. But coming back to this case, the liberty is very essential here. They say you can't remove his liberty. He has all the right to refuse treatment. So the decision is given. Again, the Swayze doctor doesn't want to give up. He challenges again in the same Ontario court, telling that please review the decision. Again, the case is heard. And again, they say, no, he has capacity. We will not allow you to treat him against his wish and will. At the same time, since he is risky to the society, he is kept in the high security prison. Imagine, he is mentally ill, but he has capacity. He is threatening. He is inside the prison. So now the psychiatrists do not want to quit. CMH team goes to the Supreme Court. In the Supreme Court, again, the decision is taken, telling that he has capacity. We will not be able to give him treatment. He spends 7 years inside the prison, not coming out of it, just because he doesn't want to take medication. But if he goes outside, he is a risk to the society. Imagine, his mother comes out and said clearly, I am also one of the members who has to be taken into consideration for decision making. This is in Canada, where it is individual rights based country. She says, I am the sufferer also. She says, this law destroyed my son's life. This is an excellent example how our Mental Health Care Act Section 4 can be in future. We are going to say this, where the patient says, I don't have illness or I will not take medication. See, there is a conflict occurred in Canada between two groups. Psychiatrists and family associations on one side, telling that he should be treated. Consumers, that is patients, and the advocates, the lawyers on the other side. So both the parties were fighting. The sufferers were the family members. That's the amazing example which can be told. And also many publications have been made under this case. And subsequently, there were 4 cases, similar things has happened in Canada. But still, their constitution doesn't allow the liberty to be changed. And invariably, even recently also, there was a publication telling that this need to be changed because you can't just telling that he has a liberty to decide, but at the same time you are putting him inside a prison to curtail his liberty. We are giving him treatment so that his liberty is regained. We are not taking his liberty. That is the argument, and that is the way they have put across. If you look at this whole case, you will understand how we are going to be evolved. And you will see many cases like this in our own country over a period of time. Delusional disorder, he may be beating his wife, or maybe wife is harassing the husband or the other family members, but they have capacity. Substance use disorder, basically addiction. They are taking various drugs and they are stealing things from home and again beating parents for for money. Again, we will not be able to help them. Depression, they say, I'm depressed, but I don't want medicine. I would rather die. Personality disorder. See, in this whole case, if you look at the way the literature has evolved over a period of time, very clearly they said that absent insight. If I don't have insight, I will not, though I may comprehend the information, weighing risk will be a problem. Unless you are sitting in that position and deciding, then only it will be easy to decide. If you sit on the other side and say, no, I may not have illness, you are talking about somebody else, I don't have illness, I will not take medication. It is like this. That is the way it has been portrayed. So this capacity to consent is a big challenge which is going to happen, and it has slowly started evolving in our country. But anyhow, Mental Health Review Board has not been formed. Over a period of time, this will be a major problem because you need to take consent before admission, before giving treatment, and every week under Section 89, if you have admitted, you have to do the capacity assessment. And every 2 weeks, if you have admitted in Section 90. And if he is on prophylaxis, Dr. Mohan Sunil gave a beautiful description of whether the patient can stop the medicine. Yes, he has all the right to stop medication. If he has, even if he is on prophylaxis, he says, I don't want to take medication, we cannot force him. Neither the family members can do anything. That is the biggest problem. That is the reason there is something called a CTO, Community Treatment Order, which has been there in UK, in US, especially in various places. Kendra law is there. I will not go into that. If there are questions, I will take into those. So we may require community treatment order to facilitate family members in providing treatment. One example I can give you, which is happening in our hospital. A young boy was admitted around 10 years back for killing a 5-year-old child. Unfortunately, he had schizophrenia, and the police were unable to prove that he killed him. So he had to be acquitted, and the new demands also gave a certificate telling that he has mental illness. That was around 10 years back. Now, recently, he has been admitted again during the lockdown with the accused of killing his own mother. And imagine, he was admitted and discharged, never came back for follow-up and did not take treatment. Now again, should the CTO be given, or should he be kept in the prison or in a high security hospital? He has already killed 2 people. I don't know in the first case whether he had killed the child or not, but there was an accusation. He was accused. Now again, he is accused of killing his own mother. So in such a scenario, whether we should force medication, whether we give parenteral medication, is a big question we have to answer, but I don't have answer. That is the reason before I start my presentation, I told you that the discussion will be on how to generate the concurrence to go ahead further. These may be very less, but again, now we have to be very careful in such a scenario where we are going to do proxy consultation. Basically, in the absence of patient, you are talking to the family members. That is proxy consultation. It may be giving advice, no problem. But the issue comes is proxy prescription. In the absence of patient, you are giving prescription. Sir, this happens in every hospital. Even in Nimans, 30%, that was on Friday, I was in the OPD. If you look at 30% of our prescriptions are proxy prescription. That means the patient has not come, the family member has come, we have given the prescription. So this will be what we call it as a legal landmine, or what we call it as a landmine for blast that I can put across, because anytime the patient can say the doctor has given a prescription without examining me, that may be a big question. So that's again will be a problematic area with regard to proxy prescription. I don't have answer, but however, The telemedicine practice guideline has given some hints of authorization letter. Can we bring this here? At the same time, in Australia, they talk something about medication, filling of medication, they say. It can be given for 2 or 3 months where the patient has given the authorization there also. That's the issue. Next comes is supported admission and treatment. Invariably, there are cases slowly increasing where the patient is admitted against his involuntary. When he is admitted, he will be shouting or he may be screaming, and the medications are given. So both the things go hand in hand. So this is the first case which will be very, very what we call it as a constitutional violation or fundamental rights violation as per the Constitution of India, because right to life and liberty comes under Article 21, which go hand in hand. This is the first scenario which I wanted to discuss. So we need to watch about this, but I don't have any clear-cut answers. The time will tell, and we have to find answers over a period of time. And again, people have to approach the court the way Dr. Swayze from the Canada approached up to the Supreme Court. We need to approach. Coming to the second scenario, that is side effect related litigations. In this scenario, I'll be talking about a case scenario which has happened and the psychiatrist sought help from me. And this is a young girl, again aged 22-year-old. She was consulting psychiatrist. She consulted 3 psychiatrists. All the 3 psychiatrists are on OPD basis, having an illness from past 1 year with repeated thoughts and death wishes and depressive symptoms and also suicidal ideas. One of the psychiatrists says, you need to go to a bigger hospital, maybe Nimans. You have to go in treatment. But the family think, why should we go to Nimans? We will go to a private hospital. So they go to Bangalore, and in one of the well-known private hospital, they get admitted. And she has suicidal thoughts. So they followed the legislation and they admitted the lady in the private nursing home, and they offer ECT. They say, see, she has suicidal ideas. We need to give ECT. The family member refuses to give ECT. They refuse, telling that we don't want ECT. And then they start giving medication. The medications were basically valproate and risperidone, because they also made a diagnosis of bipolar disorder and OCD. And the family take discharge within a week. Against medical advice, they say, no, we want to go back home. There are some function at home. The team says, no, please don't go. But still they took discharge against medical advice, and they call them for follow-up after 15 days. Unfortunately, they don't turn up for follow-up after 15 days, but they come back after 1 month. Again, the query, the medication they have taken or not, we are not sure, but they say that they are taking medication. The follow-up is done. The patient is given a medication for 2 months and sent back. Once the patient goes back, 2 months down the later, she developed fever and also abdominal pain, and she is admitted in a medical college with a severe abdominal pain. But there was no improvement. They tried to do conservative management. They found there may be acute pancreatitis because she's on valproate. They suspected, but finally she was shifted to one of the corporate hospital. In the corporate hospital, they found she had a multi-organ failure, and over a period of 3 to 6 months, she developed chronic renal failure and she required dialysis almost daily basis. In such a scenario, now the family thinks it's because of psychiatric medication, especially valproate, that caused the problem. And they have now gone to the court asking for 10 crore compensation because she's a young girl. She needs to get married. Now both the kidneys have failed, and the psychiatrist is the one who has given the valproate medication, and because of valproate it caused acute pancreatitis, and before that hepatic failure. From their acute pancreatitis, from there it led to renal failure. So it's a beautiful discussion they have put across, and it has been gone. It's now in the consumer court, especially the central consumer. So we'll not discuss the particular case because it is sub judice, but however, I have changed a lot of information here. But this is the case which has been faced by one of our psychiatrists who is still fighting the case. So this is a case which very clearly talks about the informed consent and how often we are monitoring, documentation, and The issue is how to assess medical negligence. Whether our psychiatrist was negligent in giving valproate, whether it was in the adequate dosage, whether he took informed consent, whether he played reasonable degree of care, that is standard of care. In this regard, how do we do assess medical negligence? Again, medical negligence is based upon a simple test called as Bolam test. I have discussed this Bolam test many times. Because there are PGs, postgraduate students here, I will again explain about the Bolam test. See, first time in the history of medical negligence, forget about surgery, everything, with regard to medical negligence, in 1952, a young person called as Bolam. Now we will forget the old case. Now I am talking about Bolam's test. This is in UK. The Bolam is a young boy. He goes to veterinary hospital for treatment because he had depression. And he goes and gets admitted. And he has severe depression. The doctor, the psychiatrist there in the hospital, they say, you need to take ECT. They agree and they give ECT for this person. The first ECT, nothing happened. Second ECT, there was improvement in depression. Third, he improved in depression, but unfortunately, he developed acetabular fracture now. That is basically acetabulum fracture he had third. But he has improved now, but he is very angry. I went with depression. Now I got a discount fracture. He appeals to the court telling that the doctors are very negligent because I was not given muscle relaxant and anesthesia. Imagine this is in 1952-53. Around that's the time when anesthesia was evolving. Muscle relaxant were introduced. Now how do you decide? Imagine you are the judge. Go back. In 1952, you are sitting there and there is no case of medical negligence till date, either in the US or UK, anywhere in the world. Bolam test is the first test of professional negligence. That too from psychiatry it was introduced, not because of surgery or gynecology. The Bolam test is used across the world, across every fraternity. It came from psychiatry. That too because of electroconvulsive therapy. Now the judge, McNair, is the person who's sitting and he doesn't know what to do because there is no case laws available and there is no any legislation regarding medical negligence in 1952. And it was in the 57, he decided how to go about. For a moment, you think you are the judge and how do you would like to take a decision if it was in 1952? Of course, you will call for expert opinion. The same thing Judge McNair called for the experts. The experts had a different opinion now, two different opinions. One opinion said that we will give anesthesia, muscle relaxant, and we will restrain and we will warn. That is the first group. Second group said, sir, anesthesia at 1952, come on, it's very dangerous. At that time, the Boyle's machine was not there to that extent, and anesthesia was slowly as a different specialty was growing. It is dangerous to give anesthesia and giving muscle relaxant. It is high risky than giving anesthesia and ECT. So there were two divided opinion now. Again, judge is in complete unable to decide what to do now. Now the Judge McNair thought for some time and he clearly said, if a doctor is able to follow one of the guideline which is there. See, at that time, there were two groups of guidelines were there. Guideline means the standard of practice. That time, the guideline was not there. The standard of practice were two. One was with anesthesia and muscle relaxant. Another one was without. So, if the doctor is able to follow one of the procedure which is adopted at that time, the doctor is not responsible for medical negligence. This is the landmark judgment which has occurred in Bolam test. Now also it is used in Supreme Court of India and every court, even in the consumer court, Bolam test is used. It says, if a doctor reaches the standard of a responsible body of medical opinion, he is not negligent. In simple word, I can say is, if you are able to follow the guidelines which are there prevalent at that time, you will not be held responsible. And Jacob Matthew versus State of Punjab case, which is a criminal negligence, it has been used. Suresh Gupta versus Government of NCT Delhi, it has been used or has been quoted. So it has been accepted. So that we call it as a peer review test. The reason being is our own doctors sitting with us will decide whether the doctor is responsible or not. One example I will give you. because we are talking about psychiatric medications today. Imagine a patient with schizophrenia comes to me and he says, I'm very symptomatic and he's not improving. I decide to give 16 mg of risperidone. 16 mg. Now the question is whether Dr. Suresh is responsible, that he is medical negligent or not. Imagine he develops side effects. Now the question, whether he is negligent or not. Now they will ask Dr. Karim Reddy sir, what do you do? Karim Reddy sir will say, no, it is maximum is 6 to 8 mg. Under no circumstances we will give 16 mg. If he gives that opinion, gone. Dr. Suresh will be considered as medical negligent. And if he is given 2 to 3 mg, whether it will be considered as negligent? No. I have crossed the limit of what we call it as prescription. There the negligence is decided. And again, it has to be clearly documented telling that he has crossed the limit, that reasonable degree of practice has been violated. That means any person in Dr. Suresh's place would have not prescribed 16 mg. Any prudent doctor or a prudent psychiatrist will not prescribe 16 mg. That is the reason we should be very careful. But however, the Bolam test said, imagine if Dr. Karim Reddy sir said, no, Dr. Suresh is my friend. Why should I take against him? In some cases, we give 16 mg because he is working in demands. If there is no treatment available, he has all the liberty. He is a Apex Institute. They are trying because this 6 to 8 mg is the decision which has taken in the clinical trials. Some patient may require 16 mg. For example, in OCD, we give 80 mg and sometimes we give up 120 mg. Because of this peer review decision, the judiciary and the law, the basic advocate said, this peer review system is not acceptable to the society. The reason is the doctors are protecting themselves because Dr. Karim Ram Reddy said in the one of the decision, he clearly said, no, it is not applicable. It is definitely has violated. And if he slightly gives opinion, no, Dr. Suresh has also done law. I have also done law. He's a very good person. He's a very good speaker. He's an opinion maker. So he has done. So for that reason, they did not accept. And then the new law came in, something called as Bolito test. I'll be discussing about Bolito. So summarizing Bolam test, failure to match up with the required standard of care and peer review applied may not be considered as the standard of care. That was the case. So similarly, the Bolam test starts with B. There is something called as Bolito test. The Bolito test again, in UK it has happened. A young child, the child is 2 years old, called as Patrico Bolito. The child is admitted in one of the hospital in a pediatric ICU, that is Bartholomew's Hospital, under Dr. Horn and Dr. Rodriguez. And the child has severe upper respiratory tract infection, and every time the child coughs, it goes into breathlessness. Twice, the child goes into severe cough and breathlessness, and the ICU nurse calls the doctor who is on duty, that is basically Dr. Horn. And unfortunately, before the Dr. Horn came, the child recovered. But unfortunately, both the time the Dr. Horn did not come. He said, I am busy in the casualty, I'll come. And in the third time, the child went into a severe coughing and had a brain damage, and subsequently later the child died. Now, this case went to the court. Again, the same phenomena. See, that was in 1952. Now we are in 1996. In 96, again, the judge called the experts. The experts gave two opinions again. One group of said, sir, even if the doctor had come to the ICU, he would have done the symptomatic treatment. What is the symptomatic treatment? One group said, sir, we will intubate, or else we do tracheostomy. Again, that group said, if it is in spasm, you try to do tracheostomy or intubate, it will go into further and you are going to kill the child. That is one group. Another group said, sir, we will just give one oxygen and it will recover on its own and wait for it. The two groups, one group said symptomatic, another one is doing this intubation will be a risky procedure. Now, the court was again, I have to tell the doctor was not negligent or not, but here the court took a different opinion, telling that the doctor did not examine the patient, did not examine when the patient was in ICU. Forget about Bolam test later. it did not logically explain why the doctor did not come for treatment. That is basically for examining the child. So the court went against the doctors in this case and clearly explained Bolitho test is whatever the doctor's body or professional body or your clinical practice guideline is there, it has to be logically explainable to the court. That's where the first time the Bolitho test came in. That means Bolam test will be acceptable only if it is logically be explainable to the court. That means the court has to say, yes, the doctor has taken some decision, or else the court is logically able to explain why the decision was taken. So that is the satisfaction of the court is very essential. So Bolam test and Bolitho test. But Bolitho test is in a couple of cases has been taken, but Bolam test is the one which is widely accepted. So this is how the professional negligence has been assessed on both two tests. Because of these two tests, there have been a parameters has been set in. What is the parameter? Every doctor has a duty to care. That by care is reasonable degree of care, not very high. The way it has to be done at the Ames New Delhi, or else at the health and wellness center like sub-center you will provide care. It has to be standard, not very high, very low. So how do we assess that? It is basically assessed on an important parameter, 3 parameters. First, there should be a duty of care. That means there should be a contract between the doctor and the patient. That is, duty of care should exist. Second one is there should be a breach in the duty of care. That means there is omission or commission in the duty of care. And the third is because of the omission or commission in the duty, there should be a damage which is directly related to the breach of duty. Then only the compensation will be given. So let me tell you 3 points. One is duty of care should exist between the patient and the doctor. There should be a duty. Okay. That means he has accepted that I'm going to treat him. That is the duty of care. But he did not provide the reasonable degree of care. That means there is a breach in the duty. The third is because of the breach, there should be a damage. That damage is directly related to the breach. And it should be compensated. And it should not be remote. What is remote? I'll give one more example for remoteness that has been added recently. In one of the clinical trial in US, what happened was the patient was on a drug trial and he was on OPD basis, he was taking the treatment. Basically, he was one of the RCT trial. Once he goes outside on the road, he suddenly feels dizzy and falls down and a vehicle runs over him. He meets with the accident. Now his family member said, sir, because of the medicine he received, he felt dizzy and fell down, the vehicle ran over him. A. B, but the other group said, no sir, he was crossing over, the vehicle hit him. In this scenario, whether it was related to medication or not was a big question which arose. And later it was found he was in a placebo arm, not in the active arm. So there the issue comes is it has to be directly related to the medication, not remotely related to the medication. He would have slipped and fell down, unrelated to medication. So that direct damage and the breach of action should be clearly indicated. Then only the medical negligence will be given. See, it is easy to understand about the breach, the duty of care, and the remoteness or direct damage can be easily understood. The issue comes is duty of care. How do you assess duty of care is based on Bolam test and Bolitho test. Bolam test is basically, again, which I had explained clearly, duty of care should be if Dr. Suresh sitting in one of the district hospital, he gives a care for a depressed patient, should not be different from if Dr. Karim Reddy sir is there or Arvind Reddy sir is there, or it may be Uday Shankar sir is there. They should be same. Then only it is called a standard of care. No, sir, I want to give extraordinary care. I will give mega dosage. It will be considered as breach of duty. That means you did not follow the proper care. You are trying to do something which is not accepted by normal people. And again, the duty of care will be exercised by the hospital receipt, prescription, whatever you talk to the patient and say, yes, we will start treatment. That is a duty of care existed. But however, the duty of care of refusing treatment is not acceptable in emergency care. In emergency care, you have to accept and give treatment because right to life under that, the Supreme Court has very clearly said that the doctor loses the capacity to choose a patient in emergency. But in normal course of an OPD, you can say, I cannot see you because I am very busy and I'm seeing today 100 cases, 101 I'll not be able to see, you can refuse a patient. But in emergency, you cannot refuse. Coming to the breach of duty of care, that is again act of commission and act of omission. Act of commission is leaving the scissor in the abdomen. Act of omission is not doing a penicillin skin test, sensitivity test before giving penicillin. That is act of omission. So in both the cases, it will be considered as breach of duty because any other person will not do. That is reasonable, prudent doctor will not do. That is the way it will be considered as breach of duty. So the breach of duty should have resulted in pain. Again, there is a breach, but the breach should cause the damage. Imagine, I as a Dr. Suresh has made a diagnosis of schizophrenia and I've started risperidone. After 5 days or maybe 1 month down the line, he goes to another doctor and he says, maybe he has gone to Dr. Mohan Kumar Sunil, and then the Dr. Mohan Sunil Kumar said, how can it be schizophrenia? It is depression, clear-cut depression. Why did you take risperidone? And he stops risperidone and he will give fluoxetine or maybe escitalopram. Now the patient goes to the court and says, Dr. Suresh is negligent. The court will ask, okay, the Dr. Suresh is negligent, I agree, but he made a wrong diagnosis. What is the damage you have had? That is the question will be asked. If he is able to prove that there was a damage because of the wrong diagnosis, then only it will be considered as medical negligence. But however, the diagnosis, the wrong diagnosis will not be considered as a medical negligence, as been told in the Supreme Court in Kusum Sharma versus Batra case. That is clearly said, because error of diagnosis will not be considered as medical negligence. That has been told. So you have to have that reasonable degree of care, not very high, very low. That is, you have to understand. But however, there is something called as contributory negligence. So whenever you write a prescription, this is for all of my colleagues, you please document. If you are starting olanzapine, you would like to write avoid oily foods, daily exercise. The same thing has been done in the case which I had discussed. One of our psychiatrists, the young girl, they had written clearly to come for follow-up after 2 weeks, which they did not come. That means there is a contributory negligence from the patient side. They said, please do exercise. The patient was not doing exercise. He was almost lazy. That was again a contributory negligence. The patient was not active. The patient was also advised for yoga, which they did not do. They all come under the category of contributory negligence from the patient side. So please do document that. Even behind the prescription, many of our doctors are started writing, if there is any side effect, stop the medicine and contact the nearest registered medical practitioner or contact the psychiatrist immediately. That will help you. Even NIMANS, in the NIMANS prescription, they have clearly said, if there is a side effect, stop the medicine and contact the nearest medical practitioner. That is very essential. That has been done. So if possible, please do that. So you write what are the things psychosocially management you want to do, please write down that. That is very essential because that will decrease the amount of negligence on your side and the contributory negligence on the patient side increases. Because at the end of the day, civil case is based on how much evidence you are going to give. If the patient gives 51% evidence, you will lose the case. If your evidence is 51%, you will win the case. It is the probability of the evidence on that basis civil case is taken. But in criminal case, it is the beyond reasonable doubt you have to prove. Then only it will be, even if there is a doubt, that means it will be, the criminal case will be falling on its face. So in civil case, it will be amount of evidence you are given. So you have, if you are treating a schizophrenia patient, you do document stop alcohol, stop tobacco, stop cannabis use. And if you are giving lorazepam medication or diazepam medication to a alcohol dependent syndrome, first thing you should write is stop alcohol. Because if you are not written stop alcohol and you have started benzodiazepine, the patient goes and takes alcohol and benzodiazepine, the patient's family will say, you never told him to stop alcohol. So you have to be clearly written stop alcohol, start medication. And if possible, write, don't take both. That is alcohol and also our drugs. That may cause problem. So this will be very supportive to the doctor because these needs to be documented. In summary, I would like to discuss the second point. The practitioner must bring to his task a reasonable degree and knowledge. Not the court doesn't expect you to do the latest literature review and treat today's. No, the reasonable degree is required. Neither the very highest nor the lowest. The court doesn't expect you, if you have done MD psychiatry, it doesn't expect you to behave like a PhD doctor, or else the doctor who is sitting in Ames and Nimans. To that level care it doesn't. It expects you the way a person who has MD psychiatry sitting in a district hospital, how does he behave? That has to be clearly done. Now the third point I am talking about, off-label medication or mega doses or investigations required. This is the third point. This is the last point I'll be discussing. See, in many cases, especially in India, we have a lot of off-label medications. What will happen? Or else we do mega doses, which I already gave an example. What will happen? This is again Maharaja Agrasena Hospital versus Master Rishabh, which was recently decided. In this case, what happens is a young lady who is pregnant, 32 weeks of pregnancy, she is suddenly goes into labor, 32 weeks, and suddenly she reaches the gynecologist, Dr. Rama Sharma. Therein, Dr. Rama Sharma sees that the lady is under already in labor. They go ahead with the labor, and then she delivers a child which is 1.49 kgs. So the child had a difficulty in breathing after the birth. So immediately the Rama Sharma said, I don't have the child pediatric ICU, so you have to shift to another hospital. So immediately the child was shifted to another hospital where the pediatric ICU was there, and the child was taken care. Later, the child is been seen by the pediatrician, and later the lady is seen by the Dr. Rama Sharma. After 5 months or 6 months, they found that the mother says the child is not responding to the light stimuli. So she takes to another hospital called a Sharaf Charity Eye Hospital. There, the Sharaf Charity Eye Hospital said, see, your child is a premature child. Unfortunately, they should have done the retinal examination and they have failed. And now it is already stage 5, bilateral eye, and your child's chances of visibility is nil. Total retinal detachment has occurred. Now the lady becomes very unhappy and puts the case in the court. And she will request for the medical record. The medical record by the gynecologist, she refuses to give the medical record. She has to fight in Delhi Medical Council to get the record. After 6 months, she gets all the records and she goes to the consumer court. And in the consumer court, they found that there was no ROP done, that retinal examination was not done immediately after the birth. But however, the lady, the doctor at the Maharaja Agrasena Hospital, they have mentioned that retinal examination to be done. The lady says it has been introduced later, not now. So that has been discussed, but unfortunately, the guidelines which has been given by the Ministry of Health and Family Welfare was clearly mentioned that you do first month and then subsequently, if there is an absent retinopathy is there, you have to subsequently examine and see whether there is evolving is there. If you find that there is a retinopathy is occurring, do a laser treatment and you can prevent it. In this case, both the hospital lost and the mother won the case, and the National Committee had asked for 1,30,000. But however, the National Consumer Forum gave 64 lakhs, but she appealed to the Apex Court. Apex Court gave 76 lakhs as a compensation to the child and the mother. See here, the issue here is the following clinical guidelines is very essential. That means we may have clinical practice guidelines. Many a time we don't bother IPS has written, and many of us sitting in Nimans, we may criticize what nonsense they have done. They have just copy pasted American or maybe NHS guidelines. Invariably, whoever is drafting the CPG guidelines, they would have made certain tweaks considering the Indian scenario. I'll give an example. In epilepsy, if you look at the Western literature, there is no role for gardinal sodium and phenytoin. But in India, gardinal sodium and phenytoin are the first line of treatment, especially considering the economic condition of our patients, and it is available at the PHC. So those are all given there, and the clinical guidelines will be tweeted. If you look at chloropromazine, is not there in Western country, but still it is given here in under essential medicines, or maybe it will still be prescribed here. So there will be minor tweaking would have occurred in the CPG guidelines, considering the local requirements. And if NHS may say in OCD, the first line of treatment may be behavioral therapy. But here, if you look at the clinical practice guideline, OCD says we don't have so many clinical psychologists. The first line of treatment will be medication. So those minor tweakings will be done, which will be help you in the court of law. So whoever does the clinical practice guideline should keep this in mind, that we need to consider our local needs, cultures, and resources. On that basis, the clinical practice guidelines will be done. And whenever you go to the court, you have to produce clinical practice guidelines from India. Invariably, what happens is the opposition party or the prosecuting lawyer will produce a Western books. You have to say Western book is equal to Western law. Indian law or Indian clinical practice guidelines or Indian textbook talks about this. So we would like to produce this. So that will help you in the court of law. To summarize, please do follow the clinical practice guideline, and prescription need to have doctor's phone number in case of emergency. Please do document for regular follow-up. Put the date. Don't just come after 1 month. Put the date. If the patient comes 5 days later, it is the contributory negligence is there. Report back if there is any side effect. If possible, if you are thinking about the patient may attempt suicide, please do write about supervised medication. Talk about walking, regular exercise, diet, and if you require any medical opinion, please do. And if there are investigation which has to be done every 6 months, if there is a valproate you are giving, there should be a seal telling that every 6 months LFT, RFT, and hemogram to be done along with platelet count, which should be a norm. So, which are being mentioned in our clinical practice guideline, please do it. If you don't do it and something goes wrong, definitely they will say, see, your own Indian Psychiatric Society has produced the clinical practice guideline, you are not following it. That means it is produced by your own colleagues and you will not, nobody will be able to help you out. And the disclaimer down written like this is not a legally valid document is a big joke that will decrease the psychiatrist anxiety. But in the court of law, the court will decide which one to take it as a opinion or evidence. The court will decide. So mega dosage is not going to work. And the last case I will discuss about this Kunal Shah versus Balram Prasad, or what we can call it as Kunal Shah versus AMRI Hospital, which occurred one of the landmark judgment in 98. The husband and wife come to India, and the Dr. Kunal Shah himself is a pediatrician, and he's a doctor by himself. His wife is a child psychologist. They come to India to Calcutta, and in Calcutta suddenly she develops fever and then rashes all over body. She is taken to a doctor. The doctor will decide and say, we will start steroid. He will be giving dipomedrol, that is methylprednisolone 8 mg stat. And again, there is no improvement. They come after 2 days. Again, the dose has been increased twice a day for next 3 doses. Situation becomes very worsen. She is admitted to AMRI hospital on 11th May 98. And again, the doctors go on in administering steroids, that is prednisolone. She develops stents, that is toxic epidermal necrolysis. But the same time, Dr. Mukherjee had to leave to US because of certain program, that is conference. He has handed over to 2 other doctors called as Balram Haldar and Dr. Abhini Roy Chaudhary has been taking. But unfortunately, during this treatment, there was no supportive treatment was given. The patient started deteriorating. Finally, the husband decides to shift the lady to Bridge Candy Hospital in Mumbai. She was admitted there, but finally she dies. That is on 28 May 1998. Now the Kunal Shah goes to the court, and in the court of law, he was able to prove that the doctor had given this methylprednisolone, that is dipomedroxy is not given 80 mg twice a day. And he argues on that basis, and he is able to produce the literature of dipomedrol telling that it has to be given once a week, not twice a day. And it has given over 3 to 4 days, twice a day. And they completely reject the doctors, whoever was there. And they clearly said on first count that there was a negligence because the dosage was very high. Second, supportive treatment was not given. That was the second argument, and he wins the case, and he gets 6 crore as a compensation, which was later with interest becomes 12 crore. So we have published this. It is available on why this compensation is so high, should it be there or not, whether it will increase the litigation against the doctors, which has been discussed in one of the article in the Annals of Academy of Neurology. For the questions I will take about this. So please be very careful when you are, this is how the assessment is done about this. So finally, to summarize, how to reduce the potential liability. First and the foremost, if we are able to come up with a regular IPS informed consent forms, including with the digital consent forms, maybe something called as, suppose a doctor in Hyderabad or maybe a doctor in, this is again one of the case which has occurred in Maharashtra. A young doctor gave ECT, but the family said they have not taken consent. If we are able to come up with a video of 10 or 15 minutes, what is ECT, how the ECT is given, and how long it is given, how alternatively it is given, and what are the side effects. A 15 or 20 minutes video, which is in Hindi, English, translated by the local zone or maybe local IPS state, they come up with that, and it is a standard practice. And along with that video, one form which is there, which will be signed along with certain questions asked by the family members. And when this digital video was given to them to watch, either maybe in YouTube or anywhere, will help to say we have a standard format of giving information. How much information? Because invariably we have a doubt whether when the valproate was given, should I talk about hepatic, that is hepatic encephalopathy, or hepatitis, which is 1 in 30,000. Should I tell that or not? That is the question many a time we have a doubt. That can be decided by a IPS team along with the INI, that is Institute of National Importance, AIMS, PGI, and JIPMER. So you can say that we have collectively as a nation, along with the INI, Institute of National Importance, we have come to this conclusion, and we will give a standard disclosure format, which will be not only it is available to the doctor, it is available to the public, so that the litigation decreases. And one of the another important rescue clause is there in Mental Health Care Act of 2007 in 105. Whenever there is a diagnosis is challenged in the court of law, it has to be referred to the board. So you can say that invariably what happens is, if there is a diagnosis, if I say schizophrenia and other doctor says that it is bipolar, invariably it will be between two doctors fighting. But however, now MHCA is very clear, it has to go to the board will decide. At the same time, one important boon has been introduced in Mental Health Care Act of 2017, Section 116. Section 116 clearly says no civil court shall have a jurisdiction to entertain any cases, proceedings, which can be tried by the authority or the board. This includes even negligence. Now, if there is a consumer court, you can say under 116, this is a mentally ill patient, even deficiency of services is tried under Mental Health Care Act. So we can now argue instead of consumer court, but again, this is a gray area. I don't have the answer, but this is very clearly says no civil court have jurisdiction. So that is very beautifully has been written. And if even the patient wants to go to Medical Council of India, you can say, please first go, because many a time we have our own apprehension. In the consumer court, we don't have a psychiatrist. We have apprehension that if it goes to Medical Council of India or maybe in the NMC, National Medical Commission, there is no psychiatrist. But luckily now the registration board is headed by our own chairperson, that is Professor B.N. Gangadhar. So in such a scenario, you can say it has to go to the board, not to the consumer court. So no civil court, that means multiple cases cannot happen now under Mental Health Care Act. It has to go to the first board, and then the board will decide. So what are the other important things is you have to maintain open communication, documentation, follow the reasonable degree of standard of care, and also maintain competence in your specialty area. Ultimately, what is going to save you is documentation, nothing else. To conclude, my dear friends, the medical professionals are entitled to protection so long as they perform their duties with reasonable degree and skill. Otherwise, it will be you are going to get into trouble. And as sir has mentioned, I have a Suresh Badadmat, there is a YouTube channel where I'm releasing videos almost every week. So please do subscribe, and find any doubts, you can ask questions. Thank you very much for your patience listening. Over to the chairperson, sir.
Congratulations and thank you, Suresh Badamatji. You have done a nice job. Within the short time of 1 hour, you have given so many parallels to the practitioners, and your exposition of the subject is excellent. I think we are previously people were telling that we are swimming in the sea of carcinogens. Now I think that carcinogens can be removed and can put the potential litigations. I think we can put. We are swimming. Naturally, we have to protect ourselves. There is a question from Dr. Madhulata. Should we maintain consent forms even for prescribing medication? Should we maintain the documents when those are given for the outpatients?
Okay, sir. There are two questions are there, sir. For any normal, usual prescription, no need. But if you are changing or taking a high-risk procedure, worth maintaining the consent form. For example, usually it is given for disulfiram. You usually take the consent A. B, if you are doing clozapine, invariably we take consent. These are the two areas I will do. Even for ECT, I will take. Many a time, many doctors are telling that if you are giving injection or starting first time, please do take informed consent. That's what they say. It is worth taking it. Otherwise, not required for a simple risperidone, it is not required. Or a OPD procedure. Coming to the OPD procedure based, whether I should keep the documents or not. The Mental Health Care Act is very clear that you have to keep some basic medical record under section 23, if I remember, 23 or 25, sorry, 25. Section 25 clearly says that you have to keep a basic medical record. And what are those medical record? One is IP and also OP. We fought, actually, the IPS team, if I remember, Dr. Raju sir was there. We actually tried to fight and telling that OPD is given directly to the patient. Why should we take responsibility? But unfortunately, the rights group people were so strong. They said, we are all mentally ill patients. How can you expect us to keep? You have to keep. So invariably they won't. So OPD minimum basic record is there. That is almost like a registry what you keep, that you have to keep. And IP, there is a clear-cut form is there, Form B, if I remember, that you have to keep. So both OPD and inpatient, you have to keep the minimum basic medical record, and that is as per the law. But how many years is a big question. But as per MCI, for inpatient 3 years, but we don't have answer for the OPD, But however, we had suggested in the central mental health regulations, we tried to put in there for 3 to 5 years, but unfortunately it was not accepted. It has been told as per the MCI regulation. So now when the NMC regulation is going to be documented, which is now the discussion is occurring, Professor B.N. Gangadhar sir also knows that, and ethics regulation will be rewritten. During that time, we may come up with clearly mentioning how long the medical record has to be kept. So in there we may answer that. And sir, Professor B.N. Gangadhar sir is very serious about these medical records and all those things, and he's already started reading about various things, and the discussion is occurring now. So that will be answered, madam.
Thank you. Sir.
Thank you, Dr. Suresh Badamat sir. I think we had an excellent presentation from you. I think this medical negligence is...
Sir, Ramakrishna sir wants to answer a question, something he wants to tell. Sir, go ahead.
Sir, very good lecture, Dr. Suresh.
Thank you, sir.
Can we have the standard things of instruction, do exercise, keep diet, stop alcohol in a printed format and give it question?
I think that's one of the important things, sir. I would rather request print it behind the prescription. Many psychiatrists are doing it, telling that if there is a side effects, please stop medicine and contact the nearest person. Please do exercise. Please don't take oily foods, yoga. Those are the things which can be easily written, which can be documented, and it should be, if possible, in the patient's own language. Definitely, it will help you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir. I think we had a discussion about a very important topic. That's the medical legal litigations related to the psychotropic medications today. We all know, I think this medical negligence causes enormous damage to the patients. I think even WHO, somewhere in September 2019, has given a report. Nearly 2.6 million deaths occur because of the medical negligence. So that figure definitely exceeds even the deaths reported by road accidents or even by the seasonal deaths because of the infection rates and all that. So in general, most of us, we give medical prescription very easily without looking or without thinking much about the consequences which he has narrated so far. I think while giving prescription, we need to think. We need to think about the various aspects, and we should not cause harm to the patient in any way by way of ignorance or by way of even doing harm unknowingly or even a harm and not taking a diligent action that would have reduced the discomfort to the patient. So in all these aspects, I think the medical negligence comes into field. Of course, the medical malpractice is definitely something different. I think as far as medical negligence is concerned, I think we must have a definite concern about this type of litigations just before we give the prescription to any individuals. I think we see many patients, I think especially with psychiatric disorders, we give the prescription. The patient, maybe after 2-3 times, he comes regularly to us and subsequently he disappears. He doesn't come to us. We see the same patient after 6 or 7 years. I have seen so many patients like that, thinking the medicines which you have been repeating are working very well. So I need these medicines. That's why I have used these medicines for 6 or 7 years. When the relatives insist and they bother about it continuously using the medications by the patient, then he comes to us. My relatives are not agreeing. So let me stop these medicines. I tried to stop the medicine, but I am unable to stop the medicines. So like this, I think we have seen several patients coming to us after using the medicines for several years without consulting the psychiatrist. And we see some of the patients misusing the drugs, that's abusing the drugs, especially the psychiatric drugs like benzodiazepines especially. Very commonly, we come across the misuse of the drugs. In such cases, I think we should be very careful about giving instructions to the patients as well as the accompanying relatives. That's also very important, I believe. And I have seen some interesting cases like, for example, we give the prescription to some patient. If some of his relative develops the similar disorder, the patient himself gives him. The patient himself gives the relative, the similar symptoms I had it, the doctor has prescribed me the medicine. I had very good relief. You take it. You also take it. So this type of things also very commonly happen. In such cases, I think we need to tell the patient also not to misuse the drug by giving those medicines to anybody else. So, and the other important thing, I think we are all aware, I think some patients try to commit suicide by accumulating the drugs from several shops and try to commit suicide. This is also another problem which we come across. So naturally, when it goes to the police, they come to us, this is the prescription you have given. And he committed suicide by taking these drugs. How many drugs he has taken and how he collected and all those things, he is not bothered about it. So the prescription which he had with the patient, he looks into it and then comes to us and inquiring about this. So this type of things, very commonly we come across. So that's why, so documenting each and everything is very, very important in the prescription. Most of the times now we give the prescription to the patient. So as Sar has told, I think it's better always to keep the review date and certain instructions, as I have pointed out. What are they? For example, if an alcoholic comes, stop alcohol. So like this, I think such type of instructions will definitely help us in reducing our negligence on our part. And it goes to the contributor negligence of the patient. So he has given an excellent talk related to this. Thank you, Dr. Suresh Badamat, sir. Any other questions, sir, from the audience?
Actually, sir, I did not.
Question and answers. Yeah.
I did not touch upon the issues of there are many litigations because I was trying to do the literature review and looking into the database of various Supreme Courts of UK, US. There are many cases on the pharmaceutical companies actually on the Pfizer with regard to, there are the advocates are writing telling that if you have these problems, you get in touch with us, we will put a case. Like for example, on Zoloft, that is basically sertraline, and especially in elderly, restlessness, akathisia, and the person committed suicide. $3 million was given, dollars were given as a settlement. In various companies are there. So there is direct between the company and the patient parties, but not with the doctors. But anyhow, so those I have not touched upon, and also the perinatal area, giving medication and the child develops the congenital malformation. Those are the issues we should be careful. And if possible, if we are giving medication in child-bearing lady, we have to clearly mention, we have discussed about the issue of medication and pregnancy, and been clearly documented to use contraception. Those has to be documented. Otherwise, if something goes wrong, in UK, there is a case about Montgomery versus that. There is a case about shoulder dystocia where the doctor did not tell about the chances of having a problem. So there is there, but now in India it may come up because invariably we are very loyal to Britishers. We will copy those case laws to India. So we have to be, especially with the perinatal area. Currently there are none, but it may be taken up slowly over a period of time. Thank you, sir.
Thank you, Badamatji. Once again, thank you very much for.
Thank you, sir.
I thank the organizers for giving us this opportunity.
And
Thank
our
you, one and
session
all.
to organizers. Organizers, kindly take over. Organizers, thank you.
Usually mementos follows the session, but here I think we have received the mementos. Mementos preceded the session 3 days before. Thank you, one and all.
Suresh Badamat garu. Excellent presentation, sir. This is like in cricket, we have required 6 runs. It's like 6 balls, 6 sixes needed. So you have hit all the balls sixes.
Sir, you are the captain, sir. Yes. So captain, whenever he says to go and bat, we will go and bat. You are a Dhoni.
No, you are the captain of South Zone, sir. I remember still. Mahesh Gowda ಹೇಳ್ತಾ ಇದ್ರು ನಿಮ್ಮ ಬಗ್ಗೆ you are walking encyclopedia in legal psychiatry ಅಂತ, which has been proved now, sir. Excellent presentation. Thank you for being with us, sir, to deliver this guest lecture. I thank the legendaries in this legal psychiatry we have in AP State Branch, Kariram Reddy Garu and Narasimha Reddy Garu. They are both are in the pioneers in the legal psychiatry for chairing this session. Both of you, I thank you, sir, personally. I thank each one of you being with us today. Thank you, sir. With this, we have finished all scientific programs today. We'll jump into valedictory function of Midterm CME 2021. I request all the delegates who are into it, please log out to have the attendance certificate immediately after the valedictory function.
I request the dignitaries to join us. Dr. B. Ramesh Babu, sir, President of IPS AP State Branch. The guest of honor, Dr. Ramakrishna, sir, President, IPS South Zonal Branch. The Vice President, Dr. Y. Sanjay, sir. Dr. P. Lokeshwar Reddy, sir, Honorary Secretary. Dr. Sharat Chandra, sir, Honorary Treasurer. Dr. A. Vijay Chandra Reddy, sir, Honorary Editor. And I request Dr. T.P. Sudhakar, sir, the Organizing Chairman, and Dr. K. Uday Kumar, sir, the Organizing Secretary, to come on to the dais, please. Thank you. I will now hand over the proceedings to Dr. B. Ramesh Babu, sir, to preside over the function and give his remarks. Dr. Ramesh Babu, sir, kindly could you unmute?
Good evening, everybody. Today's chief guest, Dr. Ramakrishnan, sir.
Ramesh Balaji and Chakravarti, please be on the stage.
Yes, yes.
Two more people who are important.
Okay, sir.
Dr. Chakravarti, the chairman of Organizing Scientific Committee, please be on to the stage, sir. Dr. Ramesh Balaji. the joint secretary, the coordinator, the key person for the CME, Muralidhar and Gangadhar sir, please. Okay. We'll go on, sir. Ramesh Babu garu, please.
Good evening, everybody. Respected chief guest, Dr. Ramakrishnan sir, our beloved teacher, Organizing Chairman, Dr. T.P. Sudhakar sir, and our Organizing Secretary, Dr. Uday Kumar, and Dr. Ramesh Balaji, Dr. Chakravarti, and our office bearers, Dr. Lokeshwar Reddy, Dr. Sarath, and Dr. Vijay Chandra Reddy, and all the PG students, and Dr. Ranjit. I am extremely happy today for this excellent conference, meticulously planned one. All your efforts got good results. All the speakers and our chairpersons, everybody have done excellent job, wonderful job. Actually, this one day went on very quickly. Without our knowledge, we passed on this one day. So you have given us excellent academic feast. Thanks, Dr. Uday, and once again, thanks for all the Nellore Mind Club team. And I request now our organizing chairperson, Dr. T.P. Sudhakar sir, to give his comments.
At the outset, on behalf of the whole organizing committee, I thank the Ips Ap chapter represented by Dr. Ramesh Babu, the president, and other EC members who had given us this chance to carry out this small effort, because even though it's a very successful conference, I think personally that it is a very cohesive effort. So that's why probably it looks big, but it is still a AP midterm CME. And because of such a cohesive unit working behind it, we made it so successful. And once again, I thank on behalf of the organizing committee, all the members of the IPS executive. And I should thank actually some of the chairpersons who had been so fantastic in organizing the program to carry it along. And some of the very good speakers, especially I missed a few things. Maybe Dr. Suresh, you had done a wonderful job. Thank you, Dr. Suresh. I don't have much to say because I was only a figurehead. The whole credit should go to Dr. Uday Kumar, Dr. Chakravarti, Dr. Muralidhar, and Dr. Ramesh Balaji. Actually, in the morning itself, I told the meticulousness of Dr. Ramesh Balaji, the way in which Dr. Chakravarti had carried out the scientific proceedings. Maybe collectively we thought of who should speak in this particular CM and what should be the message we are going to give to the practitioners. It should be more practical to the people, and I hope we could live up to that level. And I'm very happy that most of the delegates are happy about the proceedings. With these few remarks, I think we should really appreciate Dr. Uday Kumar to take up such a big task during the difficult COVID times and carry it out so successfully.
May I request our chief guest, Dr. Ramakrishnan sir, to give his remarks. Sir, unmute, sir. Kindly unmute, sir.
Thank you so much for the AP State Branch for giving me this honor in this hereditary function. The whole 6 sessions were brilliant. That's what I simply say, brilliant. I didn't attend all the 6. I attended 3 totally. One, as usual, I am very fond of Dr. Suresh Badama's lectures. Wherever he speaks, I used to attend. And one more request from me to the audience, whoever it may be. you visit his site and get the knowledge whatever you want in his YouTube. That is worthwhile because, and especially for postgraduate students, visit his site because he is more into basics, even phenomenology, delusion, hallucination, he is describing. And many a time we may not find time to teach all these things, which he does very meticulously. That is one thing I want to emphasize here in this stage. And I also attended Dr. Prasad Rao session, very excellent. And that psychotropic medication for mood disorders. Suresh Kumar lecture, that was very nice, very excellent. And another one I attended fully was by Dr. Raju about sexual dysfunction and other aspects. So, does it look like a state CME? It looks like a maybe national or international CME. The standard is like that. That's what I'm honest. And it is up to the international standards. And another thing which I like in this conference is the maintain time. That is again very important. And I hope people will have enjoyed this session. When I talked to Dr. Uday Kumar, I was angry with him that he didn't send the uniform shirt to me. And he told he will send by post. I should not get it, I should get it somehow, isn't it? So, it is, see, Uday Kumar is writer sense, not to worry. Because you are kind enough to send me advanced, beautiful shawl and this memento and all. It is very nice. This is on my, I kept it in my table. So as a remembrance of Uday Kumar and AP State Branch. So I request to continue more and more like this CMEs, and you also participate in the Wiser CME, which we are organizing every third Saturday, which is picking up very well. All three CMEs so far we have conducted had more than 600, 700 visitors like that. This week it is getting postponed because of the national EC that is being held. It will be held on 27th. So okay, difference. And our Samanvi program, now Samanvi program is again catching up Andhra also. For that, I should be very happy that women empowerment is also going side by side. And I need not tell anything about TP Sudhakar, a man of conceptualization, organization skills, and getting people to work. That is again very important as a chairperson. So he has done that, and his pupils have done a wonderful job. Wonderful job, sir. It is not very easy. I know from my experience of organizing all this. So it is a wonderful effort from Uday Kumar team, and I thank all the officers of IPS State Branch, Dr. Raju Garu, everyone for cooperating in such a way that it has become what Dr. Sudhakar was telling. It is a small one, because of its cohesiveness, it has become big. Yeah, we should stand united in all our efforts, and we should make it big. And I request the organizing people to send me the video of these proceedings, and we will post in the IPS website also. Thank you very much for giving me this opportunity.
Thank you, sir. Thank you, sir.
Vandanam.
Thank you, sir. Thank you. Yesterday we had conducted PG quiz. Now PG quiz winners results will be announced by Dr. Ranjit. Dr. Ranjit, can you declare the results now?
Dr. Ranjit Kumar is the associate professor who is working in Narayana Medical College, who has done this.
I would like to thank the organizing secretary, Dr. Uday Kumar sir, and the organizing chairperson of the TP Sudhakar sir for giving me this opportunity to conduct the quiz. And I would also like to thank all the participants for being with me so patiently. The quiz ran like a marathon. It was almost for 3 hours, and I thank the postgraduates for staying for so long with us. I would also like to thank Dr. Lokeshwar Reddy sir for coming a day early and helping me out with the technicalities. I would also like to thank Dr. Ramesh Balaji sir for being throughout the session with me. And the first place went to Katuri Medical College team. It was Dr. Sakha Meghana and Dr. Syed Zainab. The second place went to Narayana Medical College and Hospital Nellore team. The winners are Dr. Tahir Bhasha Mahalati and Dr. Nandita, who are here. And the third place went to PES Institute of Medical Sciences, Kuppam. The winners are Dr. Chaitanya Vardhan Reddy and Dr. Puneet Nath Reddy. Thank you. I invite Dr. Tahir Bhasha and Dr. Nandita to come on to the dais and take your certificates.
My heartfelt congratulations to winners.
With your permission, Dr. Ramesh Babu, I will be handing over the certificates to the winners.
Yes, sir. Yes, sir. I wish the winners very bright future. Thank you, Dr. Ranjit, for cooperating with us for conducting this UG quiz, PG quiz, along with our Dr. Lokeshwar Reddy.
Ranjit should get a token of appreciation for conducting PG quiz.
Yes, yes, yes. Thank you, Ranjit.
He's the quiz master.
I request our senior members to give feedback. Our senior members, Dr. Nagareddy, you can say a few words.
It was an excellent conference. Uday, invisunda? Hello. Uday. Invisilla on this,
It's audible. It's audible.
Audible, sir.
Audible was very much audible.
చాలా బాగుంది. ఇన్ ప్రెజెన్స్ గా మేము నేను రమేష్ బాబు సార్ హెల్త్ రీజన్స్ వల్ల అటెండ్ కాలేకపోయాము. లేకపోతే వండర్ఫుల్ కాన్ఫరెన్స్ సిన్స్ మార్నింగ్ ప్రసాద్ రావు గారి నుంచి స్టార్ట్ చేస్తే ఎవ్రీ టాపిక్ అన్ని ఫాలో అయ్యాం. రోజంతా చాలా బాగుంది. వెరీ నైస్ లా ఆర్గనైజ్డ్. మన రామకృష్ణ సార్ చెప్పినట్టు ఇట్ ఈస్ ద స్టాండర్డ్స్ అనే నిజంగా కూడా అది మనకి నేషనల్ ఇంటర్నేషనల్ లెవెల్స్ ఉన్నాయి. టాపిక్స్ ఆల్సో వెరీ ఇంపార్టెంట్. వెరీ మాకు బాగా అటెండెన్స్ కూడా బాగుంది. ఇట్ వాస్ వెరీ నైస్. నైస్లీ ఆర్గనైజ్డ్ కాన్ఫరెన్స్ ఉదయ్. నువ్వే చేయగలవు ఇట్టటి. You can only do such kind of new things. Shirts also very nice. Send us also one shirt if possible. Thank you very much.
All delegates should be given shirts.
Yes, sir. We demand it.
Yes, appreciate it.
Thank you, Nagareddy. I'll be sending you 2 shirts.
If I'm permitted to say a few words.
Sir. Please, you're welcome, sir. Welcome, sir.
This is a very productive Sunday, I must say. There are rarely a meeting in which I'm a speaker. I listen to all the speakers. This is one meeting from the inauguration time, from what Sudhakar's talked to everybody's, and then when it came to Prasad Rao and then Dr. Verghese, and then three speakers, lovely speakers in the afternoon, Dr. Suresh Badamat, Dr. Sunil, and then, like we had Dr. Raju himself, the national president. This is like a student. I was sitting through this meeting, and I think it's a phenomenal meeting. I will echo the sentiments of Dr. Nagi Reddy and other people to say that it was to a great standard, and it was from the very beginning to the end, it was a learning experience. I certainly want to thank the team, Dr. Sudhakar and Uday and Ramesh Balaji for pulling this through and making it possible. Thank you so much. It's an extremely productive, nice meeting. I would cherish it in my memory. Thank you.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Any others? Any other members? May I request?
Bhagyarav Garu and Kariramareddy.
Sir, Dr. Kariramareddy, sir. Kariramareddy Garu.
Really, it is an excellent CME which I have attended. During this 40 or 50 years of my medical education and training, this is one of the best conferences or CME programs I have attended. We call Corona as Asura, but Corona is really Devata. Corona Daiva is responsible for this type of thing. Otherwise, we wouldn't have attended so many lectures or so many conferences. Because of this one only, we could attend. And really excellent selection of the topics and also appropriate excellent selection of the speakers. We can't find such a selection any time. Sometimes quid pro quo occurs, and because of that one, so many not so palatable lectures and all we find. But here all the lectures are so excellent that, as Suresh sir was telling, like a student only one would sit. And another thing is, because it is recorded in YouTube, those who miss also, they can go through that one and they will have the permanent thing with them, and also they can refer also. And really I congratulate Nellore Mind Club, and I appreciate everything.
Thank you, sir. Thank you.
Thank you, sir, for your blessing message. Thank you, sir.
Sir, can I speak, sir?
Yes, you can tell. Kishore, you can.
Sir, Kishore.
I can tell.
Good, sir. Sir, good evening, everyone. Really, I congratulate Ips Ap chapter, which is being presented by Dr. Ramesh Babu Garu. It's a very wonderful CME. I have experience of 2 CMEs conducted under the Ips Ap chapter. I know how the Dr. Ramesh Babu Garu and Dr. Lokesh Reddy Garu helps in conducting the CME. They frequently helped me a lot, the CME. Though I think the same way it has been the CME being conducted by the Ips Ap CME, IP AP chapter. I congratulate Dr. Ips Sudhakar Garu and Dr. Uday Kumar Garu, Ramesh Balaji sir, and other all Nellore Mind Club people. It's a wonderful CME. All the topics are very nicely chosen, which are very important for practical aspects. So I'm going to implement, and I'm being learning from this CME. I'm going to practice in my clinic. I thank Nellore Mind Club for conducting such a wonderful CME. Thank you, everyone, and thank you for giving this opportunity.
Thank you, Kishore. Thank you.
Thank you, Kishore.
And Dr. Bhagyarav, sir. Dr. Bhagyarav Garu.
Yes. Really excellent CME. I think I can rate that one of the best CMEs I have attended. Very nicely conducted, very meticulously planned. All topics are selected and proper speakers are selected. Such a nice CME. I think whom I should give the credit, but probably to the entire team. Dr. Sudhakar and all the team. Uday Kumar. Everybody has a different role. One plans, one executes, one does the physical work, one conducts the social connections. But meticulously conducted CME, and with the best output and best consumer satisfaction. I think Nellore Mind Club is mind blowing. Such a nice CME.
Thank you, sir. Thank you. Dr. Narasimha Reddy garu. Dr. Narasimha Reddy garu.
Thank you, sir. Thank you, Dr. Ramesh Babu garu, for giving me this opportunity. My hearty congratulations to the organizing team headed by Dr. T.P. Sudhakar, Dr. Uday Kumar, and also the other members like Dr. Ramesh Balaji and all that. I think it's as everybody, as pointed out by Dr. Ramareddy garu, Dr. Suresh Kumar garu, Dr. Bhagyara garu, I think it's a very meticulous planning and a wonderful organization. There is no doubt about it. Of course, the only one thing I think the people who attended the online, I think they are missing the Nellore Pulsu, Nellore Chapel Pulsu. I think it's a very, very good organization. I think this is what exactly the CME for the practitioners. I think the practical problems that we come across during our day-to-day clinical practice are being dealt with by almost all the speakers, and it was done in a very excellent way. I think hearty congratulations to the organizing team and all the participants. Thank you one and all.
Thank you, sir, for your compliments.
PGs.
People, I request PG students to give your feedback. PG students. Kishore, any of your yes. Please welcome.
Good evening all. Myself Dr. Sindhuja from Shantiram Medical College, Nandyal.
Please go on. It is audible.
I would like to take this opportunity to thank behalf of Department of Psychiatry from Shantiram Medical College. I thank all the eminent speakers who have enlightened us about different aspects related to psychiatry and psychology. And the last two sessions particularly, which have detailed on art of weaning psychotropic medication, medical legal litigations related to psychotropic medications. These two sessions particularly are very informative and are really useful to the future psychiatry practice and also to the budding doctors. And I would like to thank the organizers of this midterm CME for choosing a very good theme, that is red flags in psychopharmacology. And the quiz which was conducted.
Please unmute. It's not audible. You are not audible. Unmute cheyandi. Hello.
And the quiz which was conducted yesterday. Really outstanding, holding the questions, covering all the aspects related to clinical psychiatry and neurology. And after a long time, we have got exposed to different specialities of psychiatry through this quiz. And I thank for giving me this opportunity to give my feedback to all the organizers of this. Thank you.
Thank you, Sindhuja. Thank you. Any other PGs? Any other PGs from Carter Medical College? From Narayana Medical College? Sir, Narasimha Reddy, sir. I can tell, sir.
Sir, with the permission of the chair, I would like to make an announcement regarding the ANSIPS 2022.
Okay, sir. Okay, sir.
Yeah, the ANSIPS 2022 at Visakhapatnam, the dates have been finalized. They are from January 20th to January 23rd. 20th, 21st, 22nd, and 23rd. Thursday, Friday, Saturday, and Sunday. The dates have been finalized, and they are going to get the digital first brochure in a day or two, and the printed brochure, the hard copy, you will receive within a week. The hard copy is already under printing. I take this platform as an advantage to invite all of you to please attend the ANSIPS 2022 that's going to be held at Visakhapatnam in January 2022. Thank you one and all. Thank you, sir, for giving me this opportunity.
Thank you, sir. Thank you. All of us will become members, sir. Soon we will become delegates of that handship, sir.
Thank you, sir. Thank you.
Any PG from Nellore Medical College? Category? Okay. Can I ask Dr. Uday Kumar?
Tejasvi, we have some PGs here, sir. PGs? Come on.
I'd like to thank everyone for this informative CME which was conducted, covering all the topics, and it was very informative, and thank you, sir.
Thank you, Miss. Thank you. Anybody else?
Dr. Ramesh Balaji is here, sir. Chakravarti is also there.
Chakravarti. Ramesh Balaji, you can say a few words.
Yes. Yeah, very much needed, sir.
Just a few words, Balaji. Only a few words. Ramesh Balaji.
సార్ చేతలు మాత్రమే మనం పని చేయమంటే ఎంతమంది చేస్తాను కానీ మాటలు మాత్రం ఐ కాంట్ స్పీక్. ఐఎమ్ వెరీ మచ్ అఫ్రైడ్ ఆఫ్ దిస్ మైక్ అండ్ కెమెరాస్. సో థ్యాంక్ యూ సార్.
He's a good worker behind the screen.
We thank you a lot for your meticulous planning, for doing everything behind the screen. Thanks a lot, boss. Thank you. Chakravarti, I didn't listen to your voice at all.
Sir, we are from the organizing committee, sir. We should not talk about this. We should not talk about ourselves. But overall, we are very satisfied that the program went well. Thank you.
Thank you, Chakravarti. Thank you, Chakravarti. I asked Dr. Uday Kumar to give vote of thanks.
Thank you, Ramesh Babu garu. To my belief, anybody who is going to work needs very good associations. To this event, I'm very lucky, very glad, very happy that we have a wonderful EC members of AP State Branch. I'm very lucky, especially Ramesh Babu garu, the President, Dr. Lokesh Reddy, the Secretary, very dynamic, continuously the day one, when we have opted this program during one of those EC meetings, they were just nodding their head and then continuously made us to do this program excellently. For everything they are with us. Tomorrow we want to do something. One day before only they would have told us to do this. By 7 a.m. they used to call us, boss, have you done this? That's a kind of motivation. They have done it, and then really they are the real heroes behind of us to make this event done. I thank Ramesh Babu garu, Dr. Sanjay garu. With his wisdom and friendly talk, he used to tell us, Uday, chespadastaleva. That's a kind of encouragement he used to give us, Dr. Sanjay. And all of the EC members, again and again, I'm telling all these other states also, you need this kind of EC members to have any programs done in successful way. All the information fed into Dr. T.B. Sudhakar sir. The moment we said, let's do it, why not? We've been doing it, let's do it. Even though it is a webinar, I'll be with you, don't worry, go on. From that word to action, he's with us till this last minute of ours. He's still sitting here and guided in many of those events, like talking about the scientific program with Chakravarti and selection of speakers and then chairpersons. Even for every moment of this event, he is with us. I am really blessed of he being with us.
నిజంగా చెప్పాలంటే నాదేంలా ఇంగువ కట్టిన గుడ్డలాగా ఆయన ఇంగువ ఆయన నన్ను కట్టాడు కాబట్టి నాకు వాసన వస్తుంది. సో ది క్రెడిట్ గోస్ టు హిమ్ ఓన్లీ.
సార్, మహాభారతంలో కృష్ణుడు యుద్ధం చేయలేదు సార్, ఊరికి కూర్చోను నిలబడి ఉన్నాడు. కానీ థింగ్స్ హ్యాపెన్ పాజిటివ్లీ కదా. సో విత్ యువర్ ప్రెజెన్స్ we really feel energetic and then do the justice towards any kind of program, sir. We are really blessed of you being with us today.
నేనేం చేయలేదు ఉదయ్ కుమార్, 2 సార్లు ఫోన్ చేస్తాను అంతే, మీకు త్వరగా చేయండి అంతే. నేనేం చేయలేదు. నేను కూడా
లేదు సార్, మీరంటే మాకు భలే భయం సార్, భలే భయం. ఎక్కడ రమేష్ బాబు ఫోన్ చేసేస్తాడో అని కూడా భయపడుతూనే ఉన్నవాడు. ఆ భయం కూడా మోటివేషనే.
థ్యాంక్ యూ.
For any kind of scientific event, definitely we all require the best speakers out of best speakers. I am very fortunate to have these very nice speakers. I think there are few of them are there still in the valedictory function. I am Suresh Kumar garu, Mohan Sunil Kumar garu, and Suresh Badamat garu. They are all still there. And then Varghese Punos, Prasad Rao garu. All of them delivered. I think all of you agree that they have spelled the wonderful spellbound, lucid deliberations. Do you all agree, sir?
Yes, exactly. Yes, definitely.
From bottom of my heart, yes. I congratulate, thank each one of all the speakers for being with us and given the deliberations, sir. Just with WhatsApp message, sir, they could accept all the lectures and then given deliberations. Definitely, we in the Mind Club owe you a lot, sir. I'm really blessed of you all being with us today to have best deliberations. And we have around 370 delegates. I really appreciate all of them logged out. Now, I think after the valedictory function, throughout the program, they are all with us, all the delegates with us. And to conduct all the sessions, we have wonderful chairpersons. All of them are legendaries. All of them are well suited towards the topics. That's how we have managed to fit them in. And then they have really done the justice, or technologically wise, and then they have proved that they are the best chairpersons to conduct this program. I really blessed all chairpersons being with us today to have this wonderful event, sir. Chairpersons Kariram Reddy garu is still here, and Narasimha Reddy garu is still here, and then others. To carry on, for Taj Mahal kuda కూలీలు అవసరం. మా కూలీలందరూ కూడా డాక్టర్ రమేష్ బాలాజీ పెద్ద కూలీ. అవును సార్, ఎవరు కూడా నాపై ఆలోచించలేదు, వాళ్ళకి చొక్కాలు మాత్రం ఇచ్చాను నేను. చక్రవర్తి రమేష్ బాలాజీ గారి గురించి చెప్పాలంటే, ఆయన నేషనల్ ఈవెంట్ కూడా చేసి పడేస్తారు సార్, ఉత్త చేతులతోనే.
ఖచ్చితంగా చేస్తారు అతను.
నిజంగా తక్కువ చెప్తున్నానేమో నేను. వండర్ఫుల్ పిన్ టు పిల్లర్ ఆఫ్ దిస్ ఈవెంట్. హీఈస్ ది పర్సన్ హూ హెస్ డన్ ఇట్. ఆయనకి దండాలయ్యా, నమస్కారాలు కాదు దండాలు. చక్రవర్తి సార్, లాస్ట్ year we had done South Zone midterm CME for practitioners. Chakravarti was the scientific organizing committee chairman, sir. He was the person who had chalked out the whole scientific program, which was approved, accepted by the Mahesh Gowda, who was the one that time the scientific chairman of South Zone. We got really wondered, and this time also Chakravarti is the key person to chalk out all the scientific events, scientific program. Chakravarti garu, please, token of appreciation is really needed to you, sir.
Again, on behalf of Dr. Ramesh Babu, I am handing over a small memento to him.
Sir, ఖచ్చితంగా సార్.
డాక్టర్ టిపి సుధాకర్ గారికి 84 మంది స్టూడెంట్స్ ఉన్నారండి. ఆయనలో ప్రథముడు చక్రవర్తి గారు, రమేష్ బాబు గారు ప్రథముడు, ఫస్ట్ స్టూడెంట్ when he was the professor joined in తిరుపతి. నేను ఆయన శిష్యుణ్ణి కాదు, ఏకలవ శిష్యుణ్ణి. నన్ను బొటను వెళ్ళి అడగరేమో అనిపిస్తుంది, అడుగుతారేమో భయం కూడా ఉంది.
I'm extremely happy to say that I was first batch student to Dr. T.P. Sudhakar sir. I joined in SVMC Tirupati in the year 1986. I was first batch student in SV University and last also SV University. After that, PG course has gone to NTR Health University.
Dr. Ranjit Kumar, lot of appreciation from the organizing committee for being done the physics quiz and made your students to win second prize also. I don't think there is a scam. Wonderful, sir.
Ranjit is a very silent person. Ranjit is very silent and dynamic.
Very silent, dynamic.
He was in our Karnal Mind Club. He was doing a lot of things. Silently, he will do everything. Very efficiently, he will do. Ranjit.
Yes. That has been proved here also, sir. Ranjit is one of the best ones here. Dr. Subhani Garu, another silent person. From cell phone to computer works, all the digital works of this event. Please come on to the stage, sir, to take the token of appreciation from organizing committee.
Thank you, Subhani. All the best. I saw you once in Nellore when I was there for conference. Subhani, yes.
Dr. Subhani is the assistant professor in Nellore Government Medical College.
Okay.
AC Subbareddy Medical College. Thank you, Subhani garu, please. Yeah. Narayana PGs. Manaswini, Sweta Krishnaja. Sir, have you liked them, sir? Best anchoring, best presence, very wisely anchored and conducted these scientific sessions. Manaswini, yes, President Garg chupinchu. Ramesh Babu. Manaswini.
I wish you all the best.
All the best for gold medal, sir.
Yes.
Sweta Krishna, sir.
Thanks, I wish you all the best.
Krishnaja. Thank you, Ma Krishnaja.
I wish you all the best.
Yogita staff. Rajaswini and Shravani, please come on to the stairs. Very soon we'll be finishing, sir, please.
Okay. Thank you, all the best.
I request all the pharmaceutical companies who have helped us. We were not having even 1 rupee, sir. During that time, we were literally struggling for funds. We were asking Dr. Gangadhar Garu to donate some money. Dr. Chakravarti also was asked to donate some money. During that time, we had a lot of troubles. We had asked T.P. Sudhakar sir also, sir, we are not going to change any. Car go to left, sir. So he literally accepted. Yes, I'll do that. The first and foremost company, Sun Pharmaceutical Company, they are the persons who have taken up the scientific program and then transported all the office bearers. All Sun Pharma, sir. Sun Pharma. Anybody there from Ramakant?
But they have done excellent job. Sun Pharma people, they are in touch with me for last 1 month.
Webinar kind of things.
Yes,
It's
yes.
definitely
Since 1 month,
well,
they are in touch with me.
audio visuals.
They are giving me all the feedback of these activities. Sun Pharma people.
Indoors people. Yeah. Mahesh, sir, Indoors. రమేష్ గారు పక్కన ఉండండి. Torrent Ramesh. They're left. Crescent Pharma, Pushparaj, Chaitanya, Sharma, Chaitanya. Lera, Pushparaj, then please come. Please come. Photo. Yeah. Thank you, Chaitanya. Alchem. Suraksha Sudhakar. Alchem, thank you. Suraksha Sudhakar. Anybody from Psychoremedies? ARC Babu. Anybody from Minerva Grant, please? Yeah, manage. Thank you for giving us very congenial place to conduct this event. Thank you, Grand Minerva.
I think we are getting too much prolonged on this valedictory. And,
we'll go for next.
There is nothing much to say. And we have to thank you all people for being so patient even during the valedictory. And on behalf of again the organizing committee, I thank one and all.
Thank you, sir. Thank you, Uday. We'll go for national anthem.
Yeah, we'll raise for national anthem.
पंजाब सिंध गुजरात मराठा द्राविड उत्तर बंगा विंध्य हिमाचल यमुना गंगा उच्चल जगति तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे